It is the time now. 3 minutes to start. أنا حبدأ. أيوة إن شاء الله. يلا يا أمل to start. داهم شوية. Gonna start. Hello. Hello. Shall we start, Amal? Okay. It's okay. And I was able to reach with the
السبيكر لازم يكون فانكشن صوت مطلع واللي اونلاين يحضر شغال. اوكي مش هيك ما راح يبينه. كل واحد 25 minutes 5 دقائق اذا حدا بده اي بس او اي شيء. اذا لازم نخلص سكر اللابتوب هي هذا الباسورد هون. اذا نسلم اي سيرتيفيكت حنوقف من هون.
Okay.
عرفتي او اذا حدا
يعني تقصد speaker should be here only.
should not go لانه ما راح يبين عم يشوفونا اونلاين. بعد ما يخلص كل سبيكر ممكن تعطيهم السيرتيفيكت تبعهم الكينوت سبيكر
One by one.
افضل. لانه لو اجوا من هون ما راح يبين البرزنتيشن. طيب خليني انا اسوي هذا الشيء. تمام. طيب هلا اول حاجه شيء ما حضر شيء لا لا دكتور نور الدكتور لسه ما وصل عبير موجود روبرت موجود أنا أنا قلت خلاص أنا على شيء مشكلة
Hello. Hello. شغال. And I'm still coming in. So we'll start. Hello. Is it clear for everyone? This mic. Hello. Okay. A very good morning to all. Good morning and welcome to the 12th International Nursing, Healthcare and Patient Safety Conference. As the chairperson. Okay. Chairperson, it is my privilege to stand before you today and open this extraordinary gathering of nursing and healthcare professionals. We are here to celebrate our remarkable achievements, share knowledge, and explore the endless possibilities that lie ahead in the field of nursing. I am Dr. Sahar Abbas. Originally, I'm from Sudan. I graduated from the University of Medical Science and Technology. And since after, I'm working as an emergency physician. I worked in a well-established governmental and private hospitals. I worked in Saudi Arabia in King Abdulaziz Hospital in the ICU department. Then after that, I relocated to UAE. I worked at the time of COVID outbreak in Al-Rahba Hospital in the HDU department. Then after that, I joined Midi-Clinic Group in An-Nur Hospital in the department of the ICU. And now I'm working for the Capital Health Group in the Specialized Rehabilitation Hospital in Abu Dhabi in the Post-Acute Rehabilitation Department. As well, I'm working as a clinical educator for the American Heart Association courses. And now I'm doing my master degree in in education from Warwick University, UK, as well as infectious disease from the Royal College of Physicians, Ireland. Okay. Now, I'll give you a few ideas about the UCD conferences. Meetings, conferences, workshops, and symposiums are just a few of the events that Utilization Conferences Gathering offers. We have a committed staff whose goals include acquiring technology, incorporating an understanding of the company requirements, and accelerating with the best concept and tactics. In terms of event management, collaboration, we are a service event organizer with a focus on the academic and industrial sectors of the medical, clinical, healthcare, life sciences, pharmaceuticals, and environmental science fields. We separate from our rivals because of our dedication to quality, around-the-clock service, and unbeatable pricing. We can offer you the ultimate event and meeting experience all under one roof. UCD conferences ensure that you, the customer, select the most suitable event. Our theme for the 12 nursing and healthcare, the future of nursing, healthcare, and patient safety, captures the essence of our collective vision. It embodies our shared commitment to pushing the boundaries of what is possible, embracing changes, and embracing new ways of thinking. I would like to express my deepest gratitude to the organizing committee, the speakers, and all those who worked tirelessly to make this conference a reality. I also extended my heartfelt appreciation to each one of you for each one of you for being here today, for your dedication to healthcare, and for the impact you make on the lives of others every single day. Today marks the major activity in the brief existence of the UCD conference, a moment when we interact, share experiences, and reflect on various areas. Let us seize this opportunity to learn from each other, forge new connections, and elevate healthcare practice to new heights. Together, let us empower excellence in nursing, healthcare, and patient safety, inspire innovation, foster collaboration, and place at the center of everything we do. Now, I take the immense pleasure of introducing the keynote speaker at the 12th International Nursing Healthcare Management and Patient Safety Conference, Miss Abir Hamami, Dr. Barbara M.D. Groot, Dr. Sahar Muhammad, myself, Prof. Anigrit Hanawa, Prof. Len Kelman, Dr. Badriya Muhammad Al-Riyami. Thank you all. We will now begin the sessions. Let's start with our first keynote speaker and friend whom I met at San Francisco UCD conference, Dr. Barbara M.D. Groot from United States of America. I'm passing the stage to deliver the speech on improving fall risk assessment to reduce falls in assisted living communities.
Good morning, everybody. I've traveled a long distance and I got in very late last night, so please bear with me. Yes. Okay, is that better? Okay, so as Dr. Mohamed said, my talk is going to be about changing the way that we assess for fall risk to reduce falls in assisted living communities. Let's see. Yeah, share. So a brief little history. Falls, as you know, can occur in any setting. So they are a safety issue. They're one way that we measure our healthcare quality. In my state, New Mexico, they're the leading cause of unintentional death in adults 65 and older.
You can just come to us.
Is it going to stay? Sorry, technical difficulties. And there is limited evidence about the current fall risk reduction assessment processes and practices in assisted living communities in New Mexico. Falls increase healthcare costs. They increase hospital and emergency room overcrowding. They increase the risk of future falls. Oftentimes, patients lose independence, their ability to remain living in their homes, and they are very frequently underreported because the culture needs to be embraced where there is no blame. This was part of my doctoral capstone project. The purpose of the study was to reduce falls by 20% over a 3-month period, October 1st last year through the end of the year. And the other secondary goal was to increase staff knowledge of fall reduction practices. Question was, in adults age 65 and older, pardon me, does using the Morse fall scale and the medication risk score compared to not using the medication risk score and the Morse fall scale alone, does that reduce falls over 3 months in assisted living communities? I used Orlando's deliberative process nursing theory. I like it. It's very simple. It promotes the interrelationship between nurse and patient. The nurse responds to the patient's actual or perceived needs. It's very, very simple. I also used Rogers' diffusion of innovation theory to implement the change, and hopefully it will sustain itself in the community in which this study was performed. I searched the PubMed Cumulative Index of Nursing and Allied Health Literature, Medline, Google Scholar, and the Cochrane database for systematic reviews for English articles published in peer-reviewed U.S. journals between 2012 and 2022. Initially, I retrieved 943 articles. After a first screen, 880 were eliminated for duplication, editorials published in a foreign language. A secondary review came up with 63 articles, that's the result, and another, can't remember how many, 27 were excluded, which left me with a total of 36 studies with which to base the study on. There were 11 level 1 systematic reviews, evidence-based practice guidelines that provided very robust data for the study. 1 level 2 random controlled study, 14 level 4 cohort studies, which I included because they gave a perspective from either the nursing view or from the patient's view. And I think that's important to understand those views so that when we do implement change, it can be sustained. 8 level 6 and 2 level 7 articles were also included. I used the Promoting Action in Research, Implementation, and Health Services framework to help implement the change also. And it's very simple. It's the success of any study or any change is based on the evidence, the facilitation with the leadership in the community, and the context in which the study is performed. As this was part of a doctoral program, I received IRB approval from the University of Missouri, Kansas City, and the School of Nursing, and also from the leadership in the community. I used a prospective quasi-experimental repeated measures design. The Morse fall scale, medication risk score, and the AHRQ fall knowledge tests were my instruments. Participants were residents age 65 and older in the community, and recruitment occurred by a single resident meeting and staff identification of residents. And I say single because there was a recurrence of COVID within the community, and I was not allowed to go back into the community to conduct any more answer any more resident questions or to perform the educational intervention that I had planned either. So the study consisted of 5 steps. Residents were assessed at initiation of the project. The nurses calculated the Morse-Falls scale and medication risk scores. They implemented based on those scores. The cutoff was 45 on the Morse-Falls scale. Anybody higher than 45 was considered a high risk, lower than 45, low to moderate risk. So they implemented universal or individualized fall reduction practices. Excuse me. The second phase, they monitored the residents for falls, changes in medications, conditions, perhaps hospitalization. If a resident fell, was hospitalized, or had a change in medication, the process started over again. Monitoring continued, and at the end of the program or the study, they were reassessed again to see if there were any reductions in fall risk and or medication risk scores. It was a very small sample, which makes generalizing this to other populations very difficult. 4 women, 1 man. Ages ranged from, I believe, 88 to 92. All were Caucasian, 1 high school graduate, 4 college graduates. I also asked them to report their perceived health status. And as you can see, 4 reported them as good, 1 is fair. Also asked how many falls they'd had in the last year. 1 resident had had 2 falls. Had they restricted their activities because of falls? 1 person restricted activities, walking and showering. And then I also asked about feelings of isolation or depression. 2 residents reported yes, that they had experienced isolation or depression because of falls, and 3 reported no. 2 residents also reported that because of falls or their perceived risk for falls, they were afraid of falling, and 3 reported no. Morse-Falls scores pre-implementation, only 4 of the participants were assessed, so I had 1 missing. The mean score was 66.4. Minimum score was 40 and a maximum of 90. The Morse-Falls scale, I believe, goes to 125 total points. So the range there was 50. After implementation, all 5 residents were assessed. The mean score dropped to 61. Minimum again of 40, a maximum of 80. So we had some improvement on the Morse-Falls scale there. Medication risk scores, all 5 residents were assessed pre and post implementation. The mean score was 6, which placed them in a high risk category. Minimum range was 0, maximum was 10. 1 gentleman was on several cardiac medications, and I believe an antipsychotic, so that really bumped his score up. Post-implementation, again, 5 were reassessed. The median score remained 5. The minimum, though, rose to 2. The maximum was 10. So we had 1 resident who had 1 medication discontinued. I believe it was also a cardiac medication. The staff who participated had a little bit larger sample. All, not much, just a tiny bit. But for me, it was a win on that one. All were female. a variation in races. I had Hispanic, I had Caucasian, I had Asian, I had Native Americans. Education range from high school general education requirement to college graduates, so an RN and an LPN. 9 were resident aides, 1 was a certified nursing assistant, and 1 LPN. The time in their position would influence how they viewed falls. So I asked about that. We had 1 woman who you can see was in her position for between 21 and 30 years. Most, though, pardon me, most, though, were less than 5 years or less. Did they think that falls were a normal part of aging? 9 people reported yes, and that surprised me somewhat. 3 reported no. 12 people, all 12, believed that falls were preventable. And again, 9 people thought that falls in their community were a problem and needed to be addressed. Staff fall knowledge. I use the Agency for Healthcare Quality fall knowledge assessment. It originally was a 13-item test. I removed the 3 questions that pertain specifically to inpatient hospitals. So, pardon me, missing 1, so only 11 took the pre-implementation test. The mean score was 41.8. The minimum score was 10. Each question was worth 10 points, so this is all out of 100. And the maximum score was 90. Post-implementation, there were changes in staffing, so only 6 staff members participated in the post-assessment exam. The mean score rose somewhat to 55. The range was 80, again, a minimum of 10 and a maximum of 90. I also measured falls per 1,000 bed days. And as you can see, pre-implementation, there were 5.5 falls per 1,000 bed days. And post-implementation, even though I'm not sure how to say this one. The falls rose 2.2 falls, so to up to 7.7 falls per 1,000 bed days. And I believe that mainly was a result of a lower population and a higher number of falls. So there were some limitations that I noted. Inclusion and exclusion criteria were, I thought, fairly restrictive. They had to be age 65 and older, not be on a hospice program. They had to, it just flew out of my mind. I am so sorry. It just went somewhere else. That's embarrassing. The implementation strategies were also considered, again, using a nursing theorist to help guide the program, using a defined change process to help guide it, and then recruitment strategies. Although well-intended, again, I was only allowed a single 1-hour meeting with staff and residents. Small sample size. I don't believe, because of the number of college graduates, that they adequately represented the greater New Mexico population. New Mexico is a very poor state. It's very rural in some areas. college graduation rates are low, even though we have, you know, the higher technology businesses in the area. So again, I was not able to conduct my educational intervention due to an outbreak of COVID. And then it was very clear to me in some of the staff responses that there were differences in fall reduction practices and what actually constituted a fall. The community was supplied with posters and supplies and instructions from myself. I left my contact information with the community for reference and contact purposes. Unfortunately, earlier in the year, in February of 2022, I had another community all lined up. It was a very large community, and they had, I think, 4 or 5 buildings in the Albuquerque area. And the request went up to the leadership of the organization, and it took them 5 months to come back to me and say, sorry, we're not going to do it. That was at the end of July. So I had to kind of scramble to find another community. I was working as a nurse educator for a local college, and I chose to utilize one of our clinical sites where we send our students. I think in retrospect, if I had taken more time and found a different community that might have been more invested in learning about the falls in their communities and how to prevent that, I think I might have had a better outcome, but water under the bridge. And then transferability, again, a larger sample size. A larger sample size.
I wanted to test. Sorry for that.
That's okay. A larger sample size would have produced, I think, better outcomes. Power analysis, I should have had around 27 participants to establish a power of 0.8. Successes, the residents knew what the fall risk was. There were modest improvements in the Morse-Fall scale medication risk scores and staff fall knowledge. However, it's hard to correlate those changes with reduced falls because I was not able to conduct my educational intervention. The other outcomes, the Morse-Fall scale and medication risk scores were similar to those in other studies. And the pre and post study medication risk score did identify changes in fall risk. Opportunities, take your time. Don't catch the first fish because as I said, I think it would have been better had I had taken my time. Establish early and frequent contact. I had quite a bit of difficulty maintaining contact with the community. Telephone calls were not returned. Emails to the contact person and her supervisor were not returned. I offered to implement the educational intervention over Zoom or another platform. Oh yes, that would be a very good idea. But they never got back to me with a date and time. So again, made it very difficult. And then I have her conduct a background investigation. And this is actually something that I'm working on right now because the study was not as successful as I had intended. I'm working now on developing a survey to send to all of the assisted livings in the state of New Mexico to see what their fall reduction practices are. The regulations right now from the New Mexico Department of Health state that the community only has to assess for a history of falls. Carl, I'm going to pick on you. So Carl would be my resident. I would say, Carl, have you fallen in the last 6 months? And he would say, yes. And I would say, now tell me about what activities you enjoy. There's no follow through on that. They don't have to follow through, which puts everybody at risk. So that's, although it's background investigation, that's my study that I'm working on. So unfortunately, the study didn't demonstrate a reduction in falls as anticipated. One resident fell, 20% of my population right there. And older adults are often marginalized because of their age and physical or mental abilities. The study, again, I'm working on right now. Hopefully the outcomes of that study will help guide individuals, pardon me. Whoops, went the wrong way, hang on. Get back there. Will help guide fall reduction practices, identifying individuals at high risk, help reduce that emergency room and hospital overcrowding. What I found most interesting about falls in assisted livings was that many times residents have injuries severe enough that they can't be addressed by the community itself, and the person has to go to the hospital. With the COVID pandemic, they were housed in the hospital I worked at. We had hall beds everywhere. We had taken janitorial closets and converted them to rooms. And somebody who is already confused, at risk for falls, no bathroom facilities, the call light was a bell. They are at a higher risk for falling again in the hospital. And then most importantly, I think, with this population is to help maintain their dignity, maintain their independence, and help promote that just overall feeling of well-being and personal satisfaction. My references. Me. And I'm happy to answer any questions anybody might have. I know I went through it rather quickly. I don't have my notes with me. They're upstairs somewhere in my luggage. Any questions? Yes, ma'am.
You suggested at the end of the slides that for a background. You suggested at the end of your slides that you are encouraging for more background development kind of that. When you developed your intervention, because you were, as far as I understood, that you were, your next step was to implement the intervention after doing or doing the assessment, right? When you develop the intervention tool or whatever, did you match it with the background, with what is going on recently in the setting itself? Needs of those of that population? How did you actually make it suitable according to you?
Now I feel better. I have a microphone in my hand. So the Morse Fall scale is a tool that is highly rated and considered reliable and valid. The medication risk score, used by itself, is questionable, but
when it's used with an established tool such as the Morse-Ball scale, it has a much higher reliability, about 66 to 70 some percent. So those tools I felt were adequate to assess it. The actual fall reduction interventions were based on those scores, and that was implemented by the communities. So I didn't have, my intervention was just the use of the two tools together versus just the Morse-Ball scale. Yes, sir.
Good morning. Thank you, Barbara, for such an interesting talk. My name is Robert. I'm a physiotherapist by background. I was just interested to find out if there were any particular therapeutic interventions available for the residences. So, for example, physiotherapy or occupational therapy, because we know that research proves that exercises, strengthening, and balance activities help to reduce the risk of falls. So I was just curious to find out if those were available to your residents within the assisted living centres.
They were with a referral to the physician. So if the nurses believed that the resident required that degree of intervention, they would contact the physician who would make a referral, and the physical or occupational therapist would provide those services. The community that itself also had daily exercise programs, and all residents were eligible to participate in that. For those residents who had limited strength, they had they call them chair exercises, so they can still participate, but not to the degree of some of the other residents.
I have a question. I'm really glad to hear from you about fall, but my background is nursing, so we was talking about this in KSA in my country, and we was discussing what about if the nursing who is handling the high risk patient for fall to reduce the number of the patient for her, because sometimes they're giving her 5 and 6. And at the end there is 2 or 3 patients. They are risk for fall. So risk for fall. It means that she has to be close to the patients all the time. Plus that those patients who are above 65, sometimes they are moving by themselves. They don't want to notify the nurse. They want to stand up by themselves to go here and there. So she should be close to them. We was talking about this to develop policy that who's working with the patient high risky should decrease the number of patients for her. But,
I agree. And hopefully with this second survey, I'll be able to take that information and take it to the Department of Health, because they're the ones who license the communities right now. Right now in New Mexico, for a population of 60 residents, they need 1 nurse and 1 caregiver.
yeah.
1 to 30. Now, if I'm a caregiver and I have 30 residents and I'm in the shower helping somebody, what happens to the rest of them? So hopefully this second study will provide me with enough evidence that I can then go back to the state and say, we really need to change our practices. It's going to be an expense to the communities, of course, because they're going to have to add extra staff. I'm sure there will be some pushback from that end. But I think I have always worked with older adults. I have never wanted to be a labor and delivery nurse. Pediatric nurse doesn't appeal to me at all. I've always enjoyed the older adult population. I think that we learn so much from these folks. I love to sit as a nurse and listen to their stories from their childhood. Tell me, where were you raised? What did you do for fun? I came from a very humble background.
I was raised on a cattle ranch in California, so I know what it's like. And the stories that they can tell, and the men with their stories of their military experiences and their occupations when they were younger are just fascinating. And I think, again, it's about preserving dignity. These people are who got us to where we are today. It's on their backs that we're able to enjoy many of the things that we do. And I think we need to respect that. I'm going to get off my soapbox. Any other questions?
Good morning, ma'am. Thank you for your presentation. Here is Mohammed, working as the CRM in KSA Emergency Department and ICU Department. Actually, I was dealing with a lot of patients in ICU department, so I have that, like my colleague said, the close surveillance of the patient with full risk. But I think it's different than other departments, for example, like surgery or the ward, simple word. So my question is, how we can, according to your study, doing decrease the full risk for the patients hospitalized in the departments like surgery or medical wards?
In the US, when patients come in for surgery, whether it's elective or a scheduled surgery, the nurse, there are 2 patients per nurse. So they have very, very close observation of those folks. Preoperatively, they're fairly restricted. They restrict them to bed because they may have been medicated already. Postoperatively, they go to orthopedic for the med surg for ICU. And depending on the staffing there, it could be as high as 1 to 6, 1 nurse to every 6 patients, or it can be 1 to 1 in the intensive care unit. So I don't know. We do have staffing ratios. So on medical surgical floors, the staffing is usually 1 nurse to every 4 patients. On some of the less intensive floors, it can be as much as I said, 1 nurse to 6 patients. And I think it just depends also on the age and condition of the patients. So that's a pretty complex question for me to try and answer today, but I'm not going to stop working on this. This is kind of my passion.
Thank you very much, Ms. Barbara. It was a very nice presentation. And I do believe there will be so many questions because we are encountering this in the hospital settings. And we have to encounter and manage the situation because of the risk and the consequences and the complications. Thank you very much, Ms. Barbara. Now, Ms. Barbara, please, can I hand you your appreciation certificate, please? Yes, please. Thank you very much, Ms. Barbara. Thank you very much. Now, I would like to present my next presenter or speaker, Ms. Hiba Al-Zamil from Jordan, to present her speech about healthcare-associated infection as related to a patient 30. I'm passing her the stage to deliver the speech.
بس أكون مع الاستقرار الكاميرا تكوني هون please.
هذا السلام عليكم ورحمة الله وبركاته. Hi everybody. I'm Hiba Zamil. I'm from Jordan. I'm nursing. I'm proud to be a nurse. Really, I'm working in this field from long time يعني. But my last experience in quality and infection control and policy consultation, healthcare policy consultation. Today I will be with you to express my experience in my country, Jordan,
as infection control and how I can improve a little in this field. What's the definition of patient safety? Sometimes it's easy to think that a healthcare setting is naturally safe place, but in reality, it's dangerous place. It's not easy to say it's safe place. Why? Because we can face many problems like infections and medical errors. In fact, 2016 study done by Johns Hopkins University found that medical error may actually be the third leading cause of death in the US. Patient safety and healthcare discipline that emerge with the evolving of complexity of healthcare system, because we know all of us, the healthcare system not easy. It's complex with procedure and policy and everything. Patient safety aim to prevent and reduce the risk, error, and harm it could occur to patient during the provision of healthcare. So, a cornerstone for this discipline to improvement in this field by what? By learning from the errors and adverse event happen to patients. But there is good news. All these errors could be preventable. We can prevent it. This is the good news, and this is by proper safeguard. When we talk about patient safety, we are talking about reducing the risk for those potential errors. The Institute of Medicine has broadly defined the patient safety. They said as broad, avoiding harm to patients. But the American Board of Preventive Medicine gets more specific in this definition. The avoidance of harm as freedom. It must be freedom from accidental or preventable injuries procedures by medical care, not just avoiding harm. We have scarred numbers there. As a keynote, did you know the occurrence of adverse event due to unsafe care is likely one of the 10 leading causes of death and disability in the world at all, not just the income or the Middle East, or it's all in the world. In high-income countries, it's estimated that 1 in every 10 patients is harmed while receiving hospital care. The harm can be caused by a range of adverse events, with nearly 50% of them being preventable. We can prevent 50% of these adverse events before reaching the patients. The harm, each year, 134 million adverse events occur in hospitals in low and middle-income countries due to unsafe care, resulting in 2.6 million deaths. A huge number. This is because just preventable error could be prevented by healthcare workers working in hospital. Globally, as many as 4 in are harmed in primary and outpatient healthcare, up to 80% of harm preventable. Again, preventable. The most determinal errors are related to diagnosis, prescription of the use of medication, most of them system-wise. So investment in reducing the patient harm can lead to significant financial saving. If we reduce this, we can save money for the patient and the countries and the hospitals, and among importantly, better patients' outcome. Everyone in any place in all the world need to get health services timely, on the time, integrated and efficient, safe, people-centered. We need to focus on the patients when the patients arrive our hospitals or our healthcare. Equitable and effective. We need to focus on outcome. When our patients come, we need to improve the outcome when this admission or outpatient done. According to WHO launched first ever global report on infection prevention and control. According to this report, out of every 100 patients in acute care hospital, 7 patients in high-income countries and 15 patients in low and middle-income countries will acquire at least one healthcare-associated infection during their hospital stay. Imagine, On average, 1 in every 10 affected patients will die from this healthcare-associated infection. So we need to focus on infection prevention and control program to be comprehensive, to prevent this harm from occurring. In practice, what's the IPC? It's a practical, evidence-based approach we can use to preventing the patient and the health workers from being harmed by avoidable infection. The IPC is unique in this field of patient safety and the quality of care, as it's universally relevant to every healthcare workers and patient at every healthcare interaction. So, defective IPC cause harm and can kill. Without effective IPC, it's impossible to achieve quality healthcare delivery. Please remember this picture. Do you know what this picture means? Can anyone just explain this picture? This mother just kissing her baby.
Spreading.
This means a lovely touch can kill. Lovely touch can kill. I mean, when the mother get her baby, we just advise the mother, please keep the baby not close with you. The mother will just kissing. Everyone in the room will kiss the baby as a loving, صح? But in reality, could this baby killed by this kissing, colonized with infection, chemicals, material, and others. So a lovely touch could kill. Remember this when you care with any patient in your hospital. So, is there a relationship between infection control practice and the patient safety? Yes, we need to agree all.
Yes.
Remember this also. This is just room. Remember, this is the pillowcase, the phone, the chair, the bed. All of this healthcare-associated infection develop a patient as a result of their exposure to healthcare facility. They could get MRSA, methicillin-resistant Staphylococcus aureus, KBC, Pseudomonas MDR, C. difficile, just from the area. They come as a safe place, but really, it could be very dangerous. Stop again and rethink again and again. Why harm happen? In our healthcare facility, if it's safe, why harm happen? Why does patient harm occur? Because if we have mature system, it will take in account that increasing complexity in healthcare setting make human error more prone to mistake. Because we are complex health system, we must imagine that the human will prone more and more mistakes. Yeah. So traditionally, what's happened real in our hospital? Any one of our healthcare provider, if he make mistake, it will punished or blame. And this is not a blame-free culture. So we need to focus on a blame-free culture to increase our patient safety. If we just focus on the patient or healthcare provider as a prone for problem, it's latent error will happen, and finally will reach the patient and could be active killing error. All of you know error is a human report by IOM. This is said the humans are guarded from making a mistake when places in an error-proof environment where the system takes and processes they work in are well designed. This means we need to focus on the system, not on the human. Okay? Therefore, focusing on the system that allow harm to occur in the beginning of improvement, and this can only occur in open and transparent environment. Encourage your healthcare provider to report the error if happens. Assure the healthcare provider, you are not blamed in this error. If we have system to catch this error, it will never happen. But responsibility, it a must. If the healthcare provider have responsibility, it must be accountable to prevent this error. Okay? So we need to build a culture of safety. This culture need to be transparent, blame-free, the attitude need to be changed regarding patient safety. All of us knowing the burden of harm, if this harm happened every year, millions of patients suffer injuries or die because of unsafe and poor quality of healthcare. Many medical practice and risks associated with healthcare are emerging, a major challenge for patient safety and contributing to significantly to the burden of harm due to already unsafe care. طبعا this slide just mentioned, according to a patient safety report, some of the situation causing the most concern in the field of healthcare system. As brown, the first one, medication error. Second one, healthcare associated infection. Third one, an unsafe surgical care procedure. And this could be complication in up to 25% of patients. Almost 7 million surgical patients suffer significant complication annually, and 1 million of whom die during or immediately following the surgery. 1 million will die if they develop complication after the surgery. Unsafe injection practice, and all of us know the dangers of unsafe injection practice. HIV, hepatitis C, hepatitis B, all of these diseases transmitted by unsafe injection practice. Diagnostic error. I faced this problem before I coming from before 2 days. My brother, 37 years old, he young, medically surgically free, coming to the ER, just complaining of chest pain before, not one night, heavy chest, sweaty, drop down. When he come to the emergency, one junior doctor just coming to my brother, without asking about the significant or the sign symptom, just ask for ECG and cardiac enzyme. Cardiac enzyme normal, ECG there is a changes. He said, could be normal. Just take him to the home. But because I'm working in healthcare and I know this is not normal to be ECG changes with sign and symptom and take this patient to home. So I called the senior. Please, can you come and see my brother as friendly? He said, yes, I will come. When he come and ask some question, my brother unstable angina and need urgent admission, urgent care. When we do care, my brother have some closure and weakness in the muscle. Smoking. 37. Okay, this is some diagnostic error could be. Unsafe transfusion reaction. For example, blood transfusion, if we have some reaction and not reported by healthcare, it will be a risk for adverse transfusion reaction and transmission of infection. There is also radiation error and the sepsis. Sepsis not wait, I face a lot of cases in a neonatal ICU, general ICU. If the baby develops sepsis, especially acinito MDR or eclipse, because sepsis diagnosis early enough to save the patient life in sepsis. So we need to be more alert, okay? These infections are of resistance to antibiotic. They can rapidly lead to deteriorating clinical conditions, affecting an estimated 31 million people worldwide and causing over 5 million deaths per year. And the venous thromboembolism, blood clots. This is some problem could face a patient during the inpatient staying in the hospital. Now, we need effective IBC. But how we affect or how we achieve IBC program, we need action from all the level. Policymaker, from the beginning, we need leadership, we need policymaker, we need the facility manager to be with us, we need the health worker to participate and engage on the care and improvements. And who's this patient who get the services? We need to engage our patients in the service to get the improvement. Infection prevention and control affect all aspects of the hospital, all aspects of the health. If we didn't doing proper hand hygiene, we will affect the patients. The surgical site infection will increase and more killing the patients if we didn't follow the protocol and the guidelines in surgical prevention. surgical site prevention. The hospital, how it's prepared in emergency situation, for example, in pandemic, during COVID, all healthcare sitting complaining. PPEs, healthcare not receiving education, training, how to deal, fears, burnout, turnover. This is, we need to prepare our system to be ready in any emergency situation. Okay, and we need to follow injection safety because it will affect other and other. We need to focus on antimicrobial resistance. Now we face a big challenge with the antibiotic and this antibiotic misuse in all disciplines. It will be affected our system and our patient safety. To ensure successful implementation of patient safety strategy, again and again, we need leadership. We need data driven to be built in our decision. Okay, we need to clear policies and guidelines, procedure, education, training, preparedness. All of this need to be integrated with each other to build a huge system in healthcare. Now, we have 7 strategies to prevent healthcare associated infection. It started with safety culture. The first one, safety culture. You need to build this safety culture because if the healthcare worker feel free, feel not blamed from any error, they will be report, they will improve, they will feel like respected to improvement. Okay. Second one, we need to follow guidelines and policy to standardize the work. Guideline and you know what to do. The ICU will work alone, the medical surgical will work alone, but if you have in your system policy and guideline and the procedure, all of them will follow one standard document. And antibiotic stewardship, all of you must think again. You need to be focused, you need to be engaged on this stewardship program. It's very important now because they affected the community, the family, the visitor, the patient. And we need to focus on the surveillance. How we know if we have problem or not? If we have surveillance program active in your healthcare setting, it will catch every problem. It will catch every, for example, for healthcare associated infection, I have surveillance from 2005. I'm working on it, and I can know there is a peak there. There is a problem. What's happened? And I will present my focus BDCA to show you just this as improvement. And also we need the environmental hygiene. As we said, this environment could be source of very killing microorganism like MRSA, Klebsiella, and others. And a big umbrella in hand hygiene. If you focus on hand hygiene in your healthcare setting, 75% of the infection will be prevented. It's most simple one, just to educate your healthcare provider how to clean properly their hands. Hands, they say, it could be killed also. All of you as expert in patient safety know this Agency of Healthcare Research and Quality. They work project for improvement. All of us can take this project and maybe work as example. I just apply some project they work on and some statistics. First one, prevent central line associated bloodstream infection project. This preventing the central line by taking 5 steps every time with the patient. They take just 5 steps. The first step, wash your hand, use full barrier precaution. Full barrier means full sterile technique, and the skin, clean the skin with chlorhexidine, not iodine, bavodine, just chlorhexidine. Avoid the femoral line for adult. They use the femoral line as a guideline, evidence-based practice said. You can use the femoral line for pediatric. In adult, no, because it's more prone for infection. You can use the central line, subclavian and jugular, okay? And so avoid the femoral line and remove the unnecessary line daily. Daily, you must check as a nurse and physician, you need to check it daily, assessing your patient for need. Is this patient need a central line, or we can change for cannula or others, okay? By taking these steps, consistently reduce the type of deadly healthcare associated infection to zero in a study at more than 100 large and small hospitals. If you need to know more about this, this is the website link. You can go and read more and more. Re-engineering hospital discharge. Someone, Muhammad, I think, asked before, how can decrease the readmission for the patient from the emergency? I think this is my understanding for your question. So according to ARC, they take this as a project for improvement for decrease the readmission for patient. Reduce potentially preventable readmission by assigning one staff member to work with the patient. So we need to talk again about the ratio. They just put one assigned staff member to work closely with the patient and other staff to recounsel medication and schedule necessary for follow-up. Okay? Create simply easy to understand discharge plan for each patient and name the phone number whom to call if the problem arises. يعني باختصار, they develop discharge plan from A to Z from the patient's admission to the hospital. Someone assigned close to the patient, the other one just putting a discharge plan at all. Okay? ARC funded research shows that taking this step can help reduce the potentially preventable readmission by 30% by this research. Prevent venous thromboembolism. This other one, for those who are working in CCU and other intensive care unit, they just educate the patient most common cause of preventable hospital death by using evidence-based guide to create protocol. This protocol can guide the education for the patient from A to Z. And using the blood thinner safety like warfarin, other patient project, they just educate the patient how to use the warfarin and the contraindication and how to use it correctly. A free 10-minute patient education, just free 10-minute patient education videos and pages, booklet. They give the patient booklet about this topic and giving video 10 minutes because some patient didn't read. My challenges in my hospital, this is the discharge plan, print out and give the patient, go. But this old age, some of them have language barrier. So if you prepare just video for 10 minutes, you can solve the problem, صح? So this are doing this 10-minute patient education video. And this is decrease medication order with warfarin. This is other one, very important. They match, limit the shift duration for medical resident and other hospital staff, if possible. And I know it's not possible because all of us face shortage in healthcare provider. During pandemic, all of us, we was in panic. Sorry. Okay, evidence showed that acute and chronically fatigued medical residents are more likely to make mistake. Ensure that the resident get enough sleep and adhere to 80-hour work week limit. A resident who work 30-hour shift should only treat the patient for up to 60 hours and should have 5-hour protected sleep period between 10 p.m. and 8 a.m. So we need to focus on this also, not just that. We need to focus on something on quality for residents and the nurses and physiotherapists. All of them need to be to take enough sleep because this will lead to more mistake. Good hospital design principles. Some of this the most important one. Evidence-based principle for hospital design improve the patient safety and quality. Prevent the patient fall by providing well-designed patient room. Sometimes if the room had safety, like a bed with side rail can catch up, we can see sign, we can build with the hand. The bathroom very, very help to the patient. if anything happens. It will be good design, good prevent the fall. Yes. Also, a patient room, single room. Sometimes in Corona, we face this problem. Where to isolate the patient? What's the negative pressure system? I need negative pressure. What to use in OR? Hand hygiene products, a sink, it's available. Can anyone of healthcare worker arrive these things and use the hand hygiene product effectively? All of this could prevent the medication error by efforting a well-built system. Measure patient safety culture. I think it's the most important one. Everyone needs to know if you have patient culture or not. ARC, they give us survey for free. They put on the link. Just use it as is, and it will give you full picture about your healthcare provider and system, if we have safety culture or not. We need to build a better team and rapid response team. This team could save the patient anytime. A team building very important to protect the patients from any harm. Train your hospital staff to communicate effectively to the team. The free custom, they produce for us toolkit called Team Steel. All of us, I think, you see this team steers between endorsement. This is for healthcare hospitals. Okay. Performance and enhance performance and patient safety, provide evidence-based technique for promoting effective communication and other teamwork skills among the staff in various units. This could help you to communicate effectively if you use it. It's ready to use, and this is the link. And if we open it, it will give you a huge education material and how to use it, videos. Now, my project. After this, I will show you. During my surveillance, but because I need, yes, just 2 slides.
Just 1 minute.
Okay. Just this. Because we have surveillance system from long time, we collect this data. During 2021, we noticed that there is elevated ventilator associated pneumonia. We follow BDCA. I think all of you know what's BDCA mean. It's a plan, do, check, act approach in equality. We use it as value prevention. Action plan was developed by the we developed interdisciplinary team, and we developed action plan, do, check, act methodology, and reviewed on ongoing basic. The plan include the benchmarking data and the objective, completing for our project. The action plan also identify milestone, each with detailed description, started, the in-depth responsible team member, the primary support and resources, a section for all comment we need to use. Then we apply this action plan. We use a prevention effort in the ICU, including the IHI bundle of care. There is a standard care called the bundle of care. We use it. This protocol include additional oral care as an effort to ensure compliance with both. The bundle said we need to daily sedation vacation for the patient. We need to elevate the head of bed 30 to 45 degrees. We need to use the oral care with the chlorhexidine and thromboembolism prevention. After that, adult respiratory performance improvement monitor follow sheet for compliance was conducted to ensure all of them just apply this in ICUs. A comprehensive and mandatory in-service training was provided for all respiratory care and registered nurses working with these patients. And to assess the effectiveness of BAB, already we do a check for our data. Measurement done after implementation of this protocol, and as a result, we show significant decrease. If you see, this is the significant decrease in 2022. This is the peak in 2021, and this is from January to December. Okay, was significant by implementation, simple steps, education, bundle of care, resources, isolation, surveillance. So this is my success story. in this VAB prevention project, and this is my team. We are 3 girls and 1 boy, but I will never give.
Thank you very much.
Is working from her as a nurse.
We all believe hospital setting without effective infection control and prevention, it is impossible to achieve the quality of care. Thank you very much for your presentation. I will give the chance only for one question. Because of the limited time. Okay. Yes.
Hi, good morning. Thank you for this wonderful presentation. I have a question. In our hospital, we are monitoring our staff and hygiene based on the consumption of alcohol. Is it a good way of evaluating the hospital staff? How much, if we put some alcohol, these hand washing scrubs everywhere. Now, the consumption, is it a good method?
This is one of the way to observe the contagion, but it's good and not good. يعني if you use it with other observation ways like observation system, there's a car, there's new technology to observe, but need money, okay? It's better. But if you use it alone as a consumption, some staff use it for making coffee. You need to see a real situation.
Thank you so much. Thank you.
Okay, thank you. Carl, please speak.
Hello.
Hello.
That's a good presentation. Thank you for presenting it. Just a question. When COVID hit, the healthcare system worked on preventing infection a lot more. In fact, percentages went down in terms of who caught infections and cross-contaminations and stuff like that. It was very extreme. Went from one extreme going quite bad in terms of what we caught before COVID to putting all those things in place, all those systems in place, like you say, increased surveillance and whatnot. So now it seems that things are going back to normal. I don't want to say that. The infections are starting to rise again.
Yeah.
So what is the best way to tackle that?
Yeah. I will tell you something. Now, during COVID, all the staff was scared. So fierce. They do a lot of hand hygiene. They do taking the PPEs. As a system, we apply everything. We apply the isolation guideline. I working for COVID patient in Northern Jordan as a first hospital. I transfer all the cases of the COVID patient in my hospital and transfer this hospital just for COVID. So I produced every guideline and the procedure, and we assure the staff and provide every resources, even we face problem in the resources because of quarantine with others, limited resources. It's national, and this is not allowed. We use every international FD, but during COVID, you need to do anything you can. So during COVID, after COVID, we implement this correct. During 2022, we decreased the rate. But if you see at the beginning of this new month, raise again. Because the staff feel free, COVID go on. They, for example, my colleague said a lot of work. Even in ICU, I assigned 1-to-1. One nurse, one patients. But during the past period, one of them leave and other turn off. So we face this problem. So we need again to focus on the system. You need to be ready for any emergency situation. Just this is the golden standard. Thank you. Thank you.
Now, I would like to welcome our next speaker, Ms. Tiffany Al-Khouri from Canada. I'm passing the stage to deliver her speech on
enhancing staff involvement in hospital management, a customized electronic health records in Africa. Thank you.
Well there. So we'll be talking about a customized electronic health. So I will talk briefly about our team, our approach, what is ACES framework, and the healthcare generally, the healthcare climate, the perspective put in action as a solution, the services, and why choose ACES, and I will also show you a small demo about it. Okay, so our team, So we are an interdisciplinary team specialized in healthcare and technology, collaborating on the development of a comprehensive health information system using a high flexible technologies for a better customization. Why we choose customization? Because when we first started in Nigeria specifically, we implemented a standardized software. Okay, so what happened is that we saw a non-compliance on the system because it was a very big, like the gap between the system and the healthcare providers and their own trainings, their own education was very basic according to the standards of a standardized hospital integrated system. Okay, so our company is based in Canada as well. We are healthcare providers, quality specialists, technology quality analysts, researchers, program developers, cloud architectures, software, IT, telecom, and computer engineers. We all together have more than 10 years of experience in healthcare and technology, and we have the cherry on top, the three years in Nigeria now. Okay. So we all know that enhancing patient safety is a primary objective within the healthcare sector, okay, which undergoes constant evolution and diverse changes in terms of technology, shifting demographics as well, policy reforming and evolving patient expectations also. So given the complexity of extensive regulations of the healthcare, resistance to change is too high and arises from various factors, posing a significant challenge. So our approach is mainly these three frameworks. I'm glad that Mrs. Hiba talked about the healthcare approach, the quality approach, and the PDCA and all of this. So we'll talk here about clinical governance. We all know that clinical governance is the title of patient safety in hospitals. Okay, it will improve the quality of healthcare delivery. It will monitor performance and manage risk effectively. It will ensure, like overall, it will ensure the patient safety within the healthcare organization. Now, the second methodology is similar, like it's like the PDCA cycle, okay, but it's let's say it's used more in technology. It's called agile methodology. It will deliver high quality software products while responding to customer needs efficiently. It is very flexible, it responds to changes very easily, and it helps with continuous improvement, because we know that in healthcare there's nothing static, so we are moving forward too rapidly, and this methodology is effective for to change the software easily whenever the client or the hospital wants to change something new, maybe to add something or to remove something. Like, it's according to them and according to their own quality system. And then again, we added also the lowest model of change. So this is an approach in nursing that we use to change a habit for the staff usually. So it will navigate the complexities of change and increase the odds of successful and lasting transformation. So that briefly, the three phases are unfreeze. So whenever we want to let go any old pattern, we need to involve the client. The client is the patient, the client is the staff, and the client is the organization executives, okay? And then we will do the change. After doing the change, we will refreeze the new habit on the software itself. So briefly, this is our approach.
the unfreeze, the change, the refreeze. In the change phase, we will do the cycle of the agile methodology or through the clinical governance. Okay, so patient safety, effectiveness, timely services, etc. Now let's talk specifically about Nigeria. You will see all my references on the bottom of each page. Okay, so particularly in Nigeria, the difficulties threatening the healthcare sector are many. They have inadequate human resources. All the people there usually go abroad to practice. And if they are in Nigeria, let's say the training system or the education system is very basic. Like they don't know much about healthcare, about let's say quality culture. They are not involved this much on like about all what you need to know and the standards of healthcare. The high disease overload, of course, the poor leadership and administration, the poor integration of programs, the lack of accountability and transparency, the poor quality of healthcare services, and the weak health information management system. They do usually their customized healthcare system, but it's mostly focused on billing. It's not focused on e-prescription or any supportive decision-making sheets. Okay, so what we did is a case study in the government house clinic in Nigeria. Okay, we had all the root cause analysis reports done, and you know also in the root cause analysis you have also observations on ground. So you will have a quantitative and a qualitative study. Okay, it's been like we worked on it for almost 3 years. What we had mainly, we have compliance on protocols. Why on protocols? Because the protocols are a step-by-step process. So they know one task at a time what to do. They don't have a compliance on policies, on hospital workflows and the chain of commands. They didn't have the capacity to comply on the standardized softwares because it's too difficult for them to go through and to serve on. And then they have a weak time management, a lack of consistency, a centralized decision, a weak orientation to details, a fragile leadership and involvement, weak communication among workers, which is number one patient safety goal. Okay, and staff is not exposed to the large variety of consumables and medications that are normally used internationally. They don't know what is posiflow, they don't know what is stopcock, they don't know what is extension tubes. Like these are very simple consumables that they don't know about. They don't know that maybe also the oxygen can come from the wall. They have only the bottles of oxygen. Okay, so this was very critical for them. And for me, like as a software creator, I need to know what they want and what they know, so I can make sure they can comply, just to make sure that the patient is safe. And so, okay, now here you will see we have a lot of challenges to work on through the software. But in data mining and data processing is very difficult. So we cannot work on everything at once. So what we did is a Pareto chart just to prioritize what we need to work on as a priority. So first of all, we worked on the software about on the lack of communication among workers, then the lack of time management, the lack of consistency, and the centralized decision. We worked also a little bit on the lack of orientation to detail. Now for the rest, it will be later on. Okay, what is ACE mainly? It's an agile clinical information system. So for the weak communication among workers, we worked on a dashboard called follow-up dashboard. It means this dashboard will show you whether the patient did a lab test. So you will see that the physician requested a lab test, when it has to be done, whether the patient did the lab test, whether the physician saw the lab test as well, and whether the physician informed the patient. So to close the loop and get back to the patient again, whenever he has a lab test, radiology, investigation, etc. For the week time management, we worked on unified and direct workflows, and we worked also on the e-prescription. The e-prescription for them is a little bit different. it's not too flexible because I don't want them to, let's say, have any gap or any challenge and make any errors. Okay. Now, for the lack of consistency, we worked on enhancing notifications. So they have a lot of notifications to remind them of what they need to do, and an automated data collection forms. So all the data collection is according to a specified forms that needs to be done at all times. It's not that one patient, like let's say for the cardiovascular system, the data collection is very clear. It's not according to you what are the data you want to retrieve from the patient. And now the centralized decisions. Okay, what we did here is for the same form, it is allowed, like let's say the nurse from one side, the physician from the other side, and the lab scientist from the third side, let's say, all the three of them will work on the same sheet as a dashboard, on the same dashboard, but each person or each healthcare provider has its own access. Okay, so they can see what they did, but the power is between everybody because there also they have unipolarity. The physicians are mainly the leaders in the facility and they are the one making the decisions at all times. Okay, again, we will talk about the continuum of provider engagement. As we know, like with time, the physicians were leading before, and then the nurses shifted and they are the leaders of the hospitals. And now we are talking about interdisciplinary approach. So in the software now, we are talking about interdisciplinary approach, which is a worldwide strategy since 2015. Now, for the engagement of the patient, we have also a challenge there. For example, I cannot put a patient portal because the patient doesn't know how to take an appointment, let's say, how to surf through the application to see the results, etc. So we didn't include well while waiting for the patient to know his rights and duties. So whenever the patient will know the rights and duties that he will be more involved and he will be a partner in the decision, because I cannot at all times let the patient take a decision while he doesn't know and he's not knowledgeable about it. While now you know that, like, it's everywhere, like we work as a partnership with the patient. It's not a patient-centered approach anymore. Okay, and so with this perspective, we will rebalance the power between the providers and between also the patient and the provider. It means we will be waiting for the patient to step forward and be also a decision maker in his own health. And this, I guess, will take Nigeria to a worldwide standardized protocols and policies. And now the difference and what we are doing mainly is a site visit before every hospital launching. So whenever we do a site visit, we will elaborate the strategic vision with the executives and we will check also the architectural workflow. Because whenever you know also, you will, like the software and the communication among workers differed according to the architectural design of the facility as well. And then we will do a consultancy. We will set the customized workflow while making sure it meets the required standards. Okay, like let's say the executive will tell me or will tell us about a workflow, a specific workflow that is customized. We will just make sure as quality professionals that this is a safe workflow for the patient. It's not that according to their own, point of view only. And then we will do the implementation according to the hardware or the cloud-based, and then we will do the training for the compliance. Now here, for this facility that we worked on, they, like the staff are the one who did the, let's say, the image or the picture of the software, according to what they like to work on. The support also we also deliver support over the year. And what is specifically for us is that we do routine. Okay, and now this is a small demo, so you will see For example, here the follow-up dashboard. The follow-up dashboard, as you can see, let's say for a patient named James Smith, he did a malaria test. Okay, it was seen by the physician, it was executed and seen by the physician, but the patient was not informed yet whether the malaria is positive or negative. Okay, so it's a very simple dashboard, and it's only a view dashboard. They cannot edit anything here. So it's according, let's say, whether the physician opened the laboratory test, the software will know that this laboratory test was open. So it means the physician saw the lab test. The physician will click as lab test seen, and it will be shown here. For the nurse, it will be easier for her to follow on her patient, whether it was like the loop was closed with the patient, yes or no. Now here with the e-prescription, what we did is mainly, it's the same as the e-prescription everywhere. But what we did here is, let's say, if a medication needs to be given once daily, the software will open one row. Not the nurse will click to open one row, okay? So she cannot add or remove a row. She needs to give every 8 or or once daily, etc. Now for the every 8, you have three rows to be open. Now if it's given or not, it's according to each patient. For the IT support is on the system as well. You can see also notifications also on top of the page. Okay, I'm not sure if you can see. You can. Okay, so you don't. Okay, it's fine. What I mean by the automated data collection is, let's say, whenever you want to do an assessment for the patient, you do it according to sheets, correct? Okay. So what we did is we put the sheets on the software, so they will know what data to be collected. Okay, according to their own community, to their own the community is totally different from what we know. And now this is the integrated results for the radiology and the lab, integrated staff schedule, rebalance. Okay, now here's the rebalancing power between the departments. It means, let's say, in the first 1, 2, 3, 4 rows, okay, the nurse was the one who did the data collection. If I'm not a nurse and I access this sheet, I cannot change anything there. I don't have the access, but I have the access to continue the information. So in this way, I'm rebalancing the power so that the nurses will be more exposed. They don't know, even when we first went there, they don't know how to put an IV line. Okay, it was for the physician to put an IV line. So like just to introduce them more and to expose them more of decision-making process, etc., you need to just make them like do it step by step. Okay. Now this is, let's say, a pre-coronary CTA assessment form as well. So they like it will be well done, like what data collection we want. And now, okay, so again, what we do is we need one representative from each hospital. They will tell us what they want. We will sit with them, we will customize it with minimum standards, and then we will move. If they want, of course, if they want an advanced software, it will be done. We already have a standardized one. But for them in Nigeria, they won't use. Now, why we do also websites? Just to work on patient knowledge. Okay, we work on websites as well with the facility to let the patient know more and how to introduce healthcare and decision making for the patient more, because the website usually is for the patients. Okay, and then for the software, we will take, of course, we will take lists from the facility for the medication, for the consumables, etc., and what kind of roles they want. Let's say sometimes they ask for a permission for a physician to do a fall risk assessment. Like we won't give it. It will be for the nurses, okay? Because usually the nurses don't do this. We gave, let's say, the DVT assessment for the physician, okay? And that's it.
Thank you. Any questions? Thank you very much.
Thank you.
Can I give you a certificate?
Yes, sure.
The certification of appreciation.
Thank you. Now we'll be taking 15 minutes for a coffee break and collaboration. After the break, please everyone. Okay.
Oh, yeah.
Hello, good afternoon. We should continue now, please. Welcome back. Hi. Yes. Now, our next speaker. Can you hear me? Now, our next speaker is Mr. Carl Dowling from the UK. I'm passing him the stage to deliver a speech on existing barriers with healthcare workers who work in the emergency medical services from low-income to middle-income countries, accessing affordable continuous medical education due to their low-rated currency when converted to the United States dollars.
Keep here staying in answer the questions because online space I think they can hear and see your face. Okay.
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 Fine.
Yes. The stage is yours.
Hello. Testing 1, 2, 3. Can everyone hear me? How is everyone today? All good? Enjoying the conference? Good. That's what I like to hear. So, welcome to my presentation. Thank you for introducing me. So, there have been many changes in health professions education over the last 5 decades. As for the first 4 decades, the pace of healthcare delivery reform far exceeded the pace of healthcare professionals education reform, where once a professional completed their final sign-off and their training, they were known as a finished product. However, at this present time, healthcare workers must comply with their professional licensure laws, as me and Barbara were talking about yesterday, and follow the health system standards, where they are required to maintain some form of continuous medical education. Now, who here, if you could put your hands up for me, is involved in continuous medical education? Anybody? Do their CMEs? Yeah? Quite. Oh, yeah, sorry, I saw you there. Yeah, thank you. Excellent. Very important. Good work, team. So, one of the United Nations Sustainable Development Goals is to achieve universal health coverage. By 2030, unfortunately, there remains to be lower investments made in continuous education of healthcare for workers along the gross mismatch with disease burden and population needs as well. There are several discrepancies that exist between standards of healthcare provision with high income and low and middle income countries, resulting in poor infrastructure and under-resourced education on healthcare systems. As Zed et al. Completed a systematic review on continued nursing education in low-income and middle-income countries between 2007 and 2017, where the results gathered showed the main models utilized include train-the-trainer models, always helpful, low-dose, high-frequency models, always good, multiple media training models. So, you know, we all use multiple media now, don't we? Social media, that's a good one. In addition to strong international partnerships with increased integration of cultural context provided a stronger level of education in terms of knowledge base and improving the patient's quality of care. Well, the patient's quality of care is why we do what we do. And having a strong educational background and maintaining that is important to provide that patient care and that level. So I have a video. I don't know if it's going to play. I hope it does. I like the video. It's a good animation. But we'll see what happens. Did you accept the video when it enabled? Technology these days. So I'm clicking on it, but it doesn't seem to load. Where's Ben when you need him? Ben, where are you? Benjamin. He's gone. Okay. Well, I guess I have to continue without him. The video, it won't work. I think it might be when you download the PowerPoint Max, just the person I need. So I've clicked on it, but it's just not doing anything. Now, do we download? Oh, okay. Yeah.
It's not okay.
No, we can go without it. I can wing it on the fly.
Yeah.
Yeah. Should I do that?
So you have in YouTube?
Say again?
Have you uploaded in YouTube?
That was YouTube. I integrated it.
It's not working.
That's okay. All right, it's okay. It was a 2-minute video. It's fine. We can get past that.
Sure.
We do what we must. Thank you for your help.
Thank you.
Bless him. So, objectives. The objective of this research is to help identify the various emerging medical services. The reason of this whole situation is when I was teaching internationally, I had someone from Nigeria, of all places, contact me because I was delivering CME and CPD courses. And when they did contact me, they said they can't afford the price that we put out to complete these courses. It was about $10 for a course, airway management as an example. So when they came to me and said this, I was like, but why? They said, if you convert the Nigerian Naira, I hope I've said that right. Thank you. If you convert that to the dollar or the pound, then it kind of gets to the point where it takes quite a big percentage of their wages. So I looked into it and I thought, oh, okay, that is quite a sustainable, not sustainable, it's quite an amount, substantial amount. So I thought, let's look at other countries. So I looked at quite a few other countries, which I'll explain now, but that's where it all started, where that one person, Cynthia, bless her, came to me and told me that. She let me know it's just too expensive. So going back to it, so people around the world are unable to afford a standard financial rate with the United States dollar due to their decreased currency rate. which can impact their access to attend online e-learning courses, resources, and live lectures to help them attain CME credits, which allow medical professionals to maintain their professional registration and improves knowledge of healthcare workers and delivery of patient care. So this is what I did. Step 1. We have to get to the old piece of paper here. A comprehensive search was entered into Google. Now remember, everybody, if you ever doubt anything, always go to Google. It's a good search engine. I highly recommend. Yes, yes. Multiple sites appear to deliver. Say again. Oh, do you? Do you have? Oh, okay. Fair enough. Fair enough. Bless you. Multiple sites have appeared to deliver online affordable CME courses in healthcare ranging from $5 to $20. Step 2, an extensive search was then generated through countriesoftheworld.com. That is a good website. I highly recommend. Lots of countries on there, where a total of 117 countries were utilized from this search, with 98 national currencies being taken into consideration. So imagine going through every single currency at that point of time and converting it from the US dollar. It took a long time, but I was devoted. I was determined, and I kept going. So after that, they were all compared to the US dollar from Monday the 16th to Friday the 20th of January via Google Finance. Again, Google, I can't recommend that highly enough. From there, each currency was converted from the median amount of the attending online CME CPD courses, which was approximately 10 to 15 US dollars, give or take. Step 3, it was then vital to find at the lowest average wage from each country. So I went to EMS workers because I'm a paramedic by nature, so it was a natural thing to do. And by doing that, I looked at their median lowest amount that they earn per month. I then cross-referenced what the 10 to 15 US dollars was, converted it into their currency, and then took it away in a percentage from their median to lowest wage. Again, this took a lot of time, but it was worth it. My findings are alarming. I know, yeah. So after that, I then went to a percentage calculator. Anyone that lost 5% or more of their monthly wage was placed in a yellow group. And anyone that lost 10% or more of their monthly wage was placed in a red group. And whoever lost below 5%, 4, 3, 2, 1%, remained in the green group of their monthly wage. The color-coded groups were used to help highlight the difficulties certain countries have in affording a standard level and sustainable CME, continuous medical education. So this is my groupings right here. Look at that. Look at all of them. It's a bit blurry, but each and every single one of them were the countries that I looked at, and these are all the countries that can sustain an affordable continuous medical education on their lowest average wage, median average wage. However, there was a yellow group and a red group, and that's what this area was here. And Nigeria is on there, and so is Liberia, India, Gambia, Congo, Bhutan, Bangladesh, and so on and so forth. So this highlighted to me that they are going to struggle affording sustainable continuous medical education. So we need to support them. You know, the other countries, the ones that have more money, the ones that have more access to resources, need to find a way to support them. And there are ways to do that. So the results from the currency conversion highlighted 18 countries in total that were identified where the average cost of CME courses would have a noticeable impact on the healthcare workers who work in the emergency medical services on their average monthly wage, with a total of 14 countries being in the yellow group, which included Algeria, Bangladesh, Bhutan, Congo, Dominican Republic, Gambia, India, Kazakhstan? Thank you. Thank you. Thank you. Liberia, Nigeria, Pakistan, Somalia, Sri Lanka, and Uganda, and with additional 4 countries being in the red group due to them being affected more due to their decline in their country's currency rates, which included Argentina. I was shocked on that one, especially with Coldplay going there live. I was very shocked. It was a good concert. Also Egypt, Ethiopia, and South Korea. So in conclusion, the healthcare systems around the world now require healthcare workers to follow the route of continuous medical education, to comply with their professional licensure laws, and follow the health system standards. Over the years, various models have been used to further support healthcare workers in low income and middle income countries, which included train the trainer models. So imagine someone from a higher income country train someone from the lower income country, a healthcare worker to a healthcare worker. Imagine then they train their team, train the trainer does work effectively. You got to pick the right people to do it with the right resources. Then you've got things like low dose, high frequency models. So low as in not much education, but higher, more times in doing it. So deliver more, but less is more, if that makes sense. That does work quite well, especially when people are retaining information. It does help. Then you've also got the multiple media training models, which, let's be honest, these days, you know, Instagram, Facebook, LinkedIn, we're all on it, I'm sure. Add me if you wish. I'm always acceptance of anybody on LinkedIn. That help build over on existing knowledge. And I do understand and appreciate where people come from when they say that when it comes to different learning styles, watching something or doing it online is not the same as doing it. I appreciate that. There are practical skill sessions, but you need a bit of all of them, don't you? And then work on which one is your strength. And the learner is responsible for that, but so is the person delivering the training. So build on their existing knowledge base and help further improve the patient's quality of care, just like the infection control. What do we do for infection control? Well, in the UK, we watch a video, we do an online learning, probably takes about half an hour, and that's us done for the year. You know, sometimes we may get someone come in with a hand wash thing. We might have a little infrared thing, and you know we have to wash and then come back. That's quite fun, but that's what it is usually. So, but it does help. It does help us retain and help with that knowledge that we already had and build on the pre-existing knowledge. Very important. So these are my references. And I also have a handout for everybody because I came here with a gift. A gift with, but basically, this is the handout. It's the organization. It's the organization that I work with that helps deliver CME courses to different healthcare professionals. There's a multidisciplinary team with them, and they all have different backgrounds. Their website's on the handout. I'm sorry it's a bit blurred. My printer was on the fritz when I did that, but I thought, you know what? I'm going to get what I can and bring it here. And that's what I did. Has anyone got any questions? There's always one. Bless him. My favorite part is the questions.
Thank you, sir. Actually, it's a question and a small story happening with me in Saudi Arabia.
Oh, okay.
It's for free and without my presence even know me online. So I was wondering about this. So I asked someone who is my senior in my department. So he said, for me, for sure, he is a hacker or someone that you will just get your money and then maybe block you. So take care about this. So actually, my question is, what are the recommendations for how we can deal with this kind of people? Because it happens a lot of time. I don't know about your country or our colleagues here with us today in their countries, but in Saudi Arabia, it happens with me more than one time. So what
Well,
are
I'm sorry it happened to you. I'm glad that you're, yeah, good. Always ask questions first, pay later. That's what they say. Well, all these CME courses and CPD courses should be accredited. And if they've been created properly, they'll be accredited by CME themselves. So if you've got people that have accredited courses, which are laid out properly and are accredited with the CME organization, they should be more trustworthy than people that say, I have these courses. I mean, let's be honest, you could literally write about this session right now, not mine personally, but this day, and that could go towards your CPD and your CME, because that's something you've learned, something you've taken from today to do with your continual personal development. However, to actually go onto a proper course that's accredited, that'll be something that they aren't really usually people that are trying to take your money if they've accredited the courses and gone through the proper, what's the word, channels? Is that the right word? So yeah, make sure they're accredited. Check the leaflet, they're accredited. Recommend me, get a discount, you know you want to. I'll back you up. We've got to stick together. Teamwork makes the dream work. That's what they say. That is what they say. So close.
My experience with the question of our colleague here, right? And we face this. He's right. We are facing this in KSA, and there is a lot of people without attendance. They can give you the certification, and it can be counted the hours. But it's depend. I think sometimes we are educating the people. It's depend on the people themselves also. Do not agree to give money without attendance. Okay, they are selling. People are marketing everything, and sometimes we are. It's not only the KSA. Maybe there is a person, the one who is selling the CME, maybe can be with any different nationality. So we are educating them. Do not pay unless you will go. And one of our strategy we are making in our hospital, when there is anybody want to go outside to take CMA hour, we are asking them for the feedback to give to all the colleagues in the nursing office, for example.
Feedback is always good.
Medical or surgical. That's gonna make them feel responsible about where they go, what information or knowledge they are taking, and they have to spread this knowledge to the people. And by this way, we are making sure they went not sleeping. They went to the course, but they are not sleeping.
Sharing is caring. Yeah.
Here, like for example, she saying like, please certification, what's for this and this, and I'm saying to her, there is a feedback. What did you change in your department? You are just going to take the feedback and the certification are coming. It's both sides.
Yes.
We cannot be accountable for that person.
No.
That is gonna be for higher authority. At the same time, we can educate our staff who's in the hospital.
Yes.
Should not go unless really you will attend. And you have to come and give me feedback.
It makes sense. Feedback is very important. And you do get course evaluations. It's how these organizations, there's always people out there that try and take people's money. There's always people out there that try and take advantage of people. They identify what someone needs or wants, and then they go in for it, like a velociraptor in Jurassic Park. However, what we do is if we follow the right channels, and we follow our organization, and we follow the organization of the CME or CPD, I don't know if it's like that here or in other places, then there are places that are accredited, and it's following those accredited places. And don't think that you need to do that just to continue your personal development. You can do it just by having a conversation. Me and Barbara could talk later on in the bar about, I don't know, falls, and I could write it down and say, well, I did 30 minutes on falls with Barbara. You know what I mean? Always educational.
They should take the course of PMD, regardless which country who is providing. I take it online. First of all, I take it online. I just did not still. I think the money did not come to his account still. He's saying to me, you are already processing? I said, yes. He's saying the certification can be sent to your email. I said, where is the material? Where is the material?
Where's the material? Yeah.
The most important. Yeah, it can be. So it depends on the person himself or herself.
I just have one more. This is true, very true. Now, education business. This is unfortunately business, and they pay and take the certificate for limiting just the hours. But there is a lot of free site giving the education material for free, like CDC, WHO, a lot of site. It's evidence based, but they require the attendee to take a pre-test, post test, and a lot of things to pass. Score, not to pass, and give chance 1, 2, 3, just to educate well.
Yeah.
Other side, just pay and take.
Yeah. Yeah, no, I totally get that. And also, you've got to think as well what you need as well for yourself. So let's say you're in a special department or special team, tracheostomies, for example. Yeah, so that's not the average or normal CME course that's out there. But if you can find a place that caters to that and works with your team and collaborates with your team and provides an effective education that you need and takes what you need and provides it to you in that way, I think that's really important. You know, the generic stuff works for the majority, but not the minority. And we have to think about both cases.
Yeah. Actually, you have to make sure, verify that it has been given by sure, like I'll give you an example. American Heart Association.
Yes, that's a good one.
We, if you want to go, if you want to take a course, you have to go to the American Heart Association site and look for the certified centers.
Yes. Same with the Research Council UK for the UK approved centres. But yeah, approved centres is good, and they're accredited. Thank you for that, Doctor. Excellent.
Now.
Thank you. I'm here till Thursday. Thank you.
So our next speaker, Dr. Nazia Osmani from UAE, passing her the stage to deliver the speech on. I'm sorry.
It's okay. It's all right. We're a team.
I'm sorry, Karen. I'm sorry for that. Yes. Good. No.
Pretty good one.
You got
I'm good. Yeah. Is it my first rodeo?
Yeah.
Of course.
Sorry, Cardi.
It's okay. I like how laminated they are.
Yeah. Thank you, Cardi.
Yeah, thank you.
So go back again. So, I'm passing the stage to Dr. Nazia to present on improving pain assessment in the emergency department and its impact overall patient experience in their pain management.
Hello, good morning, everyone. So nice to see you and so nice to be here. Thanks, Miss Amal, for bringing me here. So I'm Dr. Nazia. Can you all hear me? Okay. Is it fine? Okay, I'll use this. Yeah. Is it okay now?
Okay.
Can you hear me now? Is it better? Okay, I'll be a little loud. I will start to scream now. So I'm basically, my background is dentistry, but I have been in quality and patient safety for past 10 years now. So this project, improving pain assessment in the emergency department and its overall impact on patient experience in their pain management, something very interesting, something very wide, something applicable to all healthcare professionals. This was my first attempt in pain management. I'm a dentist. I know the agony of pain, you know, what patients go through. So this was the first attempt, and I have the plans of elaborating it in all organizations where I go. So how can I just, can you help me? Okay. So we will just talk about introduction, what observations, audits, what are our objectives, what is the methodology we use, data collection tools, surveys, results, and conclusion. Honestly, this was a very small, we just went out as quality doing our rounds, and there were some observations. This is what happens when you bring small improvements and then you notice the changes. It's like a chain, it does not just affect one person, it affects everybody around. So this is like small changes, huge impacts. So let's go. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of damage. This is the definition from International Association of the Study of Pain. It is often accompanied by emotional and spiritual responses, suffering and anguish. And effective management must include methods to address the responses. So very important thing is not everybody can communicate the pain verbally. Not everybody can tell you verbally, I'm in pain. This is so important for us as healthcare providers, that we know when an individual is experiencing pain. We should be very good judges in this. And then we should provide effective pain relieving treatments. Pain is always subjective, But as healthcare providers, we convert it into scores, right? We make it more subjective so that our treatment plan becomes very appropriate. So many people report pain even in the absence of any tissue damage, So never ever underestimate the psychological impact of pain. So pain, as we know now, is the fifth vital signs, right? In all our electronic healthcare records. I work in Suleiman Habib, by the way. I forgot to tell you. I'm the acting head there for quality and patient safety. It's one of the fifth vital signs. So when they unless they do the pain assessment, the system will not allow them to go ahead. So this is something we did in our medical records. So Joint Commission International, which one of the most famous accrediting body, not just we have a chapter on pain management, that is care of patient, which says that pain should be screened, assessed, reassessed. But we also talk pain in terms of patient right. It's one of the components of patient rights and ethics. NHRA is this project was done in Bahrain. We did it in Bahrain, King Abdullah Medical City, which is the sister branch of Suleiman Al Habib. So Bahrain is like a DHA there. They also strongly advocate for proper pain screening, management, and documentation, of the pain. So overall, we should understand that overall patient satisfaction depends upon factors, which means quick intervention, assessment, encouraging the communication of the tools. This is important that we don't just, we involve the patient in pain management, and reassessment and well-being at the time of discharge. So these are some of the things that we focused on in our project. So when we went around, we have these daily quality audits, we do audits, we do observations. So when I went with my team, we found that some of the patients, who are coming to our hospital with pain, they are not being reassessed. Okay. And this was proved by our, what is not documented is not done. And this was also, we did observations and audits. So this was proved by the observation that we are doing a good assessment. When the patient is coming, we are very good with them. We are asking for the pain, but after we are doing the treatment, we are not actually doing the reassessment. So we are addressing the agony, but we are not actually knowing whether the agony is really over. So this was the observation. And so what is happening? We have these pain scores. Mostly we use Von Baker's spatial pain rating or universal. Anything is acceptable. They are coming and they are leaving from a hospital with a goal at the time of discharge should be 0 or 2, right? But they are going with the pain scale of higher than 2. Why? Because we are not assessing them. We are not reassessing them even after giving the treatment. So what happens is that either they are coming back to our ER within 24 hours, or they might be having agony at home. They might be retaking the medications. They might be overdosing themselves. So this was an important observation that we found, which was confirmed by our audits. So when I'll talk about the data now. So what we did is that we took some of the patients, we went there, and all the patients who were given any form of analgesic, we checked their assessment and reassessment. So it was very low. You can see the compliance. This was for December. Sorry, I have forgotten to write the year there. This was for December 2018. So reassessment was just 35%. Or for the month of November, and 51%. It's very low, pain assessment should be 100%. It was very low. So our hospital, Suleiman Habib, we use VIDA system. It's our in-house electronic system. It's one of the hospitals who created their own electronic systems. We are not outsourced. We have very well integrated pain management tools. We have it, but our staff is not aware. Turnover is so high, right? So trainings are not done. It is not a part of the GNO or for the medical courses. Pain management, as we said about CMEs, we were just talking. Pain management was not a part of CME. So we found this was one of the reasons we found that staff are not aware. The tools are there, but how to use the tools, there is no knowledge. So what were our objectives? to study how well the healthcare professionals are educated and experienced to do pain assessment and reassessment using the tools at regular intervals, and giving the treatment which should be appropriate, timely, and efficacious. And also to study how improvement in the form of training, education, and adherence to pain management policy will have a positive effect on overall experience of patient in the pain management. This is very important. You are doing the assessment, you are doing things well, but what are you trying to achieve out of this? So this was a dual things. First, we try to train our staff. We try to make them good in pain management policy, and then to see the outcome of, we did a pain experience survey, how well the patient experience in pain management was. So the research methodology that we used, ER staff, nurses and doctors of King Abdullah Medical City, Bahrain, were given a briefing. Sorry, why is it going so fast? Huh? We're given a briefing about this one. So they were given a briefing about problem by presenting the data. So this data, which I just said, which was very low, less than 50%. And we discussed that we will do a focus PDCA, the most favorite of all quality professionals. We like focus PDCA. So I'm sure you all know about it. It's find a problem, organize a team, then clarify, understand, and select process to improve. And then we do plan, do, check, act. Fortunately, our staff are very well aware about it. So it was a very collaborative project. So what do we want to know? We want to, as I said, our assessment process was very good, but the reassessment, especially when we give analgesics, it was not proper. They were not doing it well. So we set out indicator that we will be measuring the compliance with pain reassessment for all patients who were given any form of analgesic. And then we have a numerator, denominator, the total number of patients where reassessment was done after analgesic was given, and total number of patients who were given analgesic for that month. So our exclusion criteria was patients who came with a pain score of 0 and unconscious patients. They were not a part of our project. They were excluded. So data collection, reassessment. We have, as I said, we have a very well integrated comprehensive pain management tool based on needs, convenience, and scope and educational level. Actually, in our VIDA, we have a graphical, I think most of us have now, graphical representation. Once a staff does pain management, it comes like a line graph with time intervals. So everything was very easy. We were easily able to capture when the staff did assessment, when she did first reassessment, when she did third reassessment, and at the time of discharge also. So the process data collection was very easy because our system had an automatic style of capturing everything. But and also we then went to our policy. We had a very comprehensive policy. This part. Okay, reassessments, So how often you will do reassessment? So if you are giving oral medication, it should be done within 30 to 60 minutes. If it is IV, 15 minutes, IM, 20 minutes, subcutaneous 30, and rectal 60 minutes. So these are evidence-based reassessment. How did we do the scoring? How do you know that you are doing reassessment or not? Any reassessment delay of more than 15 minutes, we were a little strict initially. We said, no, you delayed for 15 minutes. You did the reassessment, but you delayed. No, I will not consider it. As I said, our system had an automatic style of capturing everything. So for example, if we had given an IV analgesic at 9, reassessment was very clear cut for us. So medication 9, reassessment at this time. And also any patient where pain scoring was not done at the time of discharge. This is very important. Our goal at the time of discharge should be 0 and 2. This is universal. So, no, you did not do reassessment at time of discharge. We are not going to give a score. We were very strict initially, to implement the policy very strictly. Next, very important was survey questionnaire. Now it's impact on patient. Okay. So we did a kind of brainstorming. Actually, for this project, we did not do a lot of references. We do not go to hi-fi patient experience tools and all. We sat together and we decided what is important for pain. what are the tools or what are the elements that we should involve in these experience surveys? So simple. When the patient is, ask the patient in his own language. So when the patient is coming, does he have pain was number one. It was just yes or no. How well does ER staff respond to their pain? So was it immediately, timely, delayed, or no response? Was the medication effective to relieve their pain in their own language? Simple. Highly effective, average, not effective, pain became worse. And how often the staff talked to them about their pain relief? Was it very often, regularly, hardly, or not at all? And on discharge, were they given any form of education? So this was an unintended benefit of a project. Our staff, how well they're educating the staff, our staff, how well they're educating the patients. And last, how was the overall experience with how your pain was treated and managed in ER? So really, this was just brainstorming. We did not go to any hi-fi tools. We just discussed what is important for the patient. We included some of the patient in the surveys. We asked their opinions also, what is important for you in the pain management. So this is how we created the survey. So what patient feels about, as I said, we involved some patients also. When we created the survey questionnaires, as you know, in quality and healthcare, patient involvement is very must. So some of the feedback we took for them. So we created this 6 questionnaire. There were a lot of questions, but we did not want the survey to be too long. And the survey was based on this questionnaire, and we carried it for 2 months. January 2029 and February 2019 and Feb 2019. So initially, we started the project in 2018. Then for 6 months, we did some education. Then we did the project in next year. So we put a span of at least 6 years for the things to happen. Now, this is some of the interventions I will talk about. We created a program for nursing that they will have everything was in our policy. We had all the materials. So, we have 8 specific tools. So this is some of the 8 specific tools. Everybody's aware, nursing, must be so aware about it. So if it is neonate, what tools you will use. If it is an infant between 3 months to 1 year, the tools that you use. Developmentally delayed child, children between 3 to 14 years, verbal adults, and non-verbal adults. Mostly our focus was on Warren Baker and Universal because it was an ER, and so all the ER staff attended the lectures based on these pain management policy and how to document the patient score in electronic medical record. The nursing staff established this pain management competency program in their GNOs. Now we started it formally in the general nursing orientation. And what we did is we taught them about the data collection tools, and we assigned one of the staff will only on Thursday, she will just work to collect the data, just to make this project very practical and not to fake the data, So this is how our, strategies were based on. And also, again, these pain assessments, adults and pediatric, what it is. In pediatric, I hope many of you must have worked in pediatric sessions, how tough it is for a pediatric pain to understand their pain management and to understand the assessments. So these tools were taught not by me, I was just a coordinator, but we brought the the nursing educators and also from physicians side. So these were some of the tools that we implemented, which were there, but we made them more rigorous. And then important thing is about what we found. I like it. It's very nice. Warren Baker or FACES scale is that this is one of the most widely used scales, which was made for kids, but now it's so good that it's even we use it for adults. Important thing is that this tool must be understood by patient. This is important. Our staff was not aware. They thought they will just look at the patient and put the score. No, your patient should tell you the score. You should get him involved. So it's not a tool to be used by third person. It's not a tool to be used by a third person, parents, healthcare professional, or caregivers to assess the pain. So this is an involvement of the patient in the tool. This was some of the educational pamphlets we created. We put it in the ER department. We made them, very well aware about the policy. So let's go to the results now. So this is what is happening. As I said, our data collection was a very vigorous and valid. We created two people where one was collecting the data and the validation was happening. So you can see how the statistics are going up. So we are reaching from a dip of 37 to 95%. Our aim was 90%. So yes, so there was an improvement. Now for this improvement, what is the outcome? So for that, as I said, was based on our patient experience survey, right? So we did a survey also. A total of 553 patients responded to the survey, which 580 were given any form of analgesic. So as I said, in our questionnaire, we only took patients where we gave some analgesic. Okay, so the response rate was 95% of patients responded. 58% of patients were females, while 47 were males, and 84 were adults, and 18% were pediatric. In Bahrain, 15 below 15 is the age for pediatrics. And the survey was, as I said, done in the 2 months. We did the survey. So let's go to the results. Are we really doing well? Did we really achieve anything? Let me tell you the flaw of this study is it's going so fast. And this is important slides, no? It's going so. These are important. These are the
time. That's okay.
Okay.
Yes.
So there. So one of the flaws of the study is that we did not do any experience survey before the interventions. Yes. Now, when I do the next project, this will be very important. We did it after, and we are claiming that, yes, we had great improvements, but we should have the preliminary results also. So as per our survey questionnaire, when you came to ER, did you have pain? Yes, 100% of patients had pain. How well did the ER staff respond to your pain? So 72% are saying timely and 20% are saying immediately. Out of this, 5% saying delayed and 2% are saying no response at all. So we even had patients after trainings and after interventions who are saying no response at all. So also, was medication given effective? Yes, 70. It was highly effective is only 17%. Average was 77%. Not effective at all was 4%, and pain became worse was 2%. So how often the staff talk to you about your pain relief? It was nice. The results are nice. Very often 44%, regularly 52%. Hardly 0%, not at all 0%. And on discharge, very important, the most important effect of this project was education about your pain management and use of pain medication given at home. 97% said yes, and only 3% said no. And the final one, summary, final one. Overall, how would you rate your experience in how your pain was treated and managed in our ER? So we have good statistic, 38% said good, and 46% are saying, 38% are saying excellent, and 46% of patients are saying good, fair 12%, and poor 4%. So results show that pain assessment is comparatively better as staff is more trained and experienced in using pain assessment tools and familiarity with policy. Since no initial data on pain experience on pain management was available, so we cannot definitely state that these positive responses were the result of the improvement project. However, most patients are giving positive feedback, especially how often they, staff talks to them about their pain relief. 52% are saying very often, and 48% are saying regularly. So this is clearly an indication, because our main goal was reassessment. So in patients' words that they come very often, they come regularly, that means pain reassessment is working for us, right? Also, 97% of patients agreed that they are given education, which was one of our goals, that at the time of discharge, we have to reassess the pain, we have to give them education. So 97% of our patients were educated at the time of discharge. So these are some of the unintended benefits of this improvement activity, which brings us to conclusion that educating and training the staff also means making patient aware about their own care. And overall patient experience with pain management was 96% positive, along with the fair. Okay? So yes, I'm saying all these efforts did lead to a good impact, although I'm saying the preliminary experience survey was not there, but it's clear, we are seeing some benefits. So conclusion is, taking into account the overall results, it's possible to conclude that pain management is related to assessment. It's a very critical step in overall pain management. Patient's description of pain, which is different for adult and positive, is very important in assessing of pain, and this can be put into practice by using pain assessment tools, for which both medical and nursing staff should be well trained based on the age-specific competencies. And pain managed assessment at the time of discharge, which I said was one of the important goals of the project, is significant in ER, as not properly patients may feel agony at home and might come to hospital, leading to inconvenience and emergency crowding. And pain reassessment after medication will make the care safe and prevent under or overdosing. Because as I'm saying, if we don't reassess them at time of discharge, they will go home and take another paracetamol, right? Take another medication. So we are ensuring we are not overdosing our patients. Nonetheless, in spite of there are, as I said, the initial survey was not available. Also, what I found is we only were focusing too much on nursing. Everybody is involved in patient. As a dentist, I know how important pain assessment and reassessment is for me, but our focus was on nursing only. Doctors, they were there initially with our project, but then it was nursing who was doing all the great job. So when I start this project again, I will ensure that every healthcare professional is involved in pain management and assessment. Thank you so much. Thank you very much. I like Nietzsche a lot. He's my favorite philosopher, so I'm quoting him, that the thought, even a possibility, can shatter and transform us. And I have learned it in quality improvement, that how small things can do such big things. Thank you so much. So I'm ready for any questions.
Thank you.
Yes.
And to organize questions.
Hi.
Hello. Hi.
Thank you for your presentation. So pain needs to be subjective when it comes to pain assessment, and when it comes to healthcare, we try and take on an empathetic approach. Like holistic model, for example, we treat whole person. Yeah, different parts, emotionally, physically, mentally, spiritually. So if we do that with pain, we're not always getting the proper outcome we need, the proper answer of how much in pain they are, because everyone's threshold is different. We can't put ourselves in their shoes, because if we do that, our threshold would be different to them, so we're not getting a proper score of that. So I'm just wondering, when it comes to people with cognitive problems, issues, dementia, and stuff like that, you mentioned the one Baker for children. What is used? Because I know there's a model that we use, but what model is used here with people that you can't ask the question, what's your pain score from 0 to 10, 0 being pain, 10 being the worst pain? Or can you pick one of the faces which describes how you're feeling? What is the model that you would use for those type of patients?
We have this FLAC. I'm not a pain management expert, but this was done by our team there.
Yeah.
We have a model, non-verbal adults. So it's like their movements, their cognitive abilities, how they are responding, assessing the psychological behavior. Because some people might be in a lot of pain, but they will not show you. You're right.
That's true.
That's true. Yeah. If you go to internet, FLACC, check this, please, and you will have a lot of idea on this. There are many different. There are new tools that are coming. Yeah.
Someone called Frank. Let's go with that. And he has something called LaugMD. Yeah, and that was to help with pain as well. It's been some really good results. Like people creating an algorithm, someone that looks at their what makes them laugh, and it relieves pain that way. A bit like Patch Adams. That was a great movie. Thank you.
Thank you so much. Thank you.
The argument wasn't the
Thank you so much for that excellent presentation. So I just wanted to touch upon, an observation sort of that I've had. I've had some experience in the US and I'm based in Qatar currently. And I find that there is different cultural attitudes toward how much you should treat pain. So, for example, when I was in the US, like zero pain was tolerated. You would do whatever it takes for that patient not to be in pain, including giving opioids, etc. Now, where I work, there's a lot of strict control about like opioids and things like that. So I was just wondering from your experience, like in Saudi Arabia, how do you feel that there's any role to how much people will go to treat pain? Because what's the point of assessing the patient if you can't actually make them pain free? Like, is there ever a limitation in how much pain treatment you can get?
Very interesting question. You are so right, because pain is so subjective for a patient, and what we are doing, we are converting their subjectivity in our scores, right? So as you know, Saudi Arabia and UAE, we have very strict policies on control medication. If you go to UAE policy, semi-control and control opioids. So it is assessment of patients, of doctors, and also the privileging. Not every physician can, prescribe opioids. So for example, a patient is coming to ER and that physician does not have the privilege to give opioids, so will definitely treat with a non-opioid treatment. So it depends on physician's assessment more than what patient wants. Yeah, it depends on how a physician is assessing him. Mostly we depend on him. Do you agree, ma'am? Do you agree? Yes, yes.
There is always a chance to go for that management. It's always not the first choice to prescribe medication, because always with medication there is complication. Like for example, if you want to give non-steroidal anti-inflammatory medication, you have to give it for a short period because of the complication, the renal impairment. Now, like for example, with rehabilitation, we are trying to give the conservative chances by doing exercise, moving the muscle, doing strengthening. Those also should be. And another thing, like for example, some patients are given pregabalin, for example, for their pain. After some time, after 1 week, itself pregabalin will lead to pain. So I will not go further in those medications, but I just want to reflect the idea that not all patients should take pain medication.
Yeah, especially opioids. I will give you a good example. One of the patient was so addicted to opioids that when she was prescribed Brufen, she said, I'm allergic to Brufen because she had addiction. We have to understand their control and semi-control. If you give them opioids for small, there is in some hospitals, they say give medication only after the pain is about 6. In other, they say give it after 2. So the practice is varying depending on pain score. But opioids, I would say, should be very much restricted and not given in ER actually. Yeah.
Sorry, just one last thing. You already mentioned that the input should be taken from all the staff involved with the treatment.
Yes, yes, yes.
It's not all the nurse. So how you're going to have the input from the other staff? So there is a chance for them to have. There's a way to do.
Yes, if you see the electronic medical record, everybody has patient assessment and reassessment in their documents. Physiotherapists, dentists, everybody has. Yeah. Thank you so much. Thank you.
Thank you very much for your presentation. Can you give me the chance your appreciation certificate, please? Thank you. Thank you. Thank you very much for your presentation. So now my next speaker will be Miss Amal Ibrahim, Jordan. I'm passing her the stage to deliver the speech on stress factors, stress levels, and coping mechanism among university students.
Thank you, my dear Sahar, for the introducing myself. Hello, everyone. It's a great pleasure for me to meet you in person finally.
all. My name is Amal Ibrahim from Jordan. I am the Middle East Organizing Secretary at UCG. My background is a master's degree in health management and policies and a certified professional in healthcare quality from the National Association for Health Equality in the USA, and also a certified in healthcare project management from the American University in Washington, DC, with working experience for more than 10 years in KSA and Palestine. As we all know, Palestine is facing a bad economic situation all over the world. And for the last 18 few months, we have organized and launched a healthcare project collaborated with the University of Jaén, a Spanish university, to address the chronic disease in Palestine. And we have three main pillars in that project. The first one is to prepare an official documents for chronic disease protocols to be officially applied in our association. It was the protocols for diabetes, for hypertension, cardiac disease, and mental health too. The second main pillar was for educating the healthcare professional how to apply these protocols in our clinics, how to deal with emergency and important patients facing this disease, and also educating the community. The target group was elderly, men, women, and teenage, because we are believing with diversity. The educators was men and women. We have done more than the planned number of courses, because the interaction was very amazing between the educators and the Palestinian community. They are being more aware about their situation. For example, we have many of kids, they are know about their situation, how to deal with their treatment, how to go to follow up about their treatment, and without any feel of stigma or denying that they are facing these chronic diseases, and encourage their community to attend these courses and to follow up this treatment. My speech today will be about stress factors, stress levels, and coping mechanisms among university students. It's a study done by Sultan Qaboos University. It's the first only national university in Sultanate of Oman. I would like to thank Prof. Dr. Umar Al-Umari, who's the one who gave me this great opportunity to be a co-author and helping in writing this study with them. Okay. As we all know, stress is a common feeling that all individuals coping through life. And also, it's imperative to comprehend the way of coping the stress. For the university students, according to the main demanding courses during their journey of study, they are coping a lot of kind and a lot of level of stress. The main important question here is why it's important to manage stress and learn coping skills. Because the video is not working, so I would like to hear the answers from the speakers and the participants. In your opinion, why it's important to manage stress and learn coping skills? In 1 second, please.
I think stress is affecting the psychological status. And psychological status can develop physical diseases. And if we manage the stress, so we can avoid ourselves to have the major diseases, for example.
Great. Is there another answer, or we will move to the next slide? Okay, as we all know, mounting evidence supports the belief that university students experience moderate to high level of stress. The interplay between biology and the environment renders vulnerable adolescents and young adults to experience stress and distress too. During our research, we have found 3 predictors of stress among university students: individual factors, environmental factors, and coping factors. Okay. Great. Can you hear me now? Perfect. For the individual factors, the main factor was the personality traits. A study done was found by a researcher named Ritu. He found that students with high level of neuroticism characterized by anxiety and bad thinking reported high level of stress, also a high level of bad mood. Also, these students who introverted to have the tendency to move from social support, from social interaction, have a high level of stress, less than or in the opposite side for the one who are extroverted and enjoy social interaction. For the environmental factors, we have 4 variables that included under the environmental factors was specialization, social support, living situation, and also campus resource. An important research done by McLean found that students who have high level of stress is associated with lack of family or peer support. Also, a meta-analysis was done, found that students or individuals who have a high equipped campus resource and a very excellent access to mental services have less level of stress or bad mood. Also in this study, they found that the main factors that positively associated with high level of stress was smartphone and sleeping hours. The main predictors was the coping factors. For the coping factors, it refers to the coping strategies that individual can express their stress, express their bad emotions. Okay, in this research, the students who use evidence coping strategies. For example, substance abuse or denial have a high level of stress. When we make the comparison with those who have post-coping strategies such as seeking social supports or also engaging in physical activities. Also for the coping styles, a great researcher called Amir Khan made a tripartite model coping of a strategy and have 3 main pillars. The first one, to know the problem, to seek the support, and to try to avoid facing the problem. I will repeat again. The first one is to seek support. The second one is to try to solve the problem. And the third one is to try to avoid facing the problem. The purpose of the study was to explore university students' stressors, and coping style with the aim of resolving the following: level of stress among university students, types of stressors they face, their coping mechanisms, the relationship between the level of stress, some academic, health-related, and social demographic variables. In the methods, a cross-sectional correlation design with a convenience sample of 676 of university students who completed the students' lives stress inventory and coping stress indicators was used. Eligible participants were students who met the following inclusion criteria. 1, they must be registered in the university and read and understand English. Failure to respond to more than 20% of the items was one of the exclusion criteria. A random sampling test were used, and also the study was done by 8 colleagues in Sultan Qaboos University. In the data collections, researchers conducted the public relations department to email the students who meet the inclusion criteria by sending them the survey, and the survey was opened since between the period 10 to 20 December 2021. For the outcome measures, we have used student life stress inventory using 40 items in the self-reported survey and the coping stress indicators by including 33 items. Okay, and we analyzed the data, and in the finding, overall 2/3 of the participants reported moderate level of stress. Students with chronic illnesses living alone low GPA and having exams today experience a statistically higher mean level of stress. And also, students who are living alone use the avoidance method more significantly and the social support method significantly less compared with students who are living with their families and friends. In the conclusion, this study concerns with others that university students are prone to distress. First study in the region to explore the study coping skills. Some of the employed coping and associated factors could be used to lay the groundwork for evidence-based prevention and mitigation. Okay, the video is not working, so I would like for all of you to imagine that if you are a medical student, how you can manage your academic stress. Who will be the first volunteer to answer? Yes, please, Barbara, can you share with her the mic, please? Okay. Okay. Who else? Mm-hmm. Okay, of course. Great.
Always articulating. Thinking of this can make anything easier.
Anyone else? Yes, yes, good sleep. Because also our students comment that traffic, construction work, and loud noise, they increase their level of stress too. And also in socioeconomic status, physical appearance would make their level of stress is low. If you want to know more about our study, you can see it in Hindawi website and also in the Medical Library of Medicine. Thank you for listening for me, and if you have any questions, I'm open to answer it.
Thank you.
You are more than welcome.
Any questions? I don't have one. It's not a question. When was the study? Just before my comment.
Okay, we have started the study on December 2021.
This is similar project to what of my graduation project students of fourth year in nursing. They did on the same year. It was in Roman College of Health Science. We did it in SBU. It was the same similar. We did a similar study among the students in specialty of nursing as part of the graduation project. And what they came up with when we found with the relationship between the stress and the demographic data, one of the most important things came with us is whether they were interested to go in to be a nurse.
Of course.
Because some of them actually they got by force, some of them unfortunately, others because they thought it's giving them opportunity to be employed fast. When we came to the coping strategies, they identified 4 coping strategies, which were, as far as I remember, the avoidance, either to avoid,
of course,
being stressed, avoid the problem, so avoiding being stressed, or transference, where they transfer maybe to a physical, going to gym or somewhere else, dancing.
Of course.
They were all, one of the good things which they came up with, the problem solved. It was interesting actually, because when we further investigated what do they mean by this strategy, they said we are actually facing lots of stress. So what we are doing is to list the stress, prioritize them, and then we choose the most important where we need to hit on, and then work on it. So those, I cannot remember the 4th strategy. I believe it was the avoidance, transference, problem solving, and something else. Unfortunately, I cannot remember the 4th, but this was really very interesting.
Thank you very much for your informative comment. In my opinion, I believe that the passion, their own passion, it will be decrease the level of their academic stress. You're more than welcome.
Nursing student, only taking nurses and nurse situation. These are definitely different from the student. Student need to pass exam, employment, other work. During the pandemic, we see a lot of stressor facing in nursing. Some of them depressed, some of them died, some of them a lot of things. It's bad impact. So all the organization go to well-being program for nurses. Why you didn't think of nurses in hospitals?
Actually, it's a great question. The first level of our research is to focus on the university students. The next level of the research, we will focus on the nursing in the working industry. Dr. Wissam.
Thank you, sir.
You're welcome.
I always talk to my student, say, why you are under stress? Then always use the same phrase. I was put in this college. I said, what put me in the college? It's unknown. They said, no. My family forced me to enter this college. This is not my wish. I want to be an engineer. I want to be something else, a designer, art school, whatever it is. I think this is an additional factor. And the whole 6 years of studying, you can see this or these student or this group of students will not have coping factors with the university study. They will be always under stress.
Of course.
This is not the stress that they enter the university or the college of medicine, but also the stress of graduation, the stress of being successful in the college, the stress of being a good physician.
Of course, yes.
The stress of being a good specialist. So the stress will be all over their life because from the start, it was not their wish.
Of course. You are more than welcome. The main important thing that their deep passion, and if they have a great peer or family support, they will be facing less level of stress. So it's the important thing is passion and family support. Hello.
Regarding the stress, when we are hearing stress, some people they are saying like stress is everywhere, nursing, medical, or whatever. So the stress we can expose to the stress from any.
Okay.
They don't do the cancer because anger and stress can increase the cell deviation inside the body. Can reach to the cancer. So it's a really interesting topic.
Yeah, thank you very much. Thank you for listening, and thank you for having me today.
Thank you.
You're welcome.
Presentation, I don't believe stress is here. You have to manage that inside. Each inside and outside, always positive and negative function. Okay, thank you very much.
Welcome.
Thank you.
Now, I welcome Ms. Ru'a Aman from KSA. I'm passing her the stage to deliver the speech on the impact of presence at work. Thank you very much.
Assalamu alaikum. Good morning for all. And first, I am happy to be with the UCG, and thanks a lot for organization in UCG and in 12 of conference, nursing, healthcare, management, and patient safety. I am Ru'a Aman from KSA. I am from Irada Hospital, Psychiatric Hospital, clinical nurse, nursing educator, research mentor. I'm working in education departments. Today, my subject, it will be about impact of resilience at work, especially after Amal, she said about the citrus. Now we need resilience. It is important or not? It's important. There is no just from here. Okay. Why is resilience? It is important in the workplace. We need it, right? Must be, especially we are as a nurses or in the medical health, in everywhere of our life, we need for resilience. Workplaces are often over-changing and stressful environment, and in the challenge they present can truly test a person's intensity. What interesting thought that is in some people not comfortable ride out these waves of difficulty, but they even find success in them. Resilience in the workplace, what are the benefits and how can environment work in that one? How to be developed as we are in the workplace and in the leader as employees and share in the staff friend, how it can be work in that. What is resilience? Personal resilience refers to how effectively you handle difficult experience in your life. It is often described as the ability to bounce back and comfortably carry on the midst of adversity. It is also involved being able to effectively regulate your thought and emotion, as well as receiving challenging situation as an opportunity, not personal threats. Resilience enable positive approach to work and outlook on life, which in turn enable better problem solving and help to maintain motivation. Why is resilience important in the workplace? Making people more motivation, capable of dealing with change, and less susceptible to burnout. It also improves employee overall health, as resilience and well-being in the workplace are closely linked. Better mental health means, and it will be less absenteeism and presenteeism, and in turn improve people performance throughout the workplace. A study carried out by CV Library revealed that 57% of employees see resilience as key skill for candidate. Meanwhile, 71% viewed that the ability to adapt as a key skills, which is a core aspect of resilience. These results reveal that business place high value on employees who demonstrated resilience. in another report showed that NHS staff are 50% more likely than the general public to experience work-related stress, with 44% of NHS staff reporting feeling unwell as a result of side effect of side stress. This, and from the reviewer from 2011 to 2018, they coming to be done the research about the exploring of the employee resilience in the workplace, showing that also how it will be that resilience, it is important in the work. And since of the COVID-19 pandemic, we higher rate of mental health symptoms among care worker. It is also reported that with those with history of mental health condition were most at risk. Common reason for burnout and sad work include unfair treatment at work, having an unmeaningful workload, a lack of role clarity, a lack of communication and support from managers, and reasonable time pressure. Where staff resilience is poor, where there are often more problems with sickness absence, slow working, and ineffective communication between patient and staff. Therefore, one of the key elements to maintaining the quality and safety of care is through building resilience in healthcare professionals. Due to multifaceted nature of the nurse resilience and competence, exciting when exploring the associated factor in the literature, some studies consideration that ecological network, self-care, and motivation contributed to resilience. And however, it is unclear whether age, experience, education, or years in nursing contributed to nurse resilience. It is also ambiguous whether social resource, family, friend, or poor support, physical activity, personal belief, or work environment, lack of control, and workload are key factors associated with resilience. And these reported in between 2015. The National Institute of Occupational Safety and Health stated it is anticipated that nurse work-related stress will increase in the coming years, and this should be addressed because the deep impact has in the workplace will as a later consequence, such as a job burnout. Job burnout is mental reaction against some presented sources of workplace stress and is more common in healthcare professionals than in another job category. It is a result from interaction of multiple factors, including personal, interpersonal, and occupational factors. It can have negative effect on nurse, patient, and healthcare provider system. Despite the importance of resilience in health and social care, it is currently a skills gap within employee. Where staff resilience is poor, where there are often more problems with sickness absence and slow working in effective communication between patient and staff. Therefore, one of the key elements maintaining the quality and safety of care is throughout building resilience in healthcare professionals. Example of the resilience worker can be recognized by a few categories, including their ability to engage with and utilize others for their own support and development, their composure and management of negative emotion, their use of control whilst accepting external control, their ability to learn from past experience, their aggressiveness and communicated to their role, their coordinated and use planning, and confidence and self-efficiency. How can health and social care employee help to prevent burnout? Creating a realistic,
composition, open team culture, and have an honest conversation with employee without conflict, being vigilant and alert to risk, as well as monitoring any potential indicator of burnout, having regular managed time out to discuss problem and the work-life balance, shared responsibility to identify source of stress and put appropriate measure in place, having a clear support and confidentiality policy, as well as access to external support service, ensuring staff are registered with a GB. The pandemic has composed issue and point of continuing workplace, including homework space, leading to lower job specification and burnout and poorer worker-life balance. For here must be all the time alert about ourselves and our employee and staff. Here some strategy for building resilience skills in healthcare professional. Requirement beside in-person value through indication and onboarding process, having stress management resource available, encourage learning and development, organize health and well-being initiative, working in way that protects as the well-being of your staff, raising awareness of stress and how to manage it, ensuring systems are in place to identify, investigate, and resolve a problem. Strategy for building resilience, dealing with pressure through relaxation, technique, mindfulness, self-care, and time management. Development team working skill through communication and emotional intelligence. Development problem solving and critical thinking skills. Also engaging in reflective practice, seeking and utilize sources of support, developing self-efficiency skills such as self-awareness, confidence building. How to be resilient? Must be optimism, self-belief, control of self, willingness to adapt, willingness to be flexible, ability to solve a problem, emotional awareness, social support, sense of humor. In the conclusion, the results show that the nursing working under influence of various factors, including job position, type of employment, one perception of unhealth status, history of illness, and job burnout. Health manager and policymaker can benefit from these findings to promote the strategy for enhancing the nurse resilience and ultimately improving the quality of nursing care. Further research on resilience would help nurses better cope with workplace challenge, increase their capability, and reduce vulnerability, establishing a consistent measurement framework would assist research to compare the results from different studies to draw robust conclusion from improving nursing resilience. Additionally, development intervention should target nurses to assist in strengthening their internal resource and attenuate the effect of workplace adversity to stay in the nursing workforce. Building resilience in healthcare professionals contributed to positive workplace morale, high quality care, and reduced risk of staff burnout. Florence said, I will face rejection and failure with courage, awareness, and persistency, making this experience the platform for future experience and success. In the end, relax. Your heart is stronger than what you think. Thank you.
Thank you very much, Mr. Ron, for this presentation. Any questions?
Yeah, thank you very much. It was very knowledgeable feedback. I would just like to ask, like, recently we were using like kind of press scanning and the staff satisfaction feedback. So during your all the research, are you using any tools like that in that the confidentiality of the staff will not get disturbed and they are more confident? Because so far even the managers are not involved in those kind of survey, and those surveys are more supportive in a kind like you can more open. Sometimes the burnout process is not that easy, even one to face challenges, you know, with the managers or other kind of like management. So is there any kind of tools available right now recently where like press scanning or something, the surveyor can help the staff to release their stress, or they can help in the, like in the future even?
And from our this studies, and actually still we have this research not done, but this one as a project done now from reviewer literature and studies. And we started first from the last year after COVID pandemic, we started a clinic of well-being professional to have for this staff need supporting, or what we will see if there is from the head nurse, or it can be said for him, go to this appointment to sit with the psychologist, and we will see how it is going if there is any problem. And there is also the workshop done about how stress management, and there is a quiz also done for the staff about resilience, and this will open culture inside the world. It will be more benefit for all the staff to reduce this burnout and how to be more resilient in the work. And there is tool. If you want me to sharing with you later, I will give it to you. We are now planning to done, and also how to be use it.
Thank you.
Thank you for the interesting topic.
ये recording कैसे कर रहे हो?
Yes, we all agree that during COVID, resilience was somehow forced on because of the patient practice. But let's say if I don't know if you agree, in a toxic or let's say inefficient workplace, do you think that resilience is a source of burnout? As if I'm saying to myself as a healthcare worker, let me cope under the title of resilience. So what do you think about that?
Can you repeat the exactly?
Okay, so I'm saying that the resilience management can be different organization. Now, if the organization culture was inefficient or the toxic,
yes,
and resilience management in a very healthy environment. Do you think that in a toxic or inefficient environment, the resilience will be a source of burnout?
Must be, yes. And the resilience also coming from ourselves. If you have also this, as I said here, must be, all of us must be have these sources for resilience. And also the atmosphere or environment of the work also need to be built this one, resilience. We are all professional, all of us to deal in, and we know, and we see after the pandemic, we have too much this resilience going on in the
Yeah. You want the answer?
I don't have just touch for question regards burnout measurement. I'm interested in this topic. Burnout essentially to be just. For burnout, there is no measurement yet. So you can use some administrative questions questions, starting from one question to unlimited questions. Your goal to measure the transition to lead the country.
Delegates authority. I think they can externally management. Very confidential, and it must be delegated from some delegate authorities. For example, DOH. DOH can they can rectify very easily why your organization is beginning with the inside infrastructure organization your employees. So that's very confidential platform, and your employee confidentiality is not being disturbed. And moreover, in the upcoming days, they can platform some kind of suggestion to improve the well-being or some kind of thing. That's what within UAE we are experiencing.
Thank you very much. Now we'll be going to our next speaker. First, yeah, is your certificate?
Thank you.
Thank you. Can you come? Thank you very much. So now I'll be presenting my next speaker. My next speaker is Dr. Noor Al-Khouri from Qatar. I'm passing her the stage to deliver the speech on the ACR appropriateness criteria, a guidance step towards evidence-based imaging.
Good morning, everyone. Can everyone hear me okay? Do you want me to talk louder? In the back, do you want me to talk louder? Okay. So my name is Noor. I'm based in Qatar. I'm a radiologist, which means I'm a physician who's specialized in imaging. A little bit of the different topics. I'm going to be discussing appropriate imaging, specifically the ACR appropriateness criteria. So first of all, I'm sure many of you interact with radiology or order tests for your patients, or, you know, I'm sure there's a lot of interaction with the imaging department, which is why I think it's important that everybody's aware of what it means to have appropriate imaging. Does anyone have any guesses what it means? Can anyone? Sorry?
It aids diagnosis.
It aids diagnosis. Okay. And what do you mean by proper radiology?
Yes, the tablets, the reading.
Okay.
Intervention.
Correct. And how do we decide what's the proper test?
Based on evidence-based.
Evidence-based, excellent. So this is the topic of today, and I'll be just sharing with you some evidence-based guidelines that you can use, and you can, you know, share it with your teams. in order to improve imaging for our patients. So first of all, we'll be talking about the background. I'll be sharing with you an example of how it's used, and I'll share with you some impact that it has on quality and patient safety, because that's the theme of this conference. So first of all, I just want to define what is appropriateness. So the RAND UCLA appropriateness method user's manual, which is a sort of a healthcare quality and patient safety document, defines appropriateness as when the expected benefit of a procedure outweighs the negative consequences. Benefits can be, for example, relief of pain, increased life expectancy, the correct diagnosis that we mentioned, reduction in anxiety, improved patient care. Negative consequences can be morbidity, mortality, anxiety, pain, time lost from work. Negative consequences can also be a waste of time. So oftentimes we do imaging tests that are a waste of time. And especially after COVID, this is something we should pay attention to, because when our staff is doing something that's not useful or not indicated, that takes away the resource from patients who need appropriate or indicated things. So we have to be very careful about what we do in imaging. And as I will talk about, a lot of the imaging that we do involves a lot of risk on the patient, okay? And of course, the benefits and harms are decided by evidence-based guidelines that we set. So why do we have inappropriate imaging? So what are the reasons behind us doing imaging tests that are not appropriate? So there's several reasons. So first of all, sometimes because the technology is available, we're tempted to use it. Oh, we have a new MRI machine, let's use it. Let's order MRIs, for example. A lot of times, especially in the US, there's what's known as defensive medicine, where doctors are afraid of getting sued. So they will go and do every single test for that patient just to rule out even like things that are not necessarily relevant, because they're worried that later the patient might develop something and then it will be a medical legal issue. So, and because of that, they'll order things that are not appropriate. Sometimes clinicians or people who order imaging tests are not experienced. So they're either new trainees or people who don't really follow evidence-based guidelines, and they'll just order tests. And the referrals will come to radiology, and it's up to us to be the gatekeepers and to actually correct and give advice on what's appropriate and what's not. But sometimes this doesn't happen, especially in a very busy atmosphere, especially after COVID. We are a lot of our places are short-staffed, so this becomes a big problem now. And also sometimes patient and family, they want imaging tests. So I work at a women and children's hospital, and a lot of times the parents will come and say, I want my child to get a CT. I want my child to get an MRI, just because, they want it. And a lot of times doctors will actually do that, even though that's not indicated. Self-referral, so this used to be a problem in the past. So in the 80s, a lot of private radiology practices, or a lot of private practices, they would, of course, radiology makes money, it's very lucrative. They would start ordering tests so that they would benefit monetarily, which is illegal. Right now, we have many laws that prevent this, and we have, insurance that, actually looks at things that are ordered and, decides whether or not it was appropriate or not. But this is a problem, right? Especially in the private healthcare sector. And a lot of times, there's a lack of alternatives. So if, for example, you're in Africa or in somewhere underserved, and you don't really have an ultrasound or an MRI, for example, and you have a CT, even though you have a pediatric patient who theoretically should not get CT, you'll get the CT because you don't have any other alternative. So you can see there are so many different reasons for why we can have inappropriate imaging. Why should we care? Why am I giving this talk about inappropriate imaging? First of all, healthcare is very complex. We have a lot of different teams. We have nurses, we have technologists, we have doctors, different teams of doctors. They're all working together in a very complex healthcare environment. A lot of our patients have chronic diseases, complex diseases. We're not sure what to do. And so we want to create some sort of guideline or follow some sort of guideline. And it becomes very hard and difficult, especially in a stressful, complex environment. There is a huge risk of patient harm. So a lot of times with radiology, you think about radiation. That's one risk, especially with things like CT, for example. But also there's risk of IV contrast. You know, people can have reactions. There's the risk of sedation. So especially in a pediatric patient where they need to get an MRI, so we need to have sedation because they're not going to lie still. So sedation is a huge risk as well. Sometimes we can overdiagnose someone. So if we do too much imaging, we'll find incidentalomas or, you know, a cyst in the kidney or a cyst in the liver. And that creates a lot of anxiety for the patient, for their doctors, etc. So there is a lot of harm that comes from imaging. And that's why we want to make sure that whatever imaging we do has to be indicated and appropriate. Also cost. So cost to the patient, cost to the healthcare system. I mentioned we don't want to abuse resources, especially staff, especially in a situation where staff is very short. We don't want to abuse their work and their time and their effort, etc. So what are the ACR appropriateness criteria? They are basically, ACR, by the way, stands for American College of Radiology. They are basically guidelines that the American College of Radiology created in assistance with clinicians. So it's not just made by radiologists. It's, you know, also made by doctors, clinicians who actually refer patients. And they're supposed to be guidelines in basically helping people decide what's the most appropriate imaging test to do. And they basically give you different clinical scenarios, and they tell you, like, you know, based on our evidence, this is the most appropriate test, and they share with you a lot of resources. This is free, so you can actually just go to Google ACR appropriateness on their website. Anyone can access this. And they have about 227 diagnostic imaging and interventional radiology topics that you can, you know, research, and it will give you, like, you know, what you need to do for that patient. And I'll share with you an example. It'll be very clear in a few slides. But the point is, we want to reduce inappropriate imaging because we don't want every hospital to do something different. We want a standard of care that's the same wherever you go. And we want basically to base our decisions on high quality scientific data. And they're also very regularly updated. So every year they update, they add new things, they you know, they modify based on the evidence that's available. So for example, let's say you have a patient with a headache, okay? And you're not sure, what should I get for this patient? Should I get an imaging test? What should I do? Should I do a CT? Should I do an MRI? I'm not sure. So what you do is you go to the ACR appropriateness criteria website. This is what the website looks like. You go down where you see headache. So when you click on neurologic, there's a section, and there you go, headache. So you click on that. So you can see here they have what's known as the narrative and rating table. And I will mention this to you. I'll mention what it means in a second. They have an evidence table, which they actually tell you, like, what these guidelines were based on. They do a literature search. There's an appendix, and there's also a summary for patients, a very, very patient-friendly summary that you can give to your patient and say, based on our imaging, you know, evidence, this is the test that you need to do. And this helps you because if the patient wants an MRI and you don't think it's indicated, you can say, well, based on this evidence, we think you should, for example, get an X-ray or a CT or whatever. So then basically when you look at headache, there's different kinds of headache. So it's not just one headache. They give you different variants, different clinical scenarios. So for example, this is variant 1. This is a sudden onset severe headache that reaches maximal severity within 1 hour. And this is your initial imaging test. So this is the very first test I'm going to do. Patient has very, very severe headache. What should I get? And they show you all of your different options. And they tell you, based on the appropriateness category right here, which is most appropriate. So for example, CT head without IV contrast, this is usually appropriate. And they also show you the radiation level. So you can actually use this to think about how much radiation, especially if you're dealing with a pediatric patient, you know, a young patient, you don't want to radiate them too much. So this is something that's very helpful, especially pediatric patients. And so this tells you, like, green means yes, that's appropriate. Yellow means maybe, you know, depends on the scenario. You need to read more about it. And they actually, it will actually tell you, like, the details. And then of course, everything else here is not appropriate. And they explain, so as you go through, they will explain the logic behind each and every one of these things. So this is another variant. So this is another scenario. You have a patient with a headache, and this is a primary migraine or tension type headache. So when the neurologist takes a history from a patient, they ask them certain questions to figure out what kind of headache it is. If it's something that sounds like it's a migraine or a tension type headache, look at this. They don't order any imaging. None of the imaging tests are recommended if it's a classic migraine headache, right? And so again, this is very useful. So you can use these for any patient, for any scenario. There's so many different scenarios. Variant 3, primary trigeminal autonomic cephalgia, so cluster headache. Again, cluster headache, maybe get an MRI, with and without, usually appropriate, maybe. And then you can read the literature, and they will explain that later. So you get the idea. So there's different scenarios, and you can use this to figure out what you need to do. Now, after you're done with the scenarios, they actually tell you the evidence. They have very, very detailed evidence, and they don't base their evidence on like random, research. They base it on very, very high quality research, and they tell you what standard that we use to select research studies. Some cases are observational, some studies are observational, etc. They may not be high quality. This would probably be like for high quality randomized clinical trials with lots of patients, etc. And they will use this information to come up with a guideline. They also talk a lot about like headache in general. They go through the different types, etc. So it has a lot of clinical information too for the clinician as well. And then they discuss by each variant. So we talked about the different variants. They decide whether or not the imaging is indicated. They give you the evidence behind it. And then, as I mentioned, the colors indicate how appropriateness something is. They also have something called appropriateness rating, which is 7, 8, or 9. 9 being like appropriate, recommended. 7, 8, yes, appropriate. And then maybe would be like 5, 6, 4, 5, or 6. Usually not appropriate, which is down here, is 1, 2, or 3. That's like, I don't think this is a good idea kind of thing. But again, these are not set in stone, right? You always have to use your clinical judgment. There's always going to be variations in your patients, so you have to just keep it in mind. These are just guidelines, right? I mentioned that they talk about the levels of radiation. This is very helpful if you want to explain to your patient the level of radiation that's involved. They also, quantify it in millisieverts, which is a common radiation unit that is used. And then they give you their references. So it's a very, very helpful resource. You can use it for any scenario that you can think of. They also give you a disclaimer at the end. They say that at the end, you should use your clinical judgment. Not everything is based in the guideline, correct? And then they also tell you like how they did the literature search. So in this case, they specified their search strategy. They showed you what engine they used, etc. So that's also very useful. This is the patient-friendly summary that I mentioned. So they give this, you give it to your patient. It has very simple language. It doesn't have like medical jargon. You can give this to your patient. You can tell them, this is based on the image, based on evidence. This is what you need. And then in terms of impact on quality and safety, so these guidelines have been there about 10 years now. And we're starting to see like that they really do have an impact, especially reducing things that are not appropriate. So for example, in one study, this is just one study, it actually reduced cost and it reduced the risk of radiation. So you can see here that after they basically implemented these guidelines, that the number of inappropriate CTs went drastically down, and it saved tons of money. If you look here, so this was the total number of CTs that they did, and the cost was about $837,000. And then they basically showed you like, how much it reduced the cost and the radiation. This is another study which basically highlights the fact that a lot of people are not aware of these guidelines, which is why I love sharing this and I love talking about it, because a lot of people don't know these guidelines exist. So for example, I know a lot of doctors use Google, they use WebMD, they use what is that called? There's a search for physicians. What is it? That very famous, I forgot what it is. It's a very famous search engine. Not PubMed. What's the other one? UpToDate. So a lot of people use UpToDate. A lot of people are familiar with UpToDate, but for example, this, nobody knows about it. So I'm hoping that you will also share it with your teams. It's very helpful. And just always remember there's always harms to imaging. It's not just imaging, it's harms. There's radiation, there's cancer risk, etc. So in conclusion, imaging carries various risks. So you should always consider the benefits and harms. Inappropriate imaging exposes patient not only to risk from radiation, but a lot of different risks as well as cost. It's a huge cost. It's a burden on the healthcare system, and we need to be very careful, especially now after COVID. It's very stressful. And these are high quality evidence-based guidelines that can be used to ensure safe and appropriate imaging for your patients. Thank you very much.
Thank you very much for that. Very, very interesting. For me, it's new for me, really.
Good.
Any questions?
Yeah, okay. You had mentioned the radiation exposure and the increased costs and everything like that. I used to work at a large teaching hospital in New Mexico, and we have 3 major centers in town, each with their own electronic health record, none of which speak to each other, so no interoperability. If a patient were transferred, say, from Presbyterian Hospital to the University Medical Center, none of those records would come over. Our providers at UNM did not have the ability to see anything that had been done before. Yes, they might send a disc that has some imaging on it, but it usually was not the highest quality. And part of my role then was to work with the resident staff to try and retrieve those records for them so that patients didn't end up with a great big bill because their insurance company said, well, you just had it done, half an hour ago over at this hospital. Why are you doing it again? How do you, or do you see any way to address that?
Yeah, actually, what you said is a big problem. And I think in some healthcare systems, it may be less of a problem than in others. So for example, like in Qatar, we only have one healthcare system, with, one Cerner. So it really helps us a lot. So for example, in my hospital, which is women and children's, if a woman or child was seen in the adult hospital and they were transferred, I would have access to the adult. And I've often actually found that, yes, they did get a CT just there, and we were just about to do the CT. So there were cases where a patient was saved from getting a double dose of CT, right? Just by us, as you said, being very vigilant, reviewing the records, trying to get access. But I realized there's a huge problem, maybe in some cases where they don't, they have healthcare records that don't speak to each other. Definitely, that's a huge problem. And, there's only, sometimes when you're busy, you don't really have time to go and search and look. So, again, it depends on how much you take this seriously. And, as someone who works in like Women and Child Center, we're very, very cautious, especially about CT. So, every request for CT, like we're very, very, we make sure that, they really need a CT. Do they really need a CT? Can we do ultrasound? Can we do MRI, for example? But unfortunately, people elsewhere in maybe adult hospitals, they're not trained to look at children. They don't understand that you shouldn't do CTs for children. So as you see that more and more people get specialized in kids, they do less CT. And that's one of the markers of like a child hospital or a pediatric, center of excellence, for example. But yeah, that's a great point, what you mentioned.
Very interesting presentation.
Now, insurance companies, I experienced it myself. I had some abdominal pain and it was very severe. So my doctor actually directly asked for a CT. But insurance companies, they will not let you go for CT unless you have ultrasound. So is it then when the ultrasound, then the doctor will come to know whether she should really go for CT? You think it's a good strategy for appropriateness of care? Like when I had to go through ultrasound and CT both, because your insurance company will not directly go through for CT unless you do the ultrasound first. You think it's a good strategy for appropriateness of care? Because imagine I had to go through two processes.
It depends. So it depends. I don't think that having a strategy that's like for everybody is a good idea because everyone's different. If I have an obese patient, like morbidly obese, ultrasound is not going to help. They need a CT, right? So I think it's a case by case base. And I think this is where the clinician has to make the judgment and the referring physician, like they have to decide like what's appropriate and what's not. And unfortunately, insurance is another problem, right? That's another issue that unfortunately we don't really have much control over that. Correct. But then I guess it's maybe your doctor's role to like maybe be more detailed, maybe write ultrasound is not helpful, or I'm not sure. I know that doctors have ways of like writing things that in a way that the insurance company would accept it.
Can I add one?
Yeah, go ahead.
Usually we are why the CT is indicated, okay, based on evidence base, and this is how it's going. If they will ask for ultrasound and if it's not needed, I will communicate with them. They will know that this is not indicated. Yeah, that's what we are doing.
And you know why though, right? Because CT costs more. So they don't want people to do CTs because then it's more cost on the insurance company, right?
Imagine this.
I know. I mean,
Continuous. Always have this one. But we keep on contacting them. It's very important to have very, very specific and clear referral indications.
Just write ACR appropriateness criteria on your request. Wow.
Sometimes emergency doctor call for urgent procedure, not يعني indicated for diagnosis as we said before. We need orientation for all, we need education for all, and communication.
Correct.
Emergency doctor asked for CT with angina.
Okay.
He might cause the ECG changes.
Okay.
But unity review said, why you go to this? This is close and not significant like catheterization.
Correct. And this is the role of the radiologist, right? Because we're gatekeepers. Like I always think like the radiologist is a doctor, but our medicine, instead of medicine, it's radiation, right? Yeah, so whenever we give radiation, it has to be because we have a good reason to do that.
Just want to add to this point. If I am asking, for example, for a CT or any image, I have to call the radiologist. That's what I'm doing actually.
Yes.
I'm calling the radiologist, just discussing the case with him. I'm telling him directly what is the indication for it.
Correct. Go ahead.
Thank you so much. So, just knew that you have certain child syndrome.
Yes.
Okay, so are you able to generate traumatic reports of central biology or
I think for the no, currently we don't do that, but right now we just implemented a new system where the clinician, before they order a study, they have different questions that they have to answer, like you want to get a CT. What is the indication? Why have you considered this, etc.? So we're making it more and more difficult for people to put in inappropriate studies. And as my colleague mentioned, also they have to discuss with us. So we don't approve things that we don't discuss. And this is one way that we can help. Yeah. Good. Other questions?
One more question. Yeah.
I didn't know that it would be so interesting. Good, alhamdulillah.
This is interesting. Really, it's a bigger problem. Finishing for the radiologists, for the whole system. But if you can't do CT scan because of the ACR guidelines, what about you can do CT scan according to the patient request himself? Because in our country, they can do only by the request, without the request of the clinician. This is a big problem. Patient and its relative or his relative is still the major problem of this inconsent. I can tell you that one experience from our country, the surgeon or the physician or what is the specialist of it is or have share or has a share in the CT scan center. So he is making a deal with the radiologist or with the investor to have a share from doing the CT scan. How can we apply ACR on such system? In Iraq, even my child can request CT scan.
So again, that goes back to like one of the very first slides that I was mentioning. So the reason why we wanted to form these guidelines in the first place is because of the reasons that you're mentioning. Self-referral was a big problem in the US in the 80s. A lot of doctors got so rich, a lot of radiologists, because they would get kickbacks every time they refer, to an imaging center. They had like deals with other physicians, refer to me, and then, we all get paid. And this was a really, really big problem. And actually now in the US, there's laws against this. So you're not allowed to do it. You can lose your license and go to jail. So it's very strict. But I'm sure in other countries, maybe it's not as, strict like that. And this is a big problem. And again, this is one of the reasons why we created guidelines, because we want to standardize care. We don't want a private hospital to do all these imaging tests that are not following a standard. You know what I mean? They're doing like all these extra tests that we don't really need. So it's a huge problem, and we're just beginning to be aware of it and deal with it. And I'm sure it's very challenging, like in Iraq right now. So maybe, and then going back to the patient request that you were saying. So maybe having these patient summaries. So like you can tell the patient, for example, like, this is American College of Radiology guidelines. This is what people do in America. Like, it's one of the most developed countries. This is the standard they follow. Here's the imaging test that is indicated. I'm not saying this that you can't get it because, for whatever reason, I'm basing my decision on evidence. And maybe that's helpful. I think maybe patients will listen to you. And also radiation, of course. Yeah, one of my colleagues was saying, you always have to explain to the patient that's radiation, especially CT, fluoroscopy. Yeah, so just CT. And maybe you can ask, maybe you can find out why. Maybe the patient had a family member who was misdiagnosed and now has a trauma of like missing something. Maybe they're like hypochondriac. Like, I don't know what it is, but maybe find out more and then actually just try to explain to them that there's a lot of harm. There's, the radiation accumulates over someone's life. And especially in children, especially in young people, like for me, that's like very upsetting when I see like CTs being done on children. It's very bad because, children develop cancers. And so.
Last question, please.
Okay.
The patient is admitted in a private or in the governmental. So for sure, the governmental maybe will not need for the insurance. So the CT, for example, will be done quickly. But otherwise, in the private hospital, some of them, and I work in them both. So I think there is a lot of a higher percentage of the unnecessary imaging, like CT, for the costs. Maybe the patient is cash, so he will pay cash even if he should more and more time in the private hospital just to like the financial department win, or maybe the wrong word, win more and more money. That's
Correct.
why so just it need to be mentioned in this meeting.
Absolutely. Yeah.
Okay, then thank you very much. Now move to give your certificate, please. Is it certificate? Before presentation.
Okay.
Thank you very much. So now we'll have our last speaker having our lunch break. Our next speaker is Mr. Shayma. Mr. Al-Muqaymi from UK. I'm passing
From Oman. It's how
I think this is an error. Absolutely. Yes, just an error. Sorry for that. Okay, I'm passing her the stage to deliver the speech on exploring the experience of nurses during the COVID-19 pandemic, a critical review of the qualitative literature.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon to you all. I'm going today to present about exploring nursing experience during COVID pandemic. Okay. So, sorry? Okay. Okay, before starting, I would like to ask you, how was the COVID experience? You just give me one word explaining how you felt, or how was the experience as general. Yeah, I just okay. It's your choice, okay? Okay. Anyone? Anyone can share with me the one word only about this?
Overwhelming.
Hyperventilating. Yeah. Why you felt hyperventilating?
And so they came across people were acting the way they thought they needed to, but they didn't really know what they were doing at the beginning. And through evidence-based practice over time, we then started to realise what is best to do, or what we think is best to do. But we went back to the old approach, didn't we? We went back to the medical approach, which is treat the disease, not the person. And that caused a lot of problems as well.
Yeah.
Overwhelming.
Yeah, thank you. Feeling great. At the end, we realized that many things are taken for granted. Even the simple things. When it stopped, I felt very much great for that. You know.
And you were part of that. Yes. That had care of patients.
Very bad experience. Very sad. At the time, I'm working physically.
Take this one.
Yeah. Yes. Thank you for sharing your experience. Now I'm going to present about the nurse's experience based on literature review or qualitative studies. Okay, so briefly I will discuss about the research. It's mainly qualitative research, was being critically analyzed in this paper, and we will discuss about the thematic analysis which we came out of this paper. Before starting, is my voice clear? Okay, no.
Sorry. Okay, before starting, I'll just give you briefly about coronavirus. It is recognized first in 16th century, then around in 20th century, we had around 5 pandemics. Pandemics was actually the family of COVID, but every time and then there is updated this one. So we had the SARS, MERS, SARS, Ebola, SARS-CoV-1, CoV-2, and all types of SARS we have went through, and dengue fever. I think we felt that this is the most, what can I say? The people have been crossed, the worst pandemic have been crossed, but it's not the one. Actually, the Spanish flu, which is H1N1, they called it Spanish flu, and it has killed around 17 to 50 million people. And it really was the worst the humanity has faced. So the pandemic started, the outbreak in Wuhan in China, then declared as emergency, public emergency in January 2020. It started spreading, and in 11th 2020, March, the WHO has declared it as a global pandemic. Up to July 2023, around 86 million cases have been diagnosed with COVID, which is a huge number. And the death rate almost nearing to 7 million. Around 13 billion vaccinated doses was administered. As I mentioned, it's data analysis I used is thematic analysis and content analysis of 15 papers. Those 15 papers I used the Prisma first, and then I used the CASP for the analysis. The papers was originated from US, China, Spain, Turkey, and India. Because the paper I was working on, it was end of 2020, so it wasn't, there wasn't enough papers published regarding the COVID. So this is the CASP analysis. So the thematic analysis outcome, we had come with two major themes. First theme was about staff well-being during pandemic, and the other one is about hospital preparedness. So we'll go first with the staff well-being. Staff well-being, it's divided into psychological effects and coping strategies. Can anyone tell me what was the psychological effects? What you think it has affected the healthcare professionals as total?
During COVID pandemic, I think I guess this problem with the care provider. They fear from interaction with the patients. Yeah. They fear get the virus, It's a new virus. Some of them kept crying. Some of them excluded from the area. We constantly psychosocial.
Yeah, agitating care of the patient, which was affecting the quality of care provided to the patients. Okay, we'll go in deep what the participants has experienced during this pandemic. Actually, most of them, they reported that it was really emotionally challenging for them to face this pandemic or to face those patients with unknown virus. Suddenly, you have to wear your own PPEs, you have to be careful, you have to take care of yourself, your family, the patients in the hospital, and your colleagues, and it was really challenging for everyone. So they were crying, they expressed that they felt sad, stress, anxiety, fear. They went into depression also. Most of the staff was being interviewed in the papers. They experienced depression. And some of them, the researchers have to give them immediate psychological sessions and support, not waiting after the pandemic, after the interview was over, they started giving them because of their status. Also, they felt professional burnout and psychological trauma. In addition to those psychological effects, they felt has negative emotions. As you know, you are facing huge number of patients dying in front of you. You cannot do anything. So it's very difficult to work in an area people are dying without having you the chance to give them any help. Okay, and the increase of workload and lack of resources, as there is a global shortage of PPEs, stress, fear of infecting family members, also insomnia, sleeping in their cars. I feel my voice is clear. Can I go or what? Yes, you can. Okay, because of the back thing. Sorry for that. Okay, so as they mentioned, so many healthcare providers was sleeping in accommodation, in the cars, in the hotel, fear of infecting their families, which is really psychologically depressing and tiring for them. Also, they felt social stigma because some they reported that when they are coming out of home from duty, they are seeing their neighbors going away from them. They are writing for them labels in their home, please go away. And this was verbalized by the people who was interviewed. And they felt really like social stigma. And it's very, very, very difficult it was for them. So all these emotions led to the staff experience PTSD, which is post-traumatic stress disorder. Some they started seeing psychologists after the pandemic, and some during the pandemic they couldn't cope up with the situation, and they immediately started seeing the psychologist. Based on the research, do you think that leadership skills can affect the psychological status of the staff? Through support. Yeah, through support. It's very important. It was verbalized by most of the interviewees that the role of the leadership was very vital in recovery from the psychological this one. Stress. It's builds their resilience, it improves the productivity and empowerment to their staff. In addition, it promotes their well-being. Moreover, adapting transformational leadership through the support and empowerment and positive impact on employee as emotional intelligence. They will support their staff, the leaders will support their staff, so they know how to deal with them, so they will be emotionally supported. However, not only the staff has experienced negative emotions. As you mentioned, it was a great experience. They have verbalized that it empowers their skills, their leadership skills. In addition to it improves their knowledge through training, because during the pandemic, most of the staff has got training on how to work on critical areas. So this has improved their clinical competency and improved somehow some of the quality of care. The second part of staff well-being is the coping strategies which was used by the staff or the healthcare providers to overcome the psychological effects. So the staff was verbalizing that they try to isolate themselves to avoid people, to prevent any social stigma and self-consciousness. They used humor. They worked for walking, doing sports, listening to music, and some they adapt their own coping strategies. The people who practice coping skills mechanisms, they have less psychological effect compared to the other group. Next, we'll discuss about the hospital preparedness in the pandemic. The hospital preparedness divided into technical and non-technical skills. Technical mainly will be the and knowledge. As you know that, as we mentioned, and also someone mentioned before me that there was a pandemic global shortage of the PPEs, and it was affected by lack of resources. And this was verbalized by the staff also. They had to wear it for more than 12 hours. They had to wear the PPEs for more than 12 hours, and it affected their well-being, affected their hydration, using of restroom, and some they verbalize they used to wear diapers during work because they cannot go to the toilet due to the huge number of patients. And as you see, and as I'm sure you experience when you will wear the N95, all the marks. Yeah. And then it impaired their vision, use of goggles, and affected their movement because of the full PPEs. So all those was affected and negatively to the healthcare providers. The second point is about human resource. As you know, it's a global shortage. Patients mainly was admitted in ICU, which the care has to be 1-to-1 or maximum 1-to-2, but it wasn't up to the standard because of the staff experience or the staff shortage. This had given burden to the hospitals in caring of such patients. Increasing working hours due to work overload and burden of training. As we mentioned, the training also increased, but it was also burden on the training because some training it was in-house and it's very difficult to concentrate on training and relieve your patients. So it was really challenging. Unprepared practice and implementation. Some they verbalize that they were not having skill mix due to the shortage and the staff was affected. For example, if we're having 6 patients or 6 staff per shift, sometimes the staff themselves they are getting COVID, so they will be isolated. The number of staffing will be low, and it will affect the skill mix also. Lack of knowledge, security, staff training, this was also affected. The training was mainly concentrated for the tertiary hospitals or secondary hospitals, but they forgot to concentrate on primary health care, which the first step where the patient is approaching. So we need to consider those type of health centers. There was a gap between the guidelines and the practice. As you mentioned, it was a new virus. Nobody knows how to deal with it, and there was a gap. Every now and then you will have update. So some managers they were not conveying the message to the staff, so they were having a gap of this communication.
Actually, time is up, so
okay. So non-technical skills divided into communication and support. Communication, lack of communication, using the PPE, it's very difficult wearing the N95 how to communicate with others. It was really affected by during the COVID pandemic, no clear management plan, and some staff, they refused to participate in the care, afraid of the infection. So the support is also the staff verbalized they had lack of support. There is no financial support. There is no even they were not giving any extra off for the extra hours they have given or they have worked, and it was really very important for them to be offered or to be supported by those type of support. So it was found that if the staff has a good support, they will have they will reduce their staff burnout, promote the coping strategies, and also improve the staff resilience. Implication for practice. As that time it was very limited researches, but I search now and there's a lot of researches are being conducted exploring the psychological effects or the experience of healthcare providers in COVID. Staff well-being, we really need till now because we have experienced staff turnover after the COVID. So we need to support our staff, give psychological supports, even giving allowance or something to motivate them so they will be motivated for work. Staff resilience to build them through the courses, clinical reflections, and supervision, and education and knowledge, early preparation of keep the hospital is well prepared for any pandemic. It's very, very important point we need to take it with us. Keeping the hospital, keeping the staff, preparing them for any unknown pandemic is very important. In conclusion, there's more. So we know that it's very important to have the staff well-being, maintaining their psychological health, training them, using their own coping strategies, and educating and learning them, educating them for any upcoming or any coming I don't know. So thank you so much.
Thank you very much, Ms. Noor, for your presentation. It was a very nice presentation. Do you have any question for Ms. Noor? Only one chat, because we have to go lunch.
One.
And for lunch. Well, please, we'll be gathering for a photo in 3 places, inside this hall and outside, and in the garden. Any questions? Okay, thank you very much.
Thank you.
Before that, please, can you allow me to give you your certificate of appreciation? Thank you. You want to do one more? Yes. Get now? Yes. Yeah.
You.
We're starting.
Yes.
Thank you.
Group photo, please.
Please. But please, I'm taking. No.
When you talk about
شاء الله في الكورس.
ان شاء الله يا رب، اكيد اكيد. علم احنا معنا اعلام.
Really? Yeah, one of the causes, quarter one.
What?
It's not a five grade.
That's for an ambulance there.
That's funny, man. Yeah, you see the,
It was taken.
a little bit further, yeah, a little bit further down. You see the five grade go down there. Wow.
I'll tell you something.
I just saw the smoke blowing up in the air.
1 month ago,
Terrible.
I had an accident in Salam Street,
Okay.
very fast one. Then I was hit by 4 cars to the extent I saw the accident in the news and they changed the speed of the road because of that. I lost the car, but I'm fine. For 2023 راح. I will plan a moment at a time.
That's all.
وزنت بتشتغل في فيصل ولا خلاص فريلانسر يعني؟
But I have a pop-up images, so how do you do that? Max,
I need someone to run the slides. So can Dr. Sahar take this duty? Because now it's my turn in sharing the
you can go ahead.
the sessions. Okay.
It's just for operational.
Yeah.
Yeah. Okay. Yeah, that's fine. But if I see, I have to scroll.
Go like this. Just touch it.
I know. I just wish we have a mouse. It's easy. It's, you know what I mean? It's easier with mouse. Otherwise, I have to do this. See how it's hard? It's the images that I use the tab for
Healthcare patient and patients. Thank you very much.
Did you record it? Should take a while. Yeah.
Watch them.
هلا هون عندنا دكتور احمد.
حلو، عملتي مع اثنين وما شاء الله عليكي، شايفه
معي على السريع على
على
السريع
السريع.
بدي حدا راندوملي.
مجالك
ايوه ثانك يو. هلا احنا كلنا منزلينهم هيو داي 1 منزلينهم، احنا ماشيين بالترتيب. خلصنا
الحين
من
انت كم؟
هلا دكتور احمد اوريدي عملنا
معنا حاجه مريم.
مس ماريا دكتور
How can I
تركي
go inside day 1? Okay.
داي 1
Okay.
بتفتحي هلا
Clear.
فرضا بتضغطي دبل كليك عليه اوكي وبتكبري بس هذه هي
Thank
كل
you
واحد
very
much.
25 minutes. So let's start quickly.
Okay.
Actually هذا شغال اصلا.
انا دائما بعطيهم 20 25.
Start now. Okay, so please. Okay, let's start our session for today after the lunch. It's a great opportunity to have all of you in person today. I hope you have enjoyed the first session of our day, and let's complete it for the second next speaker. Okay, so our first speaker after lunch is Dr. Ahmed Al-Adawi from UAE. I am passing him the stage to deliver the speech on quality sustainability challenges in healthcare. So, Dr. Ahmed, the stage is yours. دكتور أستاذن حضرتك
توقفها عشان الكاميرا عنها تتعامل.
أنا أشتغل
تعال مو علي.
أول مرة.
حاضر بس خليني أكبر لك إياه. استخدم هون عندك
لا لا ولا أسمع.
تمام.
Good evening everybody. Good evening everybody. In the back, listening to me, hearing me, okay? طب I can have the microphone better. Okay. I hope after lunch, it is not heavy lunch. I think the menu is, alhamdulillah, yani light. So no heavy stomach. Still, there is blood going to the brain. So I hope that you will enjoy my presentation. I'm originally a physician background, working 18 years in the education as a university staff in Egypt and Saudi Arabia. 25 years ago, I shifted my career into quality, and I have the honor to establish the first quality management office in Egypt, which is the first one in Middle East. And I joined Saudi Arabia Ministry of Health in Western region in 2001, where I was the first governmental employee appointed as a quality assurance coordinator at that time. Alhamdulillah, I succeed to establish for every hospital or to give the chance for the leaders to take a decision to establish quality management departments in every healthcare facility governmental. For sure, طبعا Saudi Arabia at that time, King Faisal University, National Guard, they are ahead in the quality, but I'll talk about the governmental sector. Over the 25 years, I have a lot of experience that I hope I can share some of this with you, and to listen from you also, to listen from your experience. And I hope during my presentation, I hope that you are putting the hat of a quality professional, quality manager, responsible of the whole quality system in the organization. Don't look to your job as a pharmacist, nurse, or a doctor, or radiologist. So please, when you are listening to me, put your mind that you are a quality professional, responsible of the whole quality management system in your organization. As you see from the title, it is about quality sustainability. And I hope that there are two words. Quality, which, yeah, I mean, since more than 25 years, people are talking about quality, quality, quality. As a word, maybe it is something new, new taxonomy, which is coming not more than 10, 15 years when we talk about this. Just as an interaction to make you less more interactive with me, when I ask any one of you what quality means to you, what the answer is? Do the right thing from the first time. Safety. Integrity.
Doing the right thing the first time and every time.
At every time. So she added to that, do the great thing every time. And sometimes next time is better than the first time. And the right time. Right proceeding for the right patient, 5 hours, 6 hours, or 7 hours, which usually the nurses are fond of. Degree of excellence. Degree of excellence. Efficiency. Efficiency. You want?
In the best possible way.
In the best possible way. So as you see, usually when we are dealing with the quality, we are usually talking in one or two aspects. Either as a descriptive, you are describing the peculiar feature of your work, efficient, safe, excellency, or you are talking the other side about practice, how the talk. You are talking. When we say quality is an excellence, degree of excellency, quality is efficiency, the safety, this is descriptive. And when we talk about doing the right thing right first time every time, doing with the best possible practice, evidence-based, this is what we talk about work. And this is what we need to talk about. A lot of people, they are talking about what? But we come into practice, usually that we are in the comfort zone. We don't want to change because quality to be implemented, we want to change. And change, usually we say there is a resistance for change. That the expression is not right. There is no resistance for change. We will change, you will change. But there is resistance for a change. This is the problem. So the quality, usually when we talk about, and that's why we are quite professional, they are usually called change agents. And as much as you succeed to let people change it, this is your success. As we say that now, they like to say that quality professional, quality coach. That's why your success in the success to change others, not yourself. So this is about the quality, which is all of us can talk about or say something about it. But when we come to sustainability, what's your opinion? What sustainability is? Sustainability يعني استدامة باللغة العربية. But what's that mean? Like quality يعني إيه؟
the sustainability plan.
So your sustainability means to improve.
Yeah.
New taxonomy for improve is partially right. Yes. Improvement for the long term. So long term maintenance. Continuous. Excellent. You are more about excellence. What are records working? So you are on the group that quality need resources. Because usually we have two aspects. Quality need resources or quality doesn't need resources. And this is a debate. Are you changed by yourself or something changing you? Some musayar or mukhayar. But quality is the debate.
Financial funding.
Yeah.
You improve the quality, like to.
I'm not denying. I'm accepting. Yes, I know. Sustainability.
Continue with the same level of perfection and standard.
This is what sustainability.
Yeah.
Serving something that's limited and precious, like a resource that is that you want to preserve.
How you are able to spend the resource how to get efficiency.
Then you have that voluntary.
So sustainability needs to continue.
Maintaining the culture of change.
Maintaining the culture of change. So it is a maintenance, some sort of maintenance. Okay. So all of you, as you see, most of you or all of you, they are talking about sustainability, about the time where you are in. Okay, they are talking about sustainability where we are in. The era which we are in, the years which we are living in. But sustainability, this is a part of sustainability. But there is another important part of sustainability. That what's about the next generations, where you are not there? Are they able to continue your success and to take over your success story and build on that and continue? This is the question. And usually, because quality is an art, and there is no right and wrong in quality, and everyone wants to prove himself or herself. So usually, seldomly, you will find an artist who can take the actions or the achievement of another artist to build on. And usually we are criticizing this. This is not the problem. Exactly like when a surgeon is criticizing the procedure of another surgeon. When a dentist, when you go to a dentist and he did some procedure in your teeth, and then you go to another dentist, he does not acknowledge. Usually he criticizes the work of that, and this is human nature. So the sustainability, I hope is great in your mind. Sustainability is about how to continue, how to maintain, how to long term of what you are doing, proving, and how much your success to let the next generation, when you are not there, they continue doing the same or better. So this is about sustainability. And this one I would for sure. يعني, I cannot say, I didn't say any success story about sustainability in the way that someone did something. And there's another generation are building on that. Usually we start from zero, going back to start from zero, because there is no endorsement. The next generation, they don't have the achievement in a blue book, in a blueprint. Usually they have it in a nutshell. They don't know the tricks. They don't know how it is done. So they have an excuse. They cannot continue something they don't know how to cook it. At the same time, the next generation don't like to continue the way that the previous generation they are doing. So this is about just as a quick introduction about my topic. So my agenda with you today is about 4 points. We'll talk about quality and sustainability. And then I will give you some strategies that from my experience, I think it is an efficacious strategies that if you take it all, you will achieve what's called quality sustainability. And you will ensure how the next generation will be able to continue what we succeed to achieve. Then I will give you from my experience what are the challenges to do this. The culture. When we talk about culture, we are not talking about ethics, because usually when we talk about culture, people thought that culture is the behavior, your beliefs, your norm, your traits. Culture here, when we talk about culture, we are talking about practice. How you are practice. When we talk about patient safety culture, I think someone will talk about this topic. Tomorrow, someone will talk about patient safety culture. When we talk about culture, we talk about the behavior, how you are behaving, how you are practicing the healthcare, not about what you believe in. And then we'll end up with a topic that I think Dr. Abir will continue at the end of the day, so I encourage you to be awake, because she will continue and build on the last point. I discovered that her topic is about reliability, and usually I name it either high performing organization or high reliability organization, HPO or HRO. So she will talk more based on her experience about this topic. Okay, so from my experience, and I hope that you take it from me, and I need to listen from you if you are not accepting my experience with you. That when we talk about quality, I'm talking about work. I'm talking about the walk. You know that expression, walk the talk? I think this expression is, people are love to say, walk the talk. Walk is about talking. Your walk, your practice should match what you are talking about. Okay? So this is the concept. So I usually like that walk, not the talk. But for sure, in order to share my experience with others, I should talk. But usually one of the traits of the quality professional, they are talkative. They have no volume. Once they open the mic with them, you cannot stop. Okay? Sorry that I will say some expression in Arabic. So عارفين طبعا شيبسي ريكلز عارفينه لما تفك. Okay. So usually there is a brand of one of the chips. It's called Pringles. When you open it, you cannot close it until you finish it. So this is the quality professional. And who is one of the characteristics of the quality professional? He should be talkative. And he should be able to convince others. Because as I told you, you should be a change agent. And you change minds of others. So if you're not a good talker, talking, but you should match your talking by your practice. And this is the challenge. Okay. So my experience that quality, it is not a destination. Quality is a journey, endless journey. That's why it is a road map. Usually the first point in that road map is about how much you love what you are doing. And I select the word love because it has a good emotional impression. Not like love or maybe in a passion. As much as the employee in a passion with what they are doing, not doing that because they want the salary at the end, not because they are afraid of anything, as much as they love and in passion with what they are doing, this is the first step in quality practice. But the second is the most important, which is the right thing, which is coming in many words in the definition. But when we say right word, it is not a quality. This is what we learned in the school. How many of us exactly implement what we are learning in the school? How many of us as physicians, as surgeons, as radiologists, when you are educating and learning in the school or faculty of medicine or faculty of nursing, you are learning step by step what you are doing. How many of us is following the exact way that you are educated? Usually we have shortcuts, workarounds, right? You agree with me? This is against quality. So when problems coming from not doing what we are educated about, don't say that we don't have quality. You don't do the work from the beginning. That's why now automation and the technology is trying to overcome this shortcoming or workaround, putting steps to follow, so that you are obliged to follow up. So as much as the doctors in the clinic, how many doctors in the clinic following the history and the examination that you are learned about? How many of us? I think rarely. Maybe you will never found a physician or a nurse is practicing exactly what they are learning. So here, this is the second step in quality. Then, if we did the first and second step, then coming the last step, which is the perfection. As a human being, as a nature from Allah, if you love what you work and you are doing exactly what you are supposed to do, by time and repetition, you become perfect. Imagine the first time you are training to drive a car. How much you are intention, how much you are concentrating not to do any mistake. After 1 year, 2 years, 3 years, 10 years, you found that you are not following exactly what you are learned, and you are doing your own way of driving. And usually, the big accidents doesn't happen from the beginners. The big accident is coming from what's called profession. So I ask myself, when I say perfect work, what that mean? What I should see my work, so I can say, yes, this work is perfect or not perfect. What that? Good outcome. KPI. What's improved? Next. خلينا to be away from the core values, transparency and honesty and justice. All of this, I want to talk about the practice. What you are doing in your work, I can say you are doing a perfect work. This is an impact. Yes, I do it as an impact. But I did operation, I have a patient care, I did an endoscopy, I prepare an medication, and I have an admission. I want to say to that work, perfect. Communication skill. Again, this is a core values. You should have it. But your work, when you can say that I did my work perfectly.
Done within the defined limited time.
Okay, but how timing entering the scene. Timing is entering the scene. Okay, and the outcome is entering the scene. So straightforward, very simple. You have two parameters for perfection. No third. The first one is about performance, about the time you are using, about the resources you are using, about the effort you are using, about the money you are using. This is the performance. And then the achievement, the outcome. Time. What in that performance and what achievement you want to say or to see? The first one is prompt performance. Prompt, yeah, in the proper time. No time extra, no time less. Prompt. And what about the achievement? It is accurate. No errors, no variation, no deviation.
The time is running out, so in 1 second.
How many time I have?
Not more 2 seconds.
I will stop here. Okay? So, don't forget the acronym PAPA. Which one? Rapid performance. Accurate achievement. PAP. Sorry. أنا مش هشتغل.
On the next slide or the pointing?
لا خلاص. So this is what we are talking about, how much you are. And usually you are doing, you can reach perfection at a certain time, at a certain piece of work. But you cannot reach perfection all of the time, all of your work. This is only for Allah. The human being, you have a value. So quality improvement coming to minimize this variation as much as you can. So this is about what? I will quickly cover because I have only how many minutes? How many seconds?
Now 1 second.
1 second. So this is the up to modern or up-to-date terminology of quality. Now quality no more about standard compliance or about accreditation, about now خلاص. This era becoming an old fashion now. Okay? Sustainability is about how you are minimizing your negative impact on environmental, social, and economic. The presentation will be with you, and I hope you can share it with them in a PowerPoint. I will not put it in a PDF, so it is edited for you. You have the right to do by it anything you want. I have no copyright. Okay? And I'll be very happy to communicate with you, to sharing your experience with me, and I'm sharing my experience with you. So in order just to, this is the strategies, sir. This is the strategies of that I recommend if you want to do a quality sustainability. These are the 6 strategies that you can do in your work. And all of this, I have a lot of practices achieved in that. We can discuss later. And these are the challenges which I face in my life when we are dealing with sustainability, quality sustainability. And the first important one is about accreditation base. All of your work as a quality professional usually enter from the gate of standard, accreditation, ours. And this is really not efficacious entry. Standards, and please remember this, standard should be used as a tools, not as a rules. You are using the standards as a rule. What in the standard I will follow, what not in the standard I will not follow. I should not follow. Okay? And accreditation is a theater. You are preparing the staff, you are preparing your evidence, surveyor come, watching your theater, giving you staff, Mabruk, certification, shut down, go back to your normal. Okay? And all of you know about post-accreditation syndrome. So this is about, alhamdulillah, Amir will continue, inshallah, about reliability. Yeah? What's that? You want to know about it?
No, I'm just telling you that there is only
Syndrome. He's a panic. He's a panic. يعني I hope that you enjoyed a lot of information. This is, by the way, this is my system that I suggest you to follow. And here is one of the achievements that I am proud of, that which is done in Saudi Arabia. This is the first, and I think there is not any book you will find in the world containing this information. This book is published in 2014 in Ministry of Health, Saudi Arabia, and I'm proud to lead a team of 100 members all over the Kingdom of Saudi Arabia, where it contains all the details that I like. If you take it without blueprint, if you follow it step by step, you will have a very robust and rigorous system. And this is here, we developed a corporate performance framework in order to measure and to sustain your work through this. This is a product done last year with the OECD, which is one of the international organizations which is comparing performance of countries together. And we got an intellectual property here from UAE about it. Thank you for your time. And really, I love to hear from you.
Thank you very much. Thank you very much, Dr. Ahmad, for your informative presentation. Actually, only for one question because time is running out, so I will choose random.
And I will answer the other questions with the
during the coffee. So,
Thank you, Dr. I really appreciate your informative information. To be honest, I wish you finished your session. I have a question. I transfer another meeting. We all know that the GCI say they focus on quality of services. Similar in Saudi.
Semester.
Yeah.
And in Egypt, the heart.
Yeah.
And in Jordan, the Arabic standards.
wait نسيت عندك اصلا اطلعي من كله هذا تاع دكتور مريم ابن الاخوه يبلش اطلعي من هذا اصلا طلعت انت من تاع دكتور دبل كليك remove this way that's the same minimize it just minimization because it's keep on coming. Okay, right. Now open the Colombia. This one. This one? No, yes, this one. Yes, I can use the items. Why it's not maximizing? So why am I going to it's not maximizing because this is off. Okay, she can't maximize. She cannot maximize the first one. Let's not have that. Let's just do over here.
Change.
No.
Change.
This is the first one. You have this.
I need my notes.
Okay.
Yeah, but it's not official.
Okay then. Okay. So there is no.
Good morning. Because it's not morning. It's happening.
Good afternoon.
That's about.
Yeah, you can say good afternoon. Okay, good night.
Thank you.
Okay. It does mean that the patient is functioning well. So you should have what's called history and examination. You have a system you are following from head to toe, asking him, examining him, diagnosing him, but using this as a vital signs to tell you from the beginning, is it a problem or not? So usually the three signs or KPI that you mentioned, they are very critical, and usually it is a gatekeeper to tell you, you have a problem or you don't have a problem. But if you don't have a problem, doesn't mean that you don't have an opportunity to be better. Okay? So this is how we convince them. And I have a lot of experience and resistance about this and how I tackle and succeed to overcome it. But as I told you, standards, they are the critical success factors in organization. You cannot live without standards. But you should use the standards as a tools, not as a rules. You should have your rules. Then you use the standards to tell you, are your rules are robust or not?
So we have America, for example, as leading country. We have Canada, advanced countries. One of them are wrong. Either the European countries or America. These don't have standards. Yeah. They enough with the 3 signs. Yes. America, they say no, we have to implement this. So I see from my point of view, one thing is in the wrong way.
All of them are right. All of them are right. But not as a starter. Take it to the point. I cannot start or take it for granted if I have standards or if I have KPIs that I am in a good, robust system. You should have the system. This is what I hope I can have more time to explain to you this. Because this is the core value of my issue. How to establish your system. What we say system now is not a system. It's science. You have a pharmacy, Excel pharmacy, you have Excel PR, you have Excel OR, you have Excel event, you have Excel infection control. All of this is science. You put it together and you assume that if everyone is doing the work well, you have a quality. No. 30% of the quality errors in the communication. So you should establish your system horizontally, not vertically. And this is my experience, and the book that I showed you tells you how to do it. I'm sorry that I can. So yeah, you have my contact in the brochure, so you are very welcome to contact me at any time. Coming to this thing, because really I have a lot of work in DHA to complete tomorrow. So yeah, I'm really not lucky to be with you tomorrow. So thank you for your time, and I hope I can hear from you and listen from you your questions and answer about it. Thank you very much. Thank you.
Thank you for this amazing presentation. So now our next speaker is a friend and a speaker who I met on our last conference in San Francisco, Ms. Maria Sheila from USA. I'm passing her the stage to deliver her speech on the mechanisms and efficacy of heat and cold therapy. So, Ms. Maria, the stage.
Thank you so much. Do I just speak? Can you guys hear me okay? Okay. Good afternoon. Too loud. I don't know why it's playing so long. It's supposed to be just 5 seconds. Well, hopefully you guys like that music. It's really about, it's like a digital kind of energizer, right? It's about your brains and things like that. But anyway, my name is Maria Sheila Sorzu Diaz, and I want to say that in Arabic, Marhaban tasharrafna, kayfa haluk, ani Maria Sheila. I love your language. I think it's very beautiful. But let me go back to here. Looks like we have many folks here. Individuals receiving physiotherapy treatments for acute and lateral ankle sprains, LAS. Now, we all know that ankle sprain is a very common injury, and its management is often costly, with important short and long-term impacts on individual society. Now, as new methods of therapy using cold or cryotherapy are emerging for the treatment of MSK or musculoskeletal conditions, little evidence exists to support their use. NCS, which provokes a rapid cooling of the skin with liberation of pressured carbon dioxide, is the method believed to accelerate the resorption of edema and recovery in the case of traumatic injuries. Now, in this diagram, it shows that the functional level is higher, meaning that the participants who received the traditional icing method, which is the red marks, was able to function faster than ones who received cryotherapy. Now, the studies with the pain at rest scores, the pain at rest scores in red for the traditional ice method show significant lower of pain level. And then the pain during usual activities score in red for the traditional ice method shows significant lower pain of level again. So in contrast to cryotherapy, there's heat therapy, which is typically reserved for treatment beyond 48 hours post-injury. Now, in this small study, continuous low-level heat wrap therapy was of significant benefit in the prevention and early phase treatment of low back DOMS, or delayed onset muscle soreness. The intervention was 67 participants performed vigorous eccentric exercise to experimentally induce low back DOMS at the hour 24 post-exercise and thereafter. They were given heat wrap and cold packs. So the pain intensity and the pain relief was the measure that they used, and self-reported physical function and disability were secondary measures. Now, as a result, in the prevention of study, at hour 24, the pain intensity, the disability and deficits in self-reported physical function were reduced 47% and 45% respectively, compared with the control group. So at hour 24 in the post-exercise, the pain relief with the heat wrap was 138%, greater than with the cold pack. There were no differences between the groups in the changes in self-reported physical function and disability. Please, no more frozen peas. Do you know how many post-op surgery instruction documents that we have read where frozen peas bag was mentioned? It was almost 100%. Now, who wants to put a frozen vegetable bag on your body? Or you probably will need a duct tape just to wrap that on your body, just to make sure it fits on you, right? your head, your knees, and so forth. Or perhaps the doctor may suggest, order an Amazon Prime. Well, guess what? Time is of the essence, right? By the time you order from the Amazon, even with Prime, you already lost 72 hours of immediate time of healing. Remember the global trends, latest trends and issues that I mentioned earlier? Well, Pure Heart is here to contribute, to mitigate that. Perhaps in a smaller or bigger way, but we all have one common goal here, right? Which is about patient safety. Pure Heart Gel Packs is just one of the cryotherapy modalities, or perhaps traditional modalities. But what is very unique about our products is that how it's contoured to fit and hugs each of the body perfectly. We conducted a very intense research and developed with a total 125 unique products to ensure that we cover the most common conditions of minimal procedures up to the most critical intensive procedures. Now, these gel packs that I'm about to show you are patients with condition with the type of carpal tunnel, ankle replacement surgery, arthroscopy, joint fusion surgery, Achilles tendon repair. My most favorite one that we created, which is hands-free, tie-free, and basically just floats in your body. You know what Band-Aid is, right? Well, we're calling this Kool-Aid. Herniated disc surgery, spine osteotomy, vertebroplasty, bone marrow aspiration, etc. Orthodontic, jaw osteotomy, maxillofacial surgery, rotator cuff surgery, shoulder arthroscopy, shoulder dislocation, thigh-plasty, inner thigh lift, lower and upper leg wrap, calf augmentation, cutaneous lymphoma. Pure Heart Gel Packs are anything but standard. It is high time for this innovative products and idea to come to the surface. Our products are safe and built with high quality products. It's direct applications. There's no freeze burn, no heat burn. But most of all, why put a block of ice bag and wrap it using tape when you can just use this? We can get all creative about how we use the gel packs alone, but if we're in pain and in bed, we want that relief to come as soon as we want that relief to come as easily and simply as possible, right? And that's what Pure Heart strives to do. It is leak-free. There's no sweating from the plastic, unlike regular plastic bags. BPA-free. The material is eco-friendly and recyclable. And we made sure that all corners are rounded and not pointy. Very flexible, and even when it's frozen. And it's FDA compliant, meaning it's an exempt under Class 1 or general controls. And regarding the gel packs, ingredients, and materials, we made sure that it meets the entirety of safety measures. It is excluded from the California Proposition 56, which is the list of bad synthetic chemicals, which causes cancer, birth defects, and reproductive harms. But most of all, our gel packs are very cost effective in comparison with the gel packs that you see in Amazon nowadays or any other website. You can either dispose it immediately or use it over and over again. To simply put, Pure Heart will be covering servicing the whole entire healthcare realm, from common injuries in ER, oncology, orthopedic, reconstructive, sports medicine, ophthalmology, hair transplant, oral, and we also do customization. If we can apply these gel packs, whether it's a hot or cold treatments, we can beat those studies because we have this medical device available at home or at work. Pure Heart is here because we want to be part of your healthcare best practices. We want to connect with you, and we hope that you welcome Pure Heart and with your open heart and embrace this new innovation. Because after all, we all have one common goal, and that is safety for our patients within the healthcare realm. Shukran.
Thanks, Maria, for this lovely, amazing presentation. I will open the stage only for one question or comments because time is running.
Actually, there is no question, so we will give you your
If you
certificate.
guys want to see my job, actually can.
Can go.
Okay.
Okay. Great.
Thank you.
Okay, let's maximize it. Thank you. Amazing.
So now our speaker is Dr. Turki Asabhan from KSA. I'm passing him the stage to deliver his speech on the impact of working environment components and local and expedited nurse job satisfaction, burnout, and intention to live in the GCC and Jordan hospitals. So, Dr. Turki, the stage is yours.
Thank you. Hello, everybody. Thank you, dear Amal, because you are the reason for me to be here. Some spoke about turnover, some about quality. We brought them all together with the GCC and Jordan as well. Yeah. So I'm going to move really quick to introduce myself. As I graduated from Texas Southern University in the United States with Bachelor of Healthcare Administration, Masters from Malaysia, University of Puerto Malaysia, and I'm PhD candidate in Deakin University in Public Health in Australia. My Viva discussion will be after 1 month, so wish me luck, please. Even if when I registered for the conference, I said, come on, what did I do? Sorry, don't be mad. However, I'm public health instructor in the Saudi Electronic University. I'm healthcare administration instructor in High University in Saudi Arabia. And I'm certified trainer in healthcare management in the Ministry of Health, as well as I'm certified surveyor in health. I'm also certified surveyor in healthcare leadership in Ministry of Health in Saudi Arabia, but I haven't practiced any profession. I just was an instructor in Saudi Electronic University for 6 months. Because I completed my bachelor, right away master, right away PhD. Now I'm going back to the United States to do postdoctoral in Texas A&M University. So yeah, imagine with 33 years old, didn't do anything, just studying. Okay, here are the outlines. We will start with introduction, the impact of working environment of nurses' job outcomes, literature search strategy, selection criteria, results, main characteristics of the studies, discussion, conclusion, and recommendations. So the 6 GCC countries with Jordan occupies a very significant location in the Middle East. The ministries of health in the 7 countries are responsible for the provision of healthcare service. They are also responsible for the regulatory mechanisms of health service, including health policies, strategies, planning, etc. Unfortunately, the healthcare systems in the 7 countries are heavily dependent. They are heavily dependent on nurses, as every healthcare system in any countries. The number of nurses are the highest. But you know, this percentage with Jordan, if we exclude Jordan, it's going to be higher. The percentage of foreigners or foreign nurses or expatriated nurses. However, let's agree that high turnover rates leads to nursing shortage. High nursing shortage leads to poor quality of healthcare delivery. the poor quality of healthcare delivery leads to patient dissatisfaction, low patient satisfaction, and extra pay to employ and train new employees or new nurses. Subsequently, there is a need to identify the quality of nurses' work environment, as it could be a possible reason of nurses turnover. I personally published several papers in job satisfaction, in turnover, and intention to leave among nurses. I found them slightly satisfied with the three aspects. So it could be the quality of work life among nurses. Currently, I'm working on a study, a cross-sectional study with mixed method, quantitative and qualitative. For now, as of time, my Viva is coming soon. I conducted this statistic review, and I found very valuable information, results, and recommendations. This is the literature search strategy, just for the sake of the type. Sinhal, Midline, Science Direct, and PubMed. The selection criteria, the inclusion criteria was a paper published in English, studies published from 2015 onward. Study sample included nurses. We moved to exclusion criteria. Paper published in language other than English were excluded. Studies published before 2015. And the research designs other than quantitative or qualitative, as we used a questionnaire to measure the job satisfaction, intention to leave, and burnout level. The result shows that we had 23 studies included. We started with 155. The studies were 6 in each Saudi Arabia and Oman. It's a good number compared with other Arab countries, as well as 4 in Jordan, 3 in Qatar, 3 and 3 in United Arab Emirates, 1 in Bahrain. Unfortunately, based on available literature, we didn't identify any study in Kuwait. But the socioeconomic factors in the 6 countries, the GCC 6 countries, are similar. So we can apply the results in the whole 6 countries. Would work in Oman or in Qatar, work in Kuwait or Saudi Arabia, etc. Here are some characteristics of these studies that included. We got these 6 studies. They showed or called to improve the quality of working environment among nurses, to increase job satisfaction and decrease the turnover and burnout. So in the most studies, we found that staffing and resource adequacy, nurse managerability, leadership and support, nurse relations that include physician and nurse relations are very important, and they were associated with job satisfaction. Also, the peer support, participate in hospital affairs, foundation for quality of care, staffing and staffing adequacy were critical for nurses' burnout. Some job-related benefits, such as housing, financial support, were important for nurses' intention to stay in the profession. I'll discuss that in the conclusion. However, the current systematic review found that supportive nurses' working environment leads to higher job satisfaction, lower burnout and intention to leave levels. Healthy and supportive nurses' working environment help to improve the quality of healthcare services provided. Also, further studies are needed to explore the impact. Furthermore, qualitative method and or mixed method cross-sectionals are important to gain a deeper overview on this issue. This is the final slide. Here are the recommendations. What do we need to create a healthy and good, high quality of working life among nurses in general, to keep them in the work and ensure they do their best at their jobs? For the GCC and Jordan hospitals management, we recommend them to provide longer term contracts, especially for expatriated nurses. In the GCC and Jordan, I'm not sure about Jordan. I need to look furthermore. But in the GCC, the contract is yearly renewed. So they every year renew the contract for nurses. Make it higher in terms of time, addressing the employees' work and family needs. Some countries, such as the Saudi Arabia and Qatar, not in all cases allow nurses to bring their families, either their children or the husband or etc. So be flexible in this point. Providing equal rights don't vary between citizen and foreigners. Some local or citizen nurses receive higher financial benefits than foreigners. They do the same, but this group of people receive higher financial benefits. Okay, we go to the government applying minimum wage for foreigners. For the GCC citizens, all the countries have minimum wage of salary, but for foreigners, no. So applying a minimum wage for expatriated nurses, allowing family visas, ensure economic growth in more remote provinces and to promote workplace stability. For future studies, conduct nationwide studies to collect more responsive data, conduct mixed method studies to understand the factors behind the job satisfaction, burnout, and intention to leave levels. Any questions?
Any questions for question? Actually, no more.
Okay. Yeah, thank you so much. Okay.
Okay. Let's. Yes, this is the first is هذا عند course book. Yes, this is the first slide. Yes, this is first slide.
Okay, our first poster presenter is Prof. Paul Opala from USA. I'm passing him the stage to deliver the speech and using technology to ameliorate the effects of healthcare staff shortage during pandemic. So, Prof. Paul, the stage is yours.
Good afternoon, everyone. Can you hear me? Can you hear me? All right, good. By the way, thank you for the introduction. My first time being in Dubai.
You like the weather?
Yes, I do. Actually, I'm from California, so it's actually hot, very extremely hot right now. So when I came to Dubai the first time in the airport, I was like, oh, it looks like California, so I love it. Logical, 60% of the articles noted that the workforce shortage in the clinical setting can be addressed through the adoption of technologies that facilitate the delivery of care through virtual reality. Most of you guys will agree that we have so many of them. The first will be telemedicine. The key term to this will be to reduce the in-person visit. So rather than see the patient one-on-one, like in real time, you're actually using technology to do your patient visit. So telemedicine is one of them. The other one will be remote patient monitoring. I know you guys may be familiar with that. It's called RPM. It's part of, it's kind of a device that patient wears and is connected. So patient can wear the device, and connect the device in a way that we, the healthcare professionals, can access the logs to ascertain the any negative impact or how to intervene in case if we see any differences or the patient is not doing well. So these are also ways we can use to kind of reduce in-person visit with the patient directly in order to curtail unnecessary challenges. The other one will be the robotic assistance. Robotic assistance has been very helpful to navigate through the challenges during pandemics. We had that with medication delivery, also with surgery, and also with disinfection. So robotic devices. Now, there was a speculation that I heard, I'm not sure that is true, that soon we're gonna have robotic also with airplanes driving, flying planes instead of actual humans. But it's still on the way, and I'm not sure how true that could be. But that's also very big. That would be a very big approach to other challenges ahead. Now, the other one will be the AI and automation, artificial intelligence. So, such as machine learning algorithms and natural language processing. These can assist healthcare professionals in diagnosing diseases, analyzing medical images, predicting patient outcomes. Automation can also handle any other routine administrative task, freeing up healthcare staff in high-risk areas, minimizing exposure and enabling them to focus on critical patient care. Again, the key word here is to reduce the inpatient visit in order to curtail unnecessary shortage of staff. All right, so looking at the figure right here, it's very tiny. Can I zoom it a little bit? See. Maybe this way. All right, so various authors actually provide a summary of the findings. The first author, you guys may not be able to see that, address crowding in the inpatient setting. You could recall that during the pandemic, in the emergency room, we're full of patients. And we had patients that were supposed to be seen for something also very serious, but we couldn't see them because of the impact of the COVID. Even the loved ones will be excluded from seeing their loved ones in the emergency room because of pandemic. So these authors provided their findings showing that there are ways we can meet the needs of these patients as well. And the other one provided information about how we can actually facilitate home-based care for all these patients that need equal care when it comes to this type of diseases. The other authors also provided the findings pertaining to implementation of these technologies and how that can be made possible. So now the goal is, if we have to go through the same process over and over and over again, how do we deal with the challenges? What will be the possible barrier to implementing such devices in our healthcare industry? I would think one of the biggest barriers will be accepting the change. And also the second will be management intervention. And if we don't have that support from the management, there's no way that can be made possible. But the goal will be to understand that even though we have gone through COVID, we don't know what lies ahead in the future. We need to keep up and understanding that there are other avenues to care for patients. During COVID, many people lost their lives I lost my very good friends, fortunately. Those here in America. I'm also from Nigeria originally, but I moved to the US in 2001. I lost my loved ones, so many of them that died of COVID. So during that time, I had to build this, I had to write this paper, I had them published, and I spread this information across in order to help many people in those hospital settings. All right, so in conclusion, the use of technology really enables, based on the findings from these authors, the use of technology enables healthcare managers to address challenges associated with workforce strategies in inpatient settings, such as an emergency department, an ICU, and home-based care. So recommendations will be that managers need to adopt effective ways of addressing the challenges, such as financing and other legal challenges to facilitate effective adoption of technologies in the management of COVID-19. And I can remove that term COVID-19 and add something else on top of that. Again, it has to be the same process of handling these pandemics, just in case it happens again in the future. So I'm going to stop here, and I think which the speakers are there.
Thank you very much for all great explanation for your amazing topic. If there's any questions, just raise your hand only in 1 second. You don't have too many questions.
Thank you.
Okay. So.
I have just one question. We go fast for artificial intelligence, as we see. Do you think one of the challenges will replace the human resource? Do you think it will replace the nurses and doctors in the future, like the robots in OR, automated machines doing this checkup? Thanks. It will replace in healthcare?
Well, the goal is not to allow that to replace healthcare. That's my goal. That's our goal, not to allow that to replace healthcare. But in cases like we can handle it, then yes, we can implement that to assist with routine tasks so we can save resources. That's the most important thing. But we can use that as to replace the actual, I don't think it's necessary at this point. But yes, if we have to go through tight challenges, we have no choice but to adopt one or two things to alleviate some possible issues. Yeah.
Thank you very much.
You're welcome. Okay.
Yes. Our next speaker is Dr. Noor Al-Khoury again from Qatar. I'm passing her the stage to deliver the speech on special consideration and the imaging of the women and children. Dr. Noor, the stage is yours.
So I apologize. I'm going to be moving a bit fast because I have a plane to catch. So please, I'm sorry if I'm going to be talking a bit fast. So last time we discussed a lot about appropriateness of imaging and imaging appropriate. And now it's a different side of quality and safety. So we'll be talking about other special considerations when you think about imaging in women and children specifically. As maybe I mentioned before, I work in a women and children's hospital. We don't really see any adult patients other than women, pregnant women, etc. So it's a very specialized center. And I'm just wanted to share my experience and talk more about how different we are from other regular hospitals. So In the beginning, I just want to remind everybody the 6 aims of quality improvement as defined by the Institute of Medicine, because this will be the framework where we'll be discussing quality and safety. And then we'll talk about some other safety risks in imaging, and then discuss some practices, best practices, and share tools for improvement. Just something to keep in mind, children are not tiny adults, okay? A lot of people think that a child is just a smaller version of an adult person. That's not true. There are certain considerations that we keep in mind when you have a child. They're not the same. They have different diseases. They're always changing. They're always growing. They're always in a state of growth. Even the same disease in a child, in an adult, will manifest differently in a child. So they require very specialized care. That's the point. And also remember, when you deal with children, you deal with their families. So your healthcare entity has to be geared toward family-centric care and ways in which you can deal with families, not just the child itself. So the 6 aims of improvement as defined by the Institute of Medicine, what are they? Safety, effectiveness, timeliness, efficiency, equity, and patient-centeredness. These are the 6 quality goals, and we'll be discussing them in detail. What is safety? That's pretty much straightforward. Providing a safe level of care that's based on scientific knowledge. Again, using evidence-based, as we talked about before. In children, we also ensure that there's something called a LARA, which is as low as reasonably achievable. And this is something we practice a lot in radiology in children, because we don't want to radiate them too much. So we're always cognizant of how much radiation we give. We try to minimize it as much as possible. We mentioned previously, we try to avoid CTs, for example. And then also in children, a lot of times we need to sedate them before we do the imaging. So safe sedation is a must. All our anesthesiologists have to be pediatric anesthesiologists. And also there are a lot of hazards related to machines, especially MRI. We also want to be careful about falls because a lot of our patients may have special needs. They may be immobile. So falls are a big topic in this kind of environment. Obviously preventing infections and ensuring medication safety. In terms of effectiveness, effectiveness basically means, is the treatment effective? Does it work? And does it provide the response that we need? And again, this has to be evidence-based. So everything we do has to be evidence-based. In our hospitals, we have a lot of MDTs. So MDTs are basically meetings between different specialties. And that's very helpful because we want to coordinate care, ensure good communication. That's really the basis of good patient care. And of course, we have defined protocols. We do a lot of peer review or peer learning within the radiology department to make sure that we all learn from each other's mistakes. This is a very big quality improvement initiative. And we try to standardize the reports and standardize our protocols as much as we can. In terms of timeliness, I think Dr. Ahmed was also mentioning this. Part of quality is timeliness. What's the point if you have a great study and you did a great exam when it's not on time, when the patient needs it, right? So our exams and our reports have to be done at the right time, and they have to be available to ensure that the patient can receive the right treatment. Our informatics and our PAC system also has to be very smoothly running, because obviously any interruption will have implications on patient safety, and communication is a big deal. So that has to be perfect. In terms of efficiency, we don't want to have any waste, in particular wasted equipment, supplies, also ideas and energy. That's something we don't think about when we discuss waste, but time, right? Emails, unnecessary meetings, clutter in your email. Those are all forms of waste. So we try to minimize that as much as possible. And in terms of the imaging, we don't do repeat imaging. We minimize the wait times for patients. When we buy an expensive machine, we want to make sure the machine is working as much as possible, because idle time is a waste. So time that the MRI machine is not working is waste. So all of these things, we have to keep in mind when we discuss efficiency. Equity. So obviously, we try to ensure a standard of care that does not vary regardless of the type of patients that we see, their nationalities, etc., geographic location. Our pediatric hospital in Qatar sees patients regardless of what nationality they are, and they provide free service to all the pediatric patients. And this includes cancer treatment, which is very expensive, as we know, but in Qatar, this is provided to them for free because it's part of the charity that we do. And so we provide expensive chemotherapy and things for patients, even when they're not, Qatari by nationality. And obviously the same goes to women as well, yeah? Patient-centeredness, again, I mentioned it's a child-friendly environment. We also pay attention to the moms, the dads. We know that, they're very stressed. They have their own issues that we have to deal with. So all aspects of the hospital is really geared toward the patient or children and their parents. So if you notice, the environment maybe look very different from a normal adult hospital. Everything is very playful. Even the decor, even the things that we use in the hospital are just meant to be used by children. And we always respect privacy and confidentiality, just like in other hospitals. This is a part of a report summarized by WHO, showing basically the how much radiation that children get from imaging. So if you notice here, they have different pie graphs, and this is just sources of radiation, different sources of radiation. You can see that in a lot of developed countries, a significant portion of the total radiation exposure is from medical imaging specifically, and that's shown in the blue. The UK is less, you can see there. And it really kind of goes with the trend about CT, because in America and I guess in Germany as well, there's heavy CT use. And so you can see that there's a direct correlation with how much medical radiation patients receive. The other sources of radiation are sources of radiation that we as humans are exposed to on an everyday basis. So everything in our environment, there's radiation that we're exposed to. When we ride a plane, for example, when we eat a banana, there's some radiation there. Like there's a lot of sources of radiation in the background. And that's normal. You cannot escape that. But, we try to minimize how much medical radiation we get. Main sources, obviously CT is a big one. And X-ray to a lesser extent. So the amount of radiation with X-ray is very, very little. But again, when someone gets repeated X-ray, then that becomes a problem. So we pay attention not only the type of radiation, but how frequently they're getting it. Fluoroscopy, which is basically real-time X-ray, that also has significant radiation. We have techniques to reduce the amount that they get whenever they do procedures. And interventional procedures also have some element of radiation. Nuke med, nuclear medicine, also significant radiation dose. So all of those things are, contributors to radiation in children. Notice how it doesn't include MRI and it doesn't include ultrasound. So ultrasound does not involve radiation and MRI does not. MRI has its own risks, which we'll talk about later. Most of the research that we have about radiation is based on data that was collected during the aftermath of the atomic World War. So a lot of the data is very, very old, and it's based on survivors from the the Hiroshima Nagasaki explosion that happened. So, there are a lot of ethical reasons why we don't have other studies, right? As you can imagine, we're not going to radiate people and follow them up over time. So the closest we can get is the data that we have from atomic bomb survivors. Just something very important to keep in mind in children. So their tissues are more radiosensitive. They're developing, especially thyroid, their gonads, reproductive organs. In women, breast tissue is something that's very active. And that's why when a woman gets a CT scan, we try to shield that area, avoid that area if possible. In a child, you avoid the thyroid, the brain, the skin, etc. And also children have a longer life. So because of their lifespan is longer, they have more time to develop cancer. Whereas in an older patient, you may not worry so much about them getting a CT. If it's a 60-year-old getting a CT scan, no big deal, right? How long are they going to live anyway? But children, they're going to live a long time. So that's why it's really key to minimize how much radiation you do. And also using, even with the same CT parameters that you're using for an adult, on a child, the same parameters, so the CT, the settings on the CT machine will result in higher radiation on the child. So just something to keep in mind. There are a lot of campaigns that have been in place to ensure that we minimize the radiation. So I mentioned ALARA, that's like one concept, but there are other campaigns like Image Wisely, there's Image Gently, specifically for certain parts of radiology that we do. Step Lightly, for example, refers to fluoroscopy procedures. So these are just different campaigns that have been in place in the US and in America for quite some time now. And we always try to follow them because they ensure that the child gets less radiation. There are some other unique risks related to MRI in children and in general, but specifically in children. So MRI can cause peripheral nerve stimulation if the patient is in there for a long time. The RF pulses with the MRI machines can sometimes elevate body temperature, so it can result in heating effects. Neonates or newborns have very immature thermoregulatory systems. They can't regulate their heat as an adult can. So a lot of the dose or a lot of the heating that can be caused from an MRI can be dangerous for a child. We don't really know yet how much damage MRI does, because still we need to have more research done in this area. But there are some studies that perhaps show that MRI can alter genes. So it can alter the genetic, structure in cells, so genomodulation, and sometimes result in intracellular changes. So again, yes, it's very exciting. We have MRI, it doesn't have radiation, but MRI can also have its own harms. So just again, this is why it's important to do appropriate imaging. Projectile injury is a very serious problem with the MRI machine. If someone has a watch or metal, or if we don't have MRI safety procedures in place, that can result in severe injury. Showing here one example of a horrible thing that happened where a child was killed because of a projectile that happened. An oxygen tank flew across the room and it crushed the child's head. So this just shows you how important it is to have safety measures. You ideally, like for a child to get medical treatment, they should go to a pediatric hospital. If you are an adult hospital that's not specialized in pediatrics, refer them to the right place, because things like this can make a difference, and you have people who are specialized and who know about these risks, and they can help better take care of the patient. As I mentioned, sometimes with children, they don't hold still in the MRI machine. So you need to have some sort of sedation. MRI studies can take up to 45 minutes, 2 hours, up to 2 hours sometimes. So you need to sedate them, and sedation has its own risks as well. So if you over sedate the person, the child, they can have respiratory depression. If you under sedate them, they can move, and that can result in a waste of the MRI machine. And so MRI scans can sometimes be very unpredictable. You have different risks related to monitoring devices or adverse reactions. There's some evidence of neurotoxicity, especially with repeated anesthesia. Sometimes there's people who say that this can affect the brain of the child. So just, again, keep in mind, there's harms. And some ways we try to minimize this at our current hospital is we use something called feed and bundle. So we feed the child, we let the mother feed her child, and then sort of wrap them and put them in the scanner, and they're relaxed and they hold still. And that kind of sometimes helps us avoid anesthesia. We also have child life support teams, they're called, where they can help the child relax. They can put an iPad, or they have different techniques on how to help kids, sit still in the scanner. Sometimes we give them movies to watch. So all of these things, you find in your pediatric hospital. This will not be seen in another place. There are contrast-related risks. IV contrast, so the one we use for CT, that can have a list of reactions here. The one in MRI, which is different, also has other risks. And there are some studies that show that, there's some deposition in the brain. So we don't really know yet about the long-term effects, especially in children who get repeated MRI with contrast. So there's studies that show that that's maybe not a good idea, but again, it's very preliminary at this point. And then of course, oral contrast, yes, that has some risk as well. So the basically conclusion is, remember the 6 aims for improvement according to the Institute of Medicine. Remember that women and children are special and they require a special hospital and they have unique risks. The risk of radiation are always greater in children compared to adults. Read about the different campaigns and efforts that are meant to decrease radiation dose in children. And again, just refer them to qualified areas if this is something that you're not specialized in. Thank you so much. And it was really I'm really happy to be involved, and it was really nice to meet everybody. And I just want to thank Amal for organizing this. She did a great job, and thank you so much, Amal, for everything. Thank you.
And pass the stage only for one question, Shia must be. Actually, not one question. Again, chances. Okay, not by phone, so the one.
عايزة ترجعي؟ سوي قائد الشعر صوريني دورة نور الحرف شوي هون على بنص جاهزة؟ شوي
Awesome. Thank you. If you have another,
ما في شيء
Yes, now we will have a break for 15 minutes, and after that we will continue with Ms. Amir.
Okay. I know I can do that. So tomorrow's nice. Thank you. Early in the morning. Yes. So, not that early. Pretty much 8, right? Just have the breakfast. What is that? That's tonight, tomorrow. Sleep 1 o'clock. Thanks to the last we sleep in that one. It's not me. I'm relaxed. Actually, it's a cold water. I see you do it now. Yeah, no, don't worry. I think it will go to me. Well, look, in the time, maybe it's not more of a no, I don't leave till the very last minute. Who's recording it?
Who's the recording? I will send the recording.
Yeah.
I'll the video.
I get it.
No, I mean, no, I get that. I mean, it's basically, can we do a tripod? Have you got the equipment you need?
No.
Martin finally is coming here. Yes, this is here. He's outside here. Already. Yes. I was thinking first you have to speak about your experience for today and contributing and encouraging people to attend our conference in November and was important 10 to 18 conference. You can say what it interesting. 2, 3.
Hi everyone, my name is Chris. I'm a professor of health sciences from California State University, San Bernardino. I'm here in attending International Nursing, Healthcare Management, and Patient Safety. It's so good. Of course, I've been invited. The first time I attended this conference, what I saw here, it just amazing. People from different cultures, different traditions, sharing their experiences in healthcare. So many physicians, nurses, healthcare professionals, professors, educators, it's just amazing. The next conference is coming up in November. It is in Los Angeles, California. And I'm encouraging all of you guys to please register. Your experience will never be the same if you attend the conference. It's really encouraging. Tell your friends or loved ones, bring your family to enjoy the experience that we have here. So I appreciate it. I hope to see you guys soon. Thank you.
Thank you. I hope you know something. Yes. Say what you want to Thank you and have a lovely day. We got to get it. Okay.
البرزنتيشن
لا احنا
بس هي تحت يعني مفتوحة ولا افتحها أنا؟
أنا بعرض لك إياها، هاي حطيت لك إياها هون، أوريدي إحنا فاتحينها أصلا. استنى سكرينها لأن ما سكرها هلا ماكس. اوكي خليها ريدي عشان لما يجوا بنبلش بالبرزنتيشن.
سو أنا بكتب بوس انتر. اوكي.
in the social session. And then I'm going to second session. How about that? And wow.
How you doing? Colleague. Oh, right, cool. I had no idea. Robert, your colleague. That's someone's colleague.
No, actually, it's the two projects that we worked on. He worked on a separate project.
Got yeah. It's good to get out there, isn't it? What's that? You do know that it's not just about doing things.
I know. So welcome everyone from back again from our coffee break. So I would like to welcome our keynote speaker, Ms. Abir Hamami from UAE. I'm passing her the stage to deliver the keynote speech on From Theory to Practice, Applying High Reliability Organization Concepts in Healthcare Through the Power Operating System. Ms. Abir, the stage is yours.
Thank you, Ms. Amal. Assalamu alaikum. Good afternoon, everyone. Hello. Let me introduce myself. So I'm originally a graduate of pharmaceutical sciences from King Saud University in Riyadh, Saudi Arabia. I hold a master in international healthcare leadership from Manchester University. I used to be working at King Faisal Specialist Hospital as an acting assistant chief quality officer and a deputy director quality management. Also, I've been participating with the Saudi, with the Central Board for Health Accreditation, SBAHI, as a hospital surveyor for more than 15 years. I can describe myself as a transformational leader, curious about and passionate about driving change and improving quality, patient safety, and patient experience, exchanging learning. And that's why I'm really delighted to be here among all of this great group of expertise here. So as you can see, my presentation is about moving from theory to practice, applying high reliability organization concepts in healthcare through the power of operating system. Anyone familiar with the term high reliability organization? Did you hear about it before? Excellent. Okay, so we will learn more together. So this presentation, we will together answer the questions and understand why we need to adopt high reliability organization, what is HRO, and how is the theory implemented, what can be the evidence of its successful implementation, and are there any challenges or barriers for its implementation? How we are going to do this, of course, I will introduce very recent systematic literature reviews that looked at implementation of HRO at an organizational level. There are multiple unit-based HRO implementation, but this literature involved reviewing its implementation at an organizational comprehensive level. The literature also include looking at assessment tools and how can we again know if it's implemented successfully or not. And I will compare and map the experience of King Faisal Specialist Hospital, where I used to work, with this literature-based information on HRO, and then share any learning or challenges from this study. So this is the outline of the presentation. So let's see this. I'm sure that we all should agree now and have a certain understanding on how safe is healthcare, in your opinion, compared to these high-risk areas like airline, nuclear plants, aviation, mountain climbing, bungee jumping. Where do you see healthcare among these industries? Both sides. Okay. Any other answer? So it compares among different industries the number of fatalities and encounters with the total number of deaths. Excellent. So surprisingly, healthcare industry lies among the top hazardous industry, believe it or not. Patients come to healthcare to be healed, whereas they are entering a very hazardous, complex system. So let's see this by numbers, comparing this by numbers. So if you remember, even Hiba in the morning, she shared this statistics from the WHO. Like in high-income countries, 1 in 10 deaths occur in hospitals. In the middle-low-income countries, 2.6 million deaths occur annually in hospitalized patients. Globally, 4 in 10 outpatients are harmed. And the cost of harm carries 15% of the healthcare expenditure. So imagine 15% of the expenditure is related to the impact of adverse events or medical error. But the good news is 50 to 80% are preventable. The impact of harm is not just, when we say harm, it's not just death. So we have even other level of harms or other impact of harm that could be on the patient and families and community, like emotional harm, mental harm, and physical harm. And also this carries a burden on families and communities, and of course, lost staff time. Let's see on healthcare systems and economy. Of course, this carries an increased additional cost of even acute care managing the adverse event, or sometimes continued cost of the chronic or continued care resulting from that harm. Indirectly, yes. Oh, sorry. Okay. Is it better now? Can you hear now? Okay, okay. Okay. So indirectly, this affects a longer length of stay, reduced access, and unable to invest resources in other opportunities in healthcare. Comparing this with aviation, look at the statistics starting from 1968, every 10 years, and seeing how is this reflected with the risk in death. 1 in 350,000 boardings as we go down. Reaching our statistic in 2022, we find that 1 death occurred in 11 million. So in aviation industry, as they proceed starting from 1968, the risk of death is minimizing to 1 every 11 million. So definitely there is a lot to learn from these industries. And that's why they are called high reliable organization. So what is high reliability organization? As you can see from the picture, these organizations, they are organizations that operate in high risk, dynamic, turbulent, and potentially hazardous environment, yet operate nearly error-free, as you can see from the previous statistics. There are a lot of initiatives and directives implementing high reliability organization in healthcare. And I can share these major hallmarks, starting in year 2000 by the Joint Commission, where they called to adopt high reliability organization concepts. Moving to from 2001 to 2015, there were a lot of publications by researchers looking at and addressing the characteristics of high reliability organization. You can, I'm sure maybe you are encountered Wick and Stuckfield researchers who published 3 editions on high reliability organizations. On 2008, the Agency of Healthcare Research and Quality published a white paper that addressed organizations who became high reliable organization, and they explained their journey. They interviewed leadership of those organizations, and they shared the lessons adapting these concepts into practice. Also, the Joint Commission Center on 2008, they established the Center for Transforming Healthcare, which offer servers and expertise to organizations who want to transfer to high reliability organization, and they offered certain worldwide initiatives that any organization can participate with. And by 2013, they released their framework, and we will be talking about it later, High Reliability Healthcare Maturity Model. In 2017, the Institute of Healthcare Improvement, IHI, released also a framework known Framework for Safe, Reliable, and Effective Care. So these are the major hallmarks applying HRO concept in healthcare. So let's learn together. So when we say HRO, as we mentioned, researchers studies this organization, and they looked at all their characteristics. And they all agreed on the 5 major characteristics, as you can see here. So first is preoccupation with failure. These organizations, they always think what can go wrong every day by everyone. What can go wrong? And they are sensitive to their operation. They always think, is our operation working well? Is the process designed to yield the best outcome? Are we having the good systems in place? They defer to expertise. They listen to the front line. They listen to the people experienced in their processes, how we can continue improving. And they are resilient. When any error happens, they report and they learn from this incident or from this event. And they are reluctant to simplify. So again, when error occurred, they ask why and why and why, and they dig deeper until they find the root cause. So all these 5 major characteristics, they are shared among all these high reliable organizations and high or hazardous organizations. So adopting these 5 main principles or concepts can encourage a state of mindfulness that whenever we come to our jobs every day, we need to perform the right thing right from the first time and every time for every patient, translating this into a high reliable patient care. So in general terms, high reliability in healthcare means exceptionally safe and continuously high quality of care. So how can we move from this logical model or theory? We need, of course, to operationalize this and turn this into an operating system. What is needed in this case, in your opinion? How can we start? These are principles. These are characteristics of like behaviors or characteristics of concepts, but how can we turn this into reality and become embedded in our daily practice? What do we need to start with?
Ooh.
Yes, please. Please. Yes.
Is it where the aviation sector, when you've got all those things, the other things you mentioned, well, the health sector's a lot bigger because it has a lot more different organizations. You've got community, you've got acute, you've got diagnostics, all these different things, pediatrics, geriatrics, rehabilitation. So there's different risks for all of them. But how can you implement what happens in the risk factors of that sort of organization, like that, to more broad organizations?
Yes, I hope now with these slides I can answer this. Yeah. Okay, yeah. So we need to have a system in place, and this can be started by framework. A framework that provides the largest umbrella that can guide the creation and organization of such a system. And we will be introducing some famous framework in this regard. We need to have strategies in place to turn these concepts into practices. And we need to have methods, practices in place, and most importantly, goals. So all these four levels can move us from theory into practice. But how would we know that we are there yet? We need to have assessment tools. So all this will operationalize the 5 main important concepts in high reliability organization. We will start learning about the famous framework. So the VA did a systematic review since 2010 to 2019, keeping in mind that organizations started implementation following the 2008 IHI or 2008 Joint Commission work. So they looked at literature, explaining their experience about implementing those concepts. And they found that among those organizations, 8 frameworks were used. The first one was the Joint Commission High Reliability Healthcare Maturity Model, the IHI Framework for Safe, Reliable, and Effective Care. The third one is the American College of Healthcare Executives Culture of Safety Framework, and the Johns Hopkins Safety and Quality Management. Also, there's another framework for Johns Hopkins Medical that concerned operating management systems. The number 5 is the Office of the Air Force Surgeon General Trusted Care Framework, and the ARC model, which is related to implementing evidence practice with nursing professionals, mainly for nursing, and high reliability team frameworks. So among the organization who implemented these concepts, they used these 8 frameworks. How are these frameworks were developed? Among either literature search, consensus among expert and content expert, pilot with existing leaders or existing organizations, or analyzing of high-performing organizations to see what are their practices, characteristics, and if there are specific trends. How were these frameworks used at their organization? Most of the framework were used at organizational level, across the board, across all services, from executive leadership to frontline, except for 2 frameworks, which are the military one, which was signed for the military services, and the ARC model, which was designed only for the nursing staff. The IHI also included a patient and family level, where they also involved patients and family. Where can this framework used? So again, literature showed that they were used in all settings, acute, chronic, hospital-wide, except again for the Air Force framework. It was designed only for the Air Force medical services. So moving to strategies, we have developing leadership, data systems, implementation intervention, culture of safety, training, and learning. Among the shared frameworks, these were the 5 most important strategies. Methods: leadership rounding, huddles, training, just culture reinforcement, good catch celebration, unit-based continuous improvement, and annual assessment of the infrastructure. As you can see, these methods, they are aligned with the major 3 categories of most of those framework, which is process improvement, culture, and leadership. Looking at the goals, as was mentioned by Dr. Noor, it was very important to identify what could be the aims to improve quality in your organization. So of course, we introduced the most important, famous one, which is the STEEP, the one that comes from the IHI. And literature showed that HRO touched base mostly on the safety dimension. It touched base on all dimensions of quality, but most importantly on the safety one. And that's why even at King Faisal Specialist Hospital, we focused on zero harm as one of our aims, where specific metrics should be assigned to measure these dimensions or these aims. As you can see here, either decrease the safety, harm events, decrease the complication, mortalities, outcome, and increase patient satisfaction, increase patient culture reporting, compliance, and even improve the outcomes. Going to the assessment tool, the literature explained 4 levels of assessment tools, either following a qualitative framework where they go through a specific like theme analysis, or using a survey. It could be validated or non-validated, or safety culture assessment, keeping in mind that having a safe culture means that everybody is mindful about improving patient and quality, and this is why it can be measured as a dimension for HRO. And the last one is following an integrated assessment. Usually there are some well-known like consultancies or expertise where they have their own specific trademarked assessment tools, where they go through a review of documents, data review, observation rounds, and stakeholders interview, like the Reliability Governance Index introduced by Pilsgeni HPI, the one that we used at King Faisal. In addition to these systematic organization frameworks, strategies, methods, and goals, there are some complementary elements, as you can see here, like project management, change management, workforce engagement, technology and innovation, transparency and communication, patient engagement is very, very important, and leadership and accountability. So it starts from the top level, creating the vision, creating the mandate for change, adopting zero harm as a major focus and aim. So now I want to introduce our experience at King Faisal Specialist Hospital, Zero Harm HRO journey. This is the roadmap for our safety HRO journey. It started with an assessment, as you can see here. And then we identified certain focus areas among this assessment tool. And the roadmap focused on 4 major lines, which include, which include universal skills among all staff, leadership skills, learning organization and concentrating on cause analysis, and robust process improvement. Of course, focusing at the end on sustainability and embedding the practice in daily processes. So the journey was 3 years, and I can share some of these highlights. So we were able to save lives 1,118 lives from our quality aims, CLAPSI, SSI, VTE, pressure injuries, falls, all these performance improvement projects that focused on these quality aims. The cost saving from these incidents or events were around 87 million, of course, based on the cost by event from literature. More than 19,000 staff were trained on best practices, and we decreased the harm event by 38%. So this is a huge, as you can see here, very, very busy slide, but it includes most of the initiatives and practices utilized throughout the 3 years journey. And they are all aligned to the 5 strategies identified in literature, which are the developing leadership, the data system. We created all these performance scorecards, zero harm scorecards, safety and reliability measures. We worked on automation, on creating the best technology-based change ideas for falls, for VTE, focusing on strategy level and creating, as I mentioned, safety as a core value. Following the diagnostic score and applying all these best practices, the reliability governance index was increased to 55%, as you can see here from the baseline. Reflecting this in other parameters, as you can see here, the serious safety event rate has been dropped by 70% post-implementation. You can compare this with literature. Like at 1 year, they dropped 68%, at 3 years, they dropped 70%, and at 5 years, they dropped 40%. So what we can see from this slide is that improvement comes with time. So even among literature, it requires some time to reach the state of high reliability organization. It cannot happen between 1 or 2 months. So it requires time where you make the change, sustain the change, keep monitoring, keep measuring until you reach your final goal. How is this affecting the reporting? So as you can see here, 57% increase compared to the baseline. Our safety event reporting increased, which should indicate a culture of safety. So everybody is willing to speak up, everybody is willing to report. How is this reflected in a patient safety culture survey? As you can see from the previous surveys, there is an increase in 16.5% in Riyadh results for the overall percent of positive response, 11% in Jeddah, and 4.8% in Medina. As I mentioned earlier, many of these practices require to have a robust process improvement in place. And this is what...
Can you conclude your presentation? 1 second.
Yes, please. So as you can see here, the number of projects, the challenges, of course, it happened, half of the journey happened during COVID. So there were some constraints, there were difficulty adapting just culture, and there were some competition between different, priorities and projects, and require to sustain training through coaching and mentoring program. And at the end, from all what I presented, the experience aligned with literature, and as you can see, it shows successful implementation, even though these challenges are in place. Thank you so much. Any question?
Thank you, Mr. for this great
Thank you.
Speech. Now we will give you the first
And yes.
Okay, Mr. Robert. Yes, okay. All on time, so it's ماشي بالترتيب. سهل. It's okay. Thank you for your help.
Okay. Now our next speaker is Mr. Robert Drost from UAE. I'm passing him the stage to deliver the presentation on the effectiveness of peer support group in stroke rehabilitation. Mr. Robert, the stage is yours.
Good afternoon, colleagues. Thank you very much for the committee for giving me the opportunity to speak on such an important subject and a topic. It is really a privilege to be amongst colleagues and friends who work tirelessly in the healthcare industry to make sure that we provide the best possible care for our patients. So let me just briefly introduce myself. My name is Robert. I'm a physiotherapist by background. I studied in South Africa. I qualified there. However, I lived in the UK for a while, and I've been now in the UAE, living in Abu Dhabi for the last 8 years, working for Mana Healthcare. And I'm really passionate about stroke. So today's topic is really about the effectiveness of peer support group in stroke rehabilitation. So we've been talking about stress and resilience today, but I just would like you to consider, while I'm talking about a particular event in your life where you've had difficulties overcoming a particular situation. So I just would like you to consider that this afternoon, and also think about the strategies that you used in overcoming that. Did you consult healthcare professionals? Did you consult perhaps family, relatives, or certain people that were perhaps in a very similar situation to yourself? So I'll go through the objectives of my talks. So essentially, it is divided into 3 particular sections. Firstly, I'll be talking about stroke. So I'll be defining stroke, looking at some of the statistics, and then looking at peer support and how that fits into rehabilitation, as well as explaining some of the core principles with regards to peer support, and of course the benefits that peer support bring. And then finally, I'll conclude with the project that we conducted within our healthcare organization in Khalifa City in Abu Dhabi. Can you hear me okay? Okay, excellent. Thank you. So first of all, we know that the World Health Organization has defined stroke as a neurological deficit of sudden onset with focal dysfunction of a non-traumatic vascular origin lasting longer than 24 hours. So we know anything before 24 hours is really considered a transient ischemic attack. But we know that there's damage to parts of the brain, which is caused by an interruption of the blood supply. So the interruption might be as a result of perhaps ischemia, where there's blockage in the vessel, or maybe there is hemorrhage or bleeding to one of the arteries that's supplying the brain. And as a result, we are fully aware that the affected part of the brain, because of this ischemia or hemorrhage, no longer functions normally. So if we consider some of the facts, and these are quite frightening facts, I think. So if you think worldwide, approximately 12.2 million people per year suffer from stroke. So new strokes occur every year. And approximately 101 million people worldwide are living with the aftermath of stroke. And even more worrying is approximately 1 in 4 people may have a stroke in their lifetime. So if you consider around the room, perhaps 4 or 5 people here might have a stroke in their lifetime. And in 2019, approximately 63% of strokes occurred in people younger than the age of 70. So really, stroke cannot be considered a disease of the elderly any longer. It is happening in younger adults, as we've seen today. We also know that there is a total estimated worldwide cost of approximately 451 billion US dollars, and this was in 2017. So it costs the government and healthcare sector a huge amount of money looking after people who have suffered with stroke. And 89% of the global stroke deaths and disability combined reside in the low to middle income countries. And if we look closer to home here in the UAE, it's been reported approximately 10,000 to 12,000 strokes occur annually here at an average age of approximately 45 years of age. So that is 20 years under the normal, if you consider Europe or North America, 20 years younger at 45 years of age. Now, I'm sure many of you are very familiar with the international classification of functioning disability and health by the World Health Organization. And we were talking about frameworks, and really this is a framework for healthcare sector, for governments and for organizations to make sure that we provide a patient-centered approach when considering the burden of disease. So for this afternoon, we're looking at stroke being the health condition that impacts a person. So for example, somebody suffers a stroke, and we know for the body functions and structure on the left-hand side, it impacts the brain. So somebody who has a stroke will have difficulties, for example, will have hemiplegia or weakness, may have communication problems, may have swallowing problems, may have difficulties in moving, but also perhaps bowel and bladder issues as well. So really, those are the body structure functions that we consider. And then we know that it causes activity limitations, right? Because of the weakness, because of those issues, people have difficulty moving in the bed, they're unable to balance themselves, they're unable to walk or go to the toilet or brush their teeth or comb their hair. So they have various activity limitations. And there might be also issues with cognition, memory, following instructions and things like that. And if we move over to the right-hand side, but how does this impact a person, their normal role in society? For example, participating, right? Your normal role as maybe a worker, you're unable to go to work and earn income or provide for your family, or perhaps you cannot participate in your favorite leisure activity. You cannot go to the bowling alley, for example, or maybe you are a student and a scholar and you can no longer enter into full-time education, and stroke impacts a person on that. But of course, we know we need to take other factors into consideration, the environment and personal factors. So the personal factors are essentially things like age, sex, gender. Those are really genetic factors. But if we consider the environment, what environment a person lives in is very important for healthcare professionals to know and understand which they need to operate in. So we know that in order to undergo the rehabilitation process, you need a team of people, right? You need an interdisciplinary team. So we spoke a little bit about a multidisciplinary team earlier on. But yeah, we're really referring to an interdisciplinary team, which is a team of members of healthcare professionals that collaborate with each other. So we can start off, for example, from the doctor, you know, with regards to medication, ensuring that patients don't have a stroke again in the future. And they are there to really control those risk factors and prevent stroke from happening again. Of course, we have the wonderful nursing team, and this is why, you know, at the conference, the nursing team look after patients daily and tirelessly, and to ensure that they are kept safe from harm. We have the therapy team as well. So the physiotherapist ensuring that patient strength and balance and coordination and mobility activities they're working on that. Of course, our occupational therapists, for those who may not be familiar, work on activities of daily living, like washing and getting dressed, grooming tasks, but also are involved in cognition training, thinking about attention, awareness, concentration, those type of activities as well. Also involved in making splints, for example, people that may have spasticity issues, and also work on equipment. You know, if patients require equipment on discharge, they are very heavily involved in that. We've also got our wonderful neuropsychologist. So the neuropsychologist is there for thinking and for memory and for intelligence, but also how to address issues with mood after stroke, because mood can have a major impact on a person following a stroke. So at Amana Healthcare, we provide a number of scopes of services for our patients. So we've heard a term of the post-acute rehabilitation service. So these are patients that following a stroke, they undergo an intensive program of therapy input. So they receive approximately 3 hours of therapy a day. That occurs normally over a period of approximately maybe 30 days to 90 days. And at the end of that program, the aim is to discharge them back into their home environment. We also have a slow stream rehabilitation program, which assists patients who might take a little bit longer to recover from their stroke. So we're talking about maybe 6 months plus. And then we've also got our long-term care unit for patients who require more intensive nursing input. So maybe patients who have had to undergo tracheostomies, or patients who have got PEG tubes or indwelling catheters. So they require more intensive therapy input. And of course, the final scope of service that we do offer is home healthcare, where we provide a nursing team and a therapy team to help assist patients as they are discharged home. So we know the whole rehabilitation process, the purpose is really to restore and to adapt patients to the best possible outcome, right? So we are there to help facilitate healing of the impairments. We are there to try and relearn skills that may have been lost, and perhaps also teach new skills for patients, and also to help them adapt to their new way of living. So now I'm just switching over a little bit to think about peer support. Okay, so what is really peer support all about? So peer support, I like this definition from this author Repa, says it's simply as simple as offering and receiving help, which is based on a shared understanding where there's respect and mutual empowerment between people in a similar situation. And I'm sure we can all identify at some point in our lives, we've consulted with people who have been in a similar situation to ourselves. Now, one may consider that maybe it's a fairly recent form of healthcare, but in actual fact, it started way back even in the 18th century. And here's a picture of a hospital, which is a psychiatric hospital in France. It's called the Piquetier Hospital. And there was a governor called Jean-Baptiste who recognized the value of employing recovered patients as hospital staff. Because what he found is patients seem to be more gentle, more honest, more humane. And so therefore implemented this as a possibility of hiring former patients, which shifted the philosophy of care in the mental health industry. But of course, it surfaced again in approximately 1965, where there were efforts that lay counselors were trained with specific skills that were there to help mentally ill patients. But we know that it has evolved, correct? We know that peer support for people with similar life experiences. So for example, people who have struggled with alcohol and substance abuse attend peer support groups, or people who might be grieving or have lost loved ones, or perhaps even lost an infant or a child, has attended some support groups to help them in their situation. So if you consider some of the forms that peer support can undergo, firstly, we know it can be very informal, it can be very natural or recurring support. In our facility, some of the patients share rooms, and when they get admitted, they have conversations, right? They talk to one another, they discuss each other's experiences, and they problem solve with each other how to overcome, and they probably decide which doctor is the best doctor or which therapist is the best therapist, right? It's all informal, right? The other part of it could be peers participating in a consumer or a peer-run program. And this is the program that we implemented in our facility, which I'll discuss in a little bit more detail afterwards. And then thirdly, they can go as far as employing people with lived experiences on a volunteer basis in statutory services. So we know sometimes, for example, in North America or in the NHS in the UK and in Europe, there are services that help to employ people on a voluntary basis that come into the facility and discuss and relate with patients who are undergoing a similar particular circumstances. So if we look at some of the core principles that define the peer support. So first of all, we know that there must be mutual respect, right? The experiences among individuals is never identical, correct? Everybody goes under different experiences, but they do have some shared similar experiences. They have, for example, they have an understanding of stroke. They can relate to the confusion stroke has had on their lives. They can relate to the loneliness or the fear or the sense of hopelessness that stroke causes. So there's a sense of mutual respect among peers with regards to stroke. It can also be reciprocal, because we know the normal relationship, traditional relationship between a healthcare and a patient. There is an assumption that the healthcare is the expert and the patient is the non-expert. But in terms of peer support, there's no assumptions whatsoever. They're all on the same level. There's no such expertise between them. We know also that it can be non-directive. It can also be recovery focused. The purpose of the peer support is focused on relationships that inspire hope. A position where a person might say, I know you can do it. They inspire hope for individuals. They help generate personal belief. They help generate commitment and energy to continue with the program. In other words, people can take control. They can use the opportunities and the resources that are available. We also know they can be strength-based. Peer support involves relationships that involve strength. They're not afraid of being with someone in distress because they too were in distress at some stage. It explores what a person has gained from that particular experience, what achievements that they've achieved during that time, even celebrating the very small steps that someone has achieved. Of course, peer support is about being inclusive. Inclusive because there is the stigmatization that someone is different, but it's important that for a peer support system is inclusive for people. It is progressive. We know peer support is not about having static friendship, but it's essentially being like a traveling companion with travelers learning new skills, right? Developing new resources and reframing challenges or opportunities to find new solutions. So it's about being progressive. And finally, it's about being safe. It's important that peers feel safe with each other because it's important that people engage in a manner that is non-judgmental. It is important that there's confidentiality amongst the peers. And this is one of the things that we really reiterated amongst our peer support groups, that the information shared was confidential. And of course, we wanted the relationships formed to be authentic relationships. And this was vital. So if we look according to the research as well, some of the benefits regarding peer support, we know that it can help improve self-esteem and confidence. It can help improve problem solving, increase a sense of empowerment, increase the access to work and education, and also improve relationships in a social setting, which is important. Greater feelings of being understood, as well as reduced of self-stigmatization as well. A greater sense of hopefulness for the future, and also a positive feelings about the future. So research has got a lot to say about peer support. So now, in concluding my talk, I will just run through the project that we developed in our healthcare setting. So just to give you some background information, we work in Khalifa City in Abu Dhabi. We are on a compound, which we have a number of villas, approximately 38 villas, which is like a dwelling or a house. And there's approximately 4 to 5 patients per villa. And we are on a post-acute rehabilitation side. So patients that enter the acute setting, they get their diagnosis, they undergo through all the diagnostic tools and they're diagnosed with stroke. And then we try to receive them as early as possible in the system. So we have a team of members, we assess the patient, we determine what issues and problems that they have. And as an interdisciplinary team, we sit together and we come up with a strategy and a plan of care for the patients that is tailor-made to that particular patient. And of course, we also have family meetings as well, where we sit down with the families and explain the route forward. But as we discussed with the families, we noticed that there was a clear lack of knowledge about their condition. Perhaps it might have been the fact that they weren't receptive enough in the early stages. Maybe they were in shock as a result of their stroke. So we decided to implement this program to help improve their knowledge and empower them with knowledge, but also provide an opportunity for them to discuss the issues amongst themselves. So we determined a team of healthcare professionals. So it was the doctors, the physios, the OTs, the nursing staff, and various other members of the team. We proposed a curriculum and set a schedule around this. And then we conducted the sessions. So the sessions was conducted over a 10-week period. So I'll give you the sort of generalized program that we did. It was done over a 10-week period. Each session was approximately an hour. So the first part of the session was taken up by a small talk, informal talk of about 20 minutes or so to provide information to our participants. And then we then gave an opportunity for them to discuss any issues or any questions that they had about their condition. So you can see from the schedule there, the types of topics we discussed. We spoke about the medical condition of stroke, explained the diagnosis and what it meant. We explained the rehabilitation process after stroke. We looked at all their, for example, physiotherapy, the role of physiotherapy, as well as occupational therapy. The speech therapist gave us a great talk about communication and swallowing. And then stroke prevention from the nursing team was a very important topic, because you could sense the anxiety and the fear amongst the participants that a stroke could happen again. They never wanted to go through that process as well. And there was a sense that they wanted to empower their own family members and their friends and their colleagues how to avoid a stroke, because we know stroke is one of those preventable diseases. So there was a sense of that urgency that they wanted to know that information. And we had our neuropsychologists also talk to them about mood after stroke, as well as burnout, caregiver burnout. So that was also a very important topic. And then finally, we ended up with the discharge process so that people will have more information about what to expect when they undergo the discharge. So we recorded the session. We said it was like a meeting minutes. We had approximately 15 to 20 participants at each session, which was great. So over the 10-week period, initially it was very quiet. Not many questions were being asked, but as the process evolved, they really got into it. The patients started engaging, they asked questions, and then they started discussing each other's lives, which was fantastic to see. The type of participants that we had a number of expats that were involved in our groups. So people from India and Pakistan and various African countries, from the Philippines, as well as one local Emirati person that was involved in the group. And it was male and females, so there was no distinction. And the average age was approximately 50 years of age amongst all the participants. So it kind of fits in that range that we're talking about with regards. Sorry, I think we've lost that. Anyhow, it fits in that range where I said the statistics of strokes here in the UAE. And then following the sessions, we conducted a satisfaction survey for the patient. So unfortunately, you cannot see it on your screen at the moment. But the satisfaction survey, we asked questions about how valuable did they find the program. And we also asked them to give us some input and guidance on some of the topics that they wanted to learn about and what they wanted to achieve during their time period there. So we had a few comments. Sorry, the screen has disappeared, but let me just briefly read some of the comments that they said. They wanted to know more about anger management in stroke, how to deal with that. Especially they wanted to know how to avoid stroke in the future. And they also wanted to know about the foods. They wanted to know about the foods that one can eat after a stroke. And this was an important topic, which was done by the dietitian, the types of foods, what a healthy diet was all about. So in conclusion, our project really demonstrated that peer support in stroke rehabilitation is an effective method for patients who have undergone a stroke. And our plan is to try and implement this in a wider community setting. So hopefully we will be able to take it to the home healthcare setting so as to spread the news about stroke rehabilitation. Thank you so much for listening to my talk today. I'm happy to answer any questions. Oh, great.
Thank you very much, Mr. Robert, for this amazing presentation. Is there any question for Mr. Robert?
Okay. All good.
No?
Super. Thank you so much.
We have yeah. Thank you very much for your presentation. I'll be having a talk about rehabilitation tomorrow. And we'll be having a talk about this implementation of this peer method in our hospital. So I'll be giving a speech about it.
Really? How come you have the next two space? So they should continue with that. Everything is okay. I don't know what is the problem.
So I'm saying to you, 200 or something. Well, I don't know what sometimes, right? I'm saying something, if you taking what you think you. What were you talking about? I'm not happy. So you already done? No, you put that, yes, it's good. I have a good faith. Smile. Smile. I didn't see you. Everybody up. Oh my gosh, what's the joke? I want to jump forward, like, how you doing? So that happens. I'm feeling paid for this. I'll do that.
Change the project. The other one is working, but I don't know what's the problem with this. Maybe there's two.
This is a good time to encourage. I don't want to miss. Thank you. Let's start with that. You want to drink? Come on. That's not what I'll say. I'm very good jumpers, right? I'm very good jumpers. Yeah, good. There you go.
Good afternoon, everyone.
Only have process. They have suggested the. You can see the presentation. See the presentation. Well. So how do you start to this? Now you can have a way. Presentation. مش شايفين بالي هو شايف لا لا انا مش شايف Okay, Mr. Martin, can you please introduce yourself while we have fixed the director one? Yes. But let me.
Good afternoon, everyone. Whilst we're waiting for the projector to be fixed, let me introduce myself. My name is Martin. I'm a Spaniard. I'm a nurse by background. I have worked in Spain, in the UK, in Saudi, and now in the UAE. I'm currently a Quality and Patient Safety Officer at Amana Healthcare, and I'll be guiding you through our project that we call Reduction of Unplanned Transfers to the Acute Care from a Long-Term Care Facility. Yes. We're still waiting.
Can see.
Yeah.
I think this is a good idea. I should there. Okay, let's go down then. It's okay. Yeah, sure. Maybe we can move to final. Okay.
Visually?
Yes.
I can put it there and there.
I'm thinking, let's bring that, we'll actually bring it in. When it's moved, it's always way to that.
Could you introduce yourself again?
Hello?
Problem solver. Is he innovative?
Is it working there? Great.
I like they think they do. I think so. But I think it's great that they are nominating weatherproof. Yes, that's been proof too.
Still here.
She's right. Barbara, you are a wise person. That is very true. Where's mom? Let's see. Oh, no. Is it up there? Yes. Is it gonna be okay for? Yes. No, that.
Let's work on the lens down today. She has a session.
Excellent. See, what did I tell you? Yeah.
Okay.
I can sit there.
And spread the word. It's straight up, can't agree. I will find out. Because it's the him on the nose. It's. Yes. I don't know how you feel. People keep quiet. Storage. Terrible. Figure the big point. Yeah, that's fine. That's fine. What's it called? Still got access to the different group. We should really mention.
Just yourself, just a month. Okay, from which city in Spain you are? From which city in Spain you are?
I'm from the northwest, so you probably don't know.
Actually, no, I have collaborated in a project in Palestine, coordinated a project with the University of Caen for 18 months. That's why I'm asking for this background. Yes.
I'll be brief, but no worries. Time.
Maybe.
So let's want to view.
We can see it, yes.
Yeah, but like this, they will see in the notes, right?
Oh, okay.
Yeah, I'll speak to Dan at least once a month. I speak to him.
We can minimize the notes.
He's all over, sure.
Oh, it's okay. No problem. Even if it's apparent.
There's no way to show only.
I think we have to minimize, but no way to minimize it. It was working.
Get the conversation. We'll talk about spiritual guidance.
For 1 second, it was working.
Frank, sometimes
I will introduce him and he will subject.
Give me 1 second. Usually then you will start. Okay. Actually, I will have to say we are sorry for this delaying. It's out of our control. Let's welcome next speaker, poster presentation, Mr. Martin Farina from UAE. I'm passing him the stage to deliver the speech on reduction of unplanned transfer to acute care from a long-term care facility, a quality improvement project. Mr. Martin, the stage is yours.
Go, Martin.
Good afternoon, everyone. Everything is somehow visible, though with my presenter notes as well. Well, I'll introduce myself. My name is Martin. I'm a nurse by background. I'm a Spaniard. I have experience in Spain, UK, Saudi, and now I work in the UAE. I work as a quality and patient safety officer for Amana, same as Rob. So I'll be presenting our project, which is called Reduction of Unplanned Transfer to Acute Care from a Long-Term Care Facility. So first of all, let me introduce who Amana is and what we do. We are a Mubadala health partner, and we are specialized in long-term care, rehabilitation, and home healthcare services, as Rob mentioned before. And we aim for an integrated continuum of care services. So our facility where this project was developed is called Amana Healthcare Village, and is a specialized residential facility located in Abu Dhabi. Has a capacity of 175 beds, and it offers a 24/7 nursing care for elderly in a home-like setting. The facility, as Rob mentioned before, provides an interdisciplinary care, which includes medical, nursing, therapy, and so on. Well, the project was born after reviewing that we were having a problem with unplanned transfers, and I'm not sure if you guys are aware of how long-term care settings quality of care is measured, but just so you know, unplanned admissions to acute care from long-term care facilities is being a debate from long and is worldwide discussed that it relates to the quality of care provided on those. It poses a pressure on both the long-term care and the acute healthcare settings and increases the cost of healthcare per capita. Providers and users and policymakers estimate that a significant portion of those can be prevented, and as well, in order to tackle the issue, multiple retrospective analyses have been conducted to analyze the causal factors. As I said, following and based on the previous, we conducted a literature review on the preventability of those issues, and we found that Auslander and colleagues in a retrospective review, after analyzing 200 hospitalizations from nursing homes, found out that 67 of them could have been prevented. Sorry about that. And then McAndrew also conducted a retrospective analysis on almost 500,000 nursing home residents that have been transferred to acute care, and after staying a minimum of 120 days in a nursing home, and finding that at least 20% of them could have been prevented. We also review an article from Ashton and colleagues from 1997, who reported that 9 to 48 of them could be prevented, which aligns with also what Bembasat and Tarajin reported in 2000. We also conducted a literature review on the interventions, and Ashton et al. Concluded that 55% of the transfers could have been prevented if the quality of care given was better. However, this statement for us didn't add any value, so we started digging deeper in other articles. We found, for instance, that Wolfsmater et al., focusing on appropriate care plan for chronic conditions and unspecialized nursing skill set, were able to reduce the unplanned transfer to acute care. And same with Bembasat and Tarajin, that concentrated on patients with defined disorders rather than just trying to lower the unplanned transfer. Lab and colleagues implemented a clinical pathway for pneumonia, and they found out that they were able to reduce at 12% hospitalizations. As I said, the situation is a global issue, and the Abu Dhabi Department of Health has established a YADA KPI that measures the quality of care provided in the long-term care facilities as unplanned transfer. And in Amana, we adopted a benchmark of 5 per thousand, 5 hospital admissions per 1,000 resident days, which we took from the University of Pittsburgh. And during last year, in 2022, we were averaging 6.3 unplanned transfer per 1,000 resident days. Therefore, we had an issue that we needed to tackle. So we conducted an analysis that was based basically on age, gender, diagnosis or reason for transfer, date of last admission or readmission to Amana Village, length of stay in Amana Village since last admission, and length of stay in acute care. We came up with some metrics, and during the period that we analyzed, we found out that 43 patients, supposed 52 transferred to acute care, where the average of those patients, average age of those patients was 61 years old. And we found that since admission or readmission, those patients had to stay with us 129 days. However, we found out also that the standard deviation was quite high, 176. Therefore, we established that we needed to dig deeper in the data and found out what was actually happening. The days in acute care were 8.48, which served us to conduct a cost-benefit analysis if we were able to reduce the transfers. As I said, due to the high standard deviation, we did a bit deeper and we started analyzing what were the reasons for transfer. The main one was respiratory distress, followed by COVID, and then some others like sepsis. We focused on the main one, which was respiratory distress, and we started digging deeper into the data, and we found out that some of the patients were actually recurrent being transferred to acute care, and most of them have a past medical history related to acute respiratory distress. For instance, some of the patients that we are admitting in Havana Village are in the last period of after being weaned from the ventilator, and those patients that have been on ventilator for years after ICU encounters, and we managed to decannulate, weaning them off in the CCID weaning unit. We then admit them in Amana Village, and there they proceed to the decannulation program. However, some of those patients unfortunately were bounced back to acute care. Because of that, we ran a linear regression, and we found out that it was statistically significant patients that were having this past medical history and patients that were transferred before to the acute care due to adult respiratory distress were again more prone to have another encounter. And then we conducted as well case reviews individually with the interdisciplinary team, as well as we were taking in consideration the family inputs into that. Then, as I said, we conducted a cost-benefit analysis in preparation for potential interventions. As we all know, when we come into management to try to convince them, like, what can we do? And if we need some, say, economical support, we always need to show them, like, if it's feasible or not. So based on our literature review, as you guys can remember, mostly the preventable transfer were ranging from 10 to 50% roughly. So we presented 10%, 30%, and 50% potential reduction of unplanned transfer, which obviously will have an impact to our organization. And based on that, we presented to management what could be done. Then our interventions, after digging deep into the literature again, we realized that perhaps we needed to do a more thorough pre-admission assessment in the acute care, which involved the lead physician, the therapist, the DCO, and also case management. We also cohorted patients as per their comorbidities and chronic conditions in a way to also train our nurse and upskill their yeah, I'll just blank out. Basically their skills. And then we developed clinical guidelines for chronic respiratory failure management, and we introduced a respiratory therapist in-house. The respiratory therapist, after he embarked, he started developing individual plan of care for those patients, and he also trained the nurses into doing deep suctioning and using the assisted cough device. And as I said before, we started some of those patients in the decannulation program, for which the respiratory therapists developed some clinical guidelines. The result of our intervention of our project was quite surprising, actually, because we saw the results like right after, and we managed to decrease by 60% our average unplanned transfer to acute care by the end of the year. So again, as I said, the unplanned transfer to acute care from a long-term care facility are a worldwide issue, and there has been a difficulty on deeming whether they are preventable and which ones are preventable or not. We were able to come up with interventions that were free of cost based on specialized care for chronic conditions, and the results were astonishing for all of us. And that's about it. Those are my references, and thank you for having me. If you have any questions, please.
Thank you, Mr. Martin, for this great, amazing explanation for your speech. If there is any question, just raise your hand. Actually, there is one question. Thank you so much for your presentation. Having worked as a hospital discharge planner, I identified certain disease processes that sent patients back to the hospital. Did I hear correctly that pneumonia was your primary reason for readmission, or were you able to categorize your?
So we based our reason for transfer on the ICD-10 codes. And the main one for us was adult respiratory distress. However, you are right, I mentioned pneumonia. I think it was Loeb and colleagues that came up with a program that managed to reduce 12%. I can share with you the reference afterwards. Thank you.
You're taking lots of that house. That was good. It will happen.
So our next and last speaker for today is Ms. Hanouf Sumbul from KSA. I'm passing her the stage to deliver the presentation on the effectiveness of peer support group in stroke rehabilitation. Ms. Hanouf, the stage is yours.
بس هنوف لازم نكون قريبين من هنا. طيب قبل ممكن ما نبدأ بس قبل ما stop, don't take photo because I think all of you are pleading. So before he will take photo for me and for us to give me only 1 minute to stand up and to extend your body. And before we will keep talking and talking, and I know all of us really, but just take a deep breath. Our topic, inshallah, will be really, really enjoyable, inshallah. And we will discuss more than I will give you. You will experience more than me. And I'm gonna get from you more than I will give you. So just take a deep breath. If anybody wants to bring anything, go to bring and come back. You are most welcome. My lecture. The happening is here. Thank you. طيب بسم الله. Our topic, inshallah, today is about encouragement strategies for mandatory continuous professional development in a nursing field. This is a brief about me. Me is Hanouf Sumbul. I graduated from Al-Qura University and I completed my master in Noura University, Advanced Nursing Practitioner, with the collaboration of DCU University. Actually, my background is a nursing. I work in a critical area in ICU and BICU, also Pedia ER. And I work in the nursing office in Maternity and Children Hospital as a nursing educator and quality. And finally, after my master, they hired me to work in the executive nursing office in Makkah Health Cluster Cities.
So now I'm working as a project manager in BHM in Makkah Healthcare Cluster. So let's start. Today, inshallah, we will define the meaning or the definition of mandatory continuous professional development. We will determine together the most common factor contributing in low attendance rate of mandatory continuous professional development in nursing, also the barriers contributing for a low attendance rate, and at the end we will discuss the most effective strategies can encourage the nursing to attend the mandatory continuous professional development. So if we will discuss in a general, what is the definition of continuous professional development? If we want to give a definition for continuous professional development, what is that? Yeah.
You need to learn certain skills. So wherever you're getting your career, you need to continue learning.
Excellent.
Those skills.
Excellent. Who else? Is there any evidence-based practice? Excellent. So if we are saying mandatory continuous professional development, it means it's a really critical process for the career development. It's not by choice, like you want or you don't want. You're gonna stay in the department and you don't want this mean you don't want. No, it's a mandatory. But how we gonna make it mandatory? Lastly, for our staff nurses to attend. The idea came when I was as a staff as a nursing educator. I was handling the media side as a nursing quality of education, and I found that the low attendance rate of nurses when we are conducting in mandatory CBDs. I will enter like this in the room, and they will keep calling the head nurses. Where is your staff? 10 minutes, 15 minutes, 30 minutes, 1 hour. Still the staff did not come. What is the problem? I was like 3 months, but this way. There is no one coming. When I go back, I asked them to change my office from the nursing office. I don't want to stay with the leaders. Leaders are leaders. They can go to anywhere to take the lecture. But those nurses, the responsibility of whom? If I'm an educator and I'm sitting down, and there is no one looking at them for inside education or inside learning, if there is no inside learning. So I told them to transfer me up near to the most critical area I handled, and that was in IPO. And I start working, observing the nurses, what they are doing. Actually, I've already have background and I work in the area, but I become close to them. I know what is the barrier. I know what is the factors. I want to learn to hear from them. Maybe they are different than me when I was working in the same department. So I want to listen from them. Then I start going inside meditation time. It's around 8, 12, like this, 8 in the morning, 12 in the PM. So I'm going to them in the meditation area, in meditation room, just to observe. Just keep observing what they are doing without asking or making them interrupted, like they will scare from me, and I was really friendly to them, like giving salam, how are you, or like friendly environment. They become comfortable. All nurses that are coming just in me. Actually, they don't know how to calculate this activity. Oh my God, I'm working in myself. How many years you are working in this department and you don't know how to calculate for example, for today? Did you see? Your observation is different than anybody. When you are sitting inside the office, you will not get anything. You will only do a plan in the paper. But on the actual side, it's not effective even if you're implementing. So we're gonna talk from this idea. After I studied my advanced nursing practitioner, they give me 2 choices: neither to start research study or quality improvement project. And when I talked with my supervisor in the capstone, she told me it's better to do it as a quality improvement project. And our cohort was 32, and I'm the only student
I did work improvement project. I was lonely. Everybody looking at me say, I need help. They're saying, you choice by yourself, BDCA, go alone. All of them, they know that they are supporting each other. And for me, even there is not that much reference for the BDCA actually. You cannot find a lot of reference. Anyhow, we will go through the lecture. Introduction, I give you some of the introduction, but we have to know that the education in nursing, that is fundamental and primary. Since 20th century, it's not something new. And by teaching our nurses, we will develop the healthcare system. And we have to care about this. Okay, we will talk about the factors. The first factors we will talk is inadequate professional proficiency. What does it mean? When we are saying inadequate professional proficiency, what does it mean? Now we are asking the staff nurses who is in the department be professional. To be professional. We are just saying work. Just be professional. But how? She doesn't know. If anybody comes to ask her, yeah, I have to be professional. But how to be professional? I don't know. They told me, be professional. So be professional is mean like you have to respect the rule and regulation of the institution you are working in. And you have to be aware about it. Not only respecting, you have to be aware about the policy and procedure, the guidelines they are following in such department, for example. Also, a significant gap between theory and practice. Sometimes there is an educator, they are sitting inside their office, and they are planning, I will give this week, I will give our staff nurses about, for example, a research of daily intake. She will give it to the staff nurses who is working in the media medical. Why she will give it to them? She just want to give. But actually, the background of the staff who is working in the medical, rarely, if they will put urine catheter. So there is a gap between the lecture and between the practice. You have to be selective if this department needs to give urine catheter or not. Really, we have to be selective about those kinds of topics. So we will go to the other. Work overload. I think all of us knows about this. Always work overload and the lots of patients making the stuff even doesn't want to hear from you. Sometimes in the clinical side, I'm doing ground and they can't see how she is putting the cannula. I want serious beside me. I want to teach her to come and to tell her how. Like this. But it's not a way. In that time, the educator herself needs to wear the gloves and to stand up beside the staff nurse. It's not the time to teach her. It's not the time to keep saying she is busy now. You just wear the glove, and stand up beside her, and tell her, offer your hand. Come, I will. After you will finish this, take care of one side. I'll keep talking. By the way, you have malpractice for this and this and this. The behavior is really considered. Not all the nursing educators are doing like this. They are going, once she will see malpractice, she will keep shouting, thinking angry. So it's not a behavior, it's not a professional behavior from the educator. Also lack of organizational support. And this is, I think, almost all of us suffering from this problem, especially if it's funded. And regardless funded or not, sometimes even the organization, they are not supporting like you will use the main auditorium for giving such a lecture. Not even letting the kitchen to prepare for you snacks and some hot water and a tea bag to open mandatory CBD lecture. So some organizations really, they are not supportive. I'm talking to you because I know
all those things because I work as a staff nurse from the beginning, and they touch the smallest things, especially in the critical area. And when I hire to the educator, I know what is the gap, but I cannot bring the changes directly because the leaders, they're gonna hate me. They're gonna say, you see, go out from this room and you back again as a staff nurse. So we have also to be very careful about what we are doing. We cannot come to them and saying, whatever you was doing in the past, that is wrong. And at the same time, you have to change. So it's really like, I don't know how to say, but now the matter become much more better. Some of the challenges also we will talk about. Here I would like to focus on the educator itself. Some of the educators, they really have poor communication skills. Yeah, sure, the staff will not attend. She will attend. You are opening the ceremony and saying, sorry, opening the main auditorium and saying, why didn't we are already in the material. We don't have the skill to let the staff to come and listen. Simply, okay? Poor teaching skills as well. Maybe the PowerPoint is really bad. The way you are receiving them is like you are a teacher and they are students. No, we are not in a school. They are old enough, mature enough to take a decision, engage in a teaching. Not like you will come like we are in a school, just do this and do that. That's not like this. Lack of proficiency and stuff. Same whatever we talked about before. Also, inability to improve staff moral, lack of efficiency teaching strategy. Some of them really, they don't know the strategies of teaching. Really, the educator themselves, sorry to say, but I was as an educator and they don't know what does it mean teaching strategies. Before going to teach the nurses, you have to improve and see yourself first. Then after you will be completed from all the side, blame the nurses why you are not attending. Let's be really frankly, now we are talking in a higher level. It's not like in one hospital. Ineffective teaching method, as we mentioned, lack of respect from other healthcare providers. Sometimes the healthcare provider themselves, they are not respecting each other, like physician not respecting nursing. And for example, the nursing educator herself not respecting the nurses. The nursing director in the hospital not respecting her nurses. And she is requiring from them attend the mandatory continuous professional development. How? We are a human being, but at the end, we are a human being. We are feeling, we are listening, we could be affected with any minor things can happen in our work. So you have to respect them. You have to listen to them. Listen what is their need for learning. So after that, you can do the plan, and which we will talk about later. Fear of educators' behaviors. Some educators, they are like this. As I told you, as I mentioned before, they are really tough, rude. If the staff nurse will do any mistake, she will really get anger. Like she doesn't have patience to keep learning, teaching them. They will do the mistake, and again she will give them another chance. Mistake and another chance. By this way, they will learn. Okay, here we will mention our strategies for encouragement. The primary strategies which we have concentrated is motivation. In the motivation is orientation program. Always when you will start with what does it mean, CPD? Why we have to learn? Talk with us. Talking there. Otherwise, we are not giving them orientation program, and we are just starting. Take a lecture. We will give you topic number 1, number 3, number 4. So they are not understanding is why we have to learn. So the orientation program is very important. As we said, conduct orientation program from the beginning. Primary motivation for nurses attended mandatory CPD are desire to increase their knowledge and improve their clinical professional skills. And how it will come if you did not give them orientation program? It's not coming. Because not all the nurses like us, we all came here to learn from each other, right? Because we are a little bit free. Some of us are working as a leader, some of us are still studying, but for the nurses, she is already busy handling 7 and 8 patients. From where she will bring the desire to improve herself or her knowledge. So active organization rule, and there is some organization, they are really pushing the staff nurses to learn. And this is very important. Also involving the staff nurses in planning and preparation implementation. This is very important when we are planning, and this is what I was doing when I'm planning for lecture or session for CPD with the nurses. I'm going to them from the beginning of the year. For example, 2023, I will send them survey, learning assessment need. They will rank all their priority. According to that, I will develop my action plan for 2023. Otherwise, how I will develop? Just by myself. I will sit in the office and I will do it by myself. I think the nurses upstairs, they need this and this and this without any data in my hand. And there is something here. I really like it. Without data, you are just another person with the opinion. Really, without data, we are just consuming. They need, as I told you, IT cannulation, for example, procedure awareness about IT cannulation. We are assuming, we are thinking only, but we did not get evidence in our hand, saying at the end with the director, she coming asking me, why you give this the first priority campaign to her? Look, I have, for example, 100 nurses in the hospital, they don't know about IT cannulation. So data is very important. And this is what we are doing now in KSA is about data. Even the CEO now working in the healthcare cluster, he will not take any decision unless there will be a data. The decision will be based on a data, not on a mind or on your opinion. Reduce fear of the nursing educator. As we said, how to reduce the fear, use simulation and provide feedback. This is very important. Some of the educators I saw who was with me, they really doesn't want to take even feedback from them, saying, who are they to take feedback from them? I'm higher position than them. Why am I gonna take feedback from them? This relationship is gonna not bring any benefit in the actual side. But listen from them. After you will give a lecture, listen from them. It was okay. Did you understand something? Or you did not understand anything? Is it the way of teaching suitable for you or not? Lead them to be engaged. You know, we have like patient-centered and patient-engaged in the treatment plan. This is what we have to do with our nurses when we are developing a plan for education to them. So by this way, we will reduce the fear of nursing educators. Qualified and professional nursing educators. This is also something very important, that they have to improve themselves in the education. There is something, do you know about it, that education or learning by game? Did you hear about this before? Like you will learn, you will teach the stuff by learning, by playing, by game. Not like I will stand up here like I'm a teacher and they are my students and they will keep saying, full stop, I finished, thank you, you can go out. No. There is really game nowadays. I talk also about this. They're gonna be in the same whatever we are now. and you're gonna play with them in the same table, and you're gonna put objectives for the girl. For example, understanding the IC calculation process or implementation. And you're gonna put the goal here, and you will play the process, you will play it. You will not give it verbally. By this way, they will listen to you, they will feel the interaction will be more than when you are standing and just give it yourself. Also paying attention to clinical behavior. Sometimes there is a stuff, and this is what I noticed, there is a stuff really, they reach to the burnout, and they really doesn't want to hear anything from anybody in the institution. So those stuff, do not face them with the anger. Face them with what happened to you. Ask them, are you feeling okay in your duty? What is making you not to attend? Listen from her. So this is what we mean by clinical behavior from the staff nurses. And last is e-learning. And the e-learning is something very important to keep looking about, because e-learning is flexible. Anytime the staff nurses can see, anytime. She can enter, for example, to see the video, and we can put for her pre and post exam, and we can see if she really got the benefit or not. It's a very flexible process. E-learning, I found in that time when I wanted to develop, in 2021, I want to develop my master dissertation, I found a lot of reference talking about the e-learning and how it's effective in a nursing education. And I want to say thank you. I really enjoyed it. And if you have any question, my BBCA, see how I developed the BBCA. Actually, when I was working in the hospital, they were saying to me, you can do quality improvement project. Okay, maybe that's everybody is doing it by personal, personal knowledge. Come here, we will do. Where is the reference? I want evidence-based reference saying to me, this is the BPPF. And this is one reason that leads me to join the BPPF, and I want to study for my master dissertation. I want to take the reference in my hand. And when I back again to my country, to my place, I separate this reference to all the nurses in all the hospitals. This is the reference for BPPA. Go and read. By this way, you will increase their knowledge. You will make them much more stronger. And that's it. I hope you enjoy them.
Thank you very much, my lovely Hannah, for your great explanation for your speech. If there is any question, just raise your hand. Okay, we have one question.
Thank you for the informative presentation.
Welcome.
You said something about data. The problem, you can't here even collect data from nurses. I mean by that they are very, very busy. So how can we gather them together to provide them training and education programs? We have Dr. Barbara, right? Yeah, the American, right? As long as I know, in the States, they have one mandatory hour per week for nurses or any profession in the hospital to gather like 25% of the staff every week.
Yeah.
Okay, so why we don't adopt the same idea and implement it here in the GCC, right? Okay, that's all. Thank you.
Maybe now, before I have time, and we will take health need assessment survey or healthcare provider assessment survey, which requires from the nurse. Okay, so
As you said, it's very difficult to take from the data, and it will be correct data, which they not they will enter because they want to finish and that's it. First of all, I think you have, because really, I was a doctor, and I was working in a clinical area, and really, I know what does it mean with the when I'm busy holding patient and giving isotropes and I'm busy with doing CPR and something you take, she's holding the paper like this and she's passing by me. Where are your gloves? Do like this, okay, come help me. This is not the time to teach me. So I think when you want to do data or collect data, you have to go accordingly. I went to each hospital, each department, I went by myself. I collect the message who's free and who was in a lunch break. Lead them to be in a lunch break. Do not force them to come. Whoever free, bring them to me. Whoever eating, let them to eat. Because they have patience. They are not free for me only. So we collect them and we explain to them. And we bring a barcode. I bring barcode and I give it to them. And they explain to the small group. And they asked, and the head nurse was there. I asked the head nurse to extend the message to all the other staff of the home. And they have the home. By this way, I can pay like our nurses in my city is around 4,400 sports. I get almost by this way, I got almost 2,300, something like this. But you have to do effort. Do not come with the barcode, like I read the barcode from my office and going to the hospital. Where is everything you get read coming to me? Please contribute to all the part. Who gonna do?
Yeah, but you're working with the organization.
Yeah.
Some people, I remember when I picked the data for my last PhD thesis, I gave them candies. So I can't say I did. Because I'm not in the organization.
Now I think so. About this one.
Yeah, but it's not the problem now, the data collection. The problem, how can we enforce them to as I'm sorry for interruption, as a connecting with it. In the states, they have one of the policies. I think it's in the GCI, I'm not sure, but it's almost in all the standards of the states. Any healthcare worker has to attend program or educational program for 1 hour per month. It's mandatory.
I think it is based more on speed.
Sorry. Okay.
Yeah, I think it's based on each state's criteria. In New Mexico, nurses are required to have 30 hours of continuing education every 2 years. Most of the nurses I know wait until the last 2 months before their license expires. They go online, they complete all the shit, but they don't learn. It's just one of the things I do no, you have lots of nurses who can help.
That's true. That's true. I feel better already. That's right. That's what I was.
One of the things I like to do to help draw people in, you mentioned bringing, getting candy, Starbucks coffee, donuts.
like at the end أقول لك على اليوم في النهاية مين اللي أنا أستفيد من ده and I'm the one I will get the benefits support the data they use the tool so again this is for me personally I will get the data analyze it and remove the action for the nurses they will never think if they are self-nurse they will never think about action plan I thought you are doing that, and you want to develop, and I'm thinking.
Publish the paper and like recommendations.
I agree. There is a lot of I think that will not get provider. But if we think by their abilities, how they are going to do their work, the least we gonna put on lot of it, and you gonna counsel them by their way. Because when I was at the top nurses, seriously, we don't have time. And instead of handling a policy saying of maximum 4 patients, the policy of the hospital saying 4 patients, and the head nurse is giving her 7 patients. If there is someone from outside will come and tell me, take and put that, should not. Like definitely, I'm saying you because now I was a staff, and now I'm at different level. But I know from the beginning how they are doing it. It's very difficult. So try to come to me by different ways. And it's a good idea. Starbucks and donuts, it's a good idea.
Yeah, I remember when I was working in the clinic, you say to us like I think so fluctuate with healthcare. That response. $25 Amazon gift. They can go online. Well, and then by the end they will get funded from the other patient. So they involve
it's more. It's one with the nurse?
Yes, it is.
Each time.
I think one of the most important points is to make them love what they are doing. And they have to be kept motivated.
Yeah.
Another point, what about discovering the staff, their colleague with the potential for teaching, and let them teach each other.
Yeah, you are right.
Yes.
This is what I was saying to you about when they will go to the course and to take course, I don't want the certification only. Yeah. I need feedback for your colleague in the department. Yeah. By this way, I gonna make sure that you already get the benefit of the lecture and you already reach to the objective of the lecture and explain to each other the interaction between the group. It's gonna be really different. In the environment of the hospital, clinical environment, there are relations between the clinical environment.
In our trust, we have cascade assessments. So it's basically a member of their team, each individual, will assess them whenever they need assessing.
Yeah.
We also try and make them feel valued when we get feedback from them. And we do course evaluation, trainer evaluation. And it's very important to do it that way as well. Because I think it's important because they feel valued and they feel like they're in charge, they're learning as well.
I mean, to be honest, I agree with what he said. I would like really to thank Ms. Amal. Yesterday, she really did just to mention, like to take a small example, what she did in our work. Yesterday, I was really when I reached here. I am the one I select the topic. I'm the one I want to come here, right? There is no one pushed. No one pushed me from my administration or institution or anywhere. They reached here and they came around 10 o'clock. When she received me, she was asking me, when you are coming, just get me your citation that you reach. When she received me and she smiled and she was talking to me and she take me to my room, you cannot imagine how much with a difference and imagination of the positivity photo. By this way, let's take her as like a small point, a small thing can lead the people to think broadly.
Yes.
By this way, she's gonna make me every time to think when I want to go to the international conference. After I will come, I will reach to the city, through the airport and down there. They will receive me the way she receives it from me. You see, the certain things. This is what we are doing with ours. Now what is it? I can't I'm giving you my idea. This is just one paper. More little tips, more